Hello, everyone. Warm welcome to everybody on a Saturday afternoon. And let me first thank you all, audience, for being here on a afternoon, on a weekend. And I hope you will be enjoying the academic feast. So I welcome on behalf of four societies, Sphere, Center for Behavioral Medicine, the Indian Psychiatry Society West Zone, and Mahatma Gandhi Trust, Aurangabad. So this is a fourth international conference on mind-body medicine in diabetes and endocrinology, the Synapse 2023. And to start with the sessions, I would like to introduce our moderator for the first session, Dr. Madhura Samudra. Hello, Madhura. And can I have a CV slide, please? Yes. So Dr. Madhura Samudra is a young budding psychiatrist, and she's just finished with her psychiatry studies and now into practice. She has been a speaker at the World Psychiatric Association conference in 2020. She has published in the WHO COVID-19 database. She's actively working in raising awareness in mental illness on various platforms. She's a certified child and adolescent sex educator, and I would like to say that she's been very actively involved with all our mind-body medicine activities, very enthusiastic. And over to you, Madhura, for the proceedings.
Thank you, ma'am. Good afternoon to all the delegates who have joined. I would like to welcome you all for the Synapse 2023 conference. I would also like to introduce the next speaker who will present the presidential address for today. Could I see the slide, please? So our next speaker is Dr. Chetan Deshmukh. He's an MD and DNB in internal medicine, and he did his MD from BJMC and Sassoon General Hospital, Pune. He did his DM in medical oncology from Tata Memorial Hospital. He's one of the first DM medical oncologists in Pune and from Tata Memorial Hospital. He's a consulting medical oncologist in Dinanath Mangeshkar Hospital, Orchids Breast Hospital, Jahangir, and Ruby Hall Clinic. He's also an honorary oncologist at Sassoon General Hospital. He's the former editor of American Cancer Society, the India Initiative. He's actively involved in clinical research for the past 15 years. He has been the investigator for about 75 clinical trials. I can't see the... He's also the president of Society for Prevention, Healthcare, and... Can you go to the previous slide, please? Yes, thank you. President of Society for Prevention, Healthcare, Education, and Research, that is SPEAR. And I would like for Dr. Chetan to take over and please give the presidential address.
Thank you, Dr. Madhura, for those kind words of introduction. Good afternoon and warm welcome to all my friends, colleagues, mentors, and teachers who have gathered here to attend Synapse 2023, the fourth international conference on mind-body medicine. It's been about 4 years since we started our NGO, SPHERE, which is an acronym for Society for Prevention, Healthcare, Education, and Research. The inception happened a few months before March 2020, and we had our first conference in February 2020, which served as an introduction to this rather important but not oft-spoken topic of mind-body medicine. In March 2020, COVID pandemic struck and things have never been the same again. A lot of organizations had to reduce or even close down their work. And I'm proud and very happy to say that SPHERE continued to work with the same zeal and in fact grew in strength. From providing the much needed N95 masks to healthcare professionals in April 2020, distribution of food grains and medicines to the needy, to imparting education to people regarding physical and mental health, SPHERE continued to work on its motto of tackling health issues at all levels. The global pandemic made people aware of the importance of physical health, prevention, and mind health, especially during phases of those lockdowns. I'm sure all of us agree that those were tough times, difficult times indeed. Synapse conference continued to happen during this period. It happened virtually in 2021 and in a hybrid format in 2022. Another important activity has been the practical and hands-on training workshops in improving mind health and behavioral intervention in clinical practice. Last year, we had more than 100 delegates who benefited from this workshop. Cut to 2023. Today, we begin Synapse 2023, the fourth annual event. We decided to conduct this event virtually this year for a couple of reasons. One is, I thought that reducing the hassles of travel and staying away from work can help focus on the core academic issues. Secondly, virtual format allows people to access this conference from across the world to participate, to share their thoughts and work. This year, we have people joining from the United States, Germany, and Nepal. After 3 years of a rather troublesome period of the pandemic, we are gradually returning to normalcy. However, we believe that important lessons were learned during this period, lessons which we believe should be built upon, updated, and improvised. Mind health, the link between mental and physical health, concept of allostasis have gained unprecedented importance in the management of non-communicable diseases and in physiological states like menopause, puberty, and in fact, daily living. Sphere has started work in comprehensive global health and wellness assessment, and we hope to showcase our work in near future. We are also working in women health and cancer prevention. The sheer scope of the work is absolutely vast and overwhelming. We welcome collaborations from like-minded organizations, individuals, and companies in their respective capacities to join us in this endeavor. Once again, I welcome you all to Synapse 2023, and I hope you all have a fruitful and learning experience. Thank you.
Thank you, Dr. Chetan, for the wonderful presidential address. I think it was the perfect welcome that we needed to kickstart the Synapse 2023 conference. For our next speaker, I would like to invite Dr. Vaishali Deshmukh, whom we have seen work tremendously hard to make all of the previous conferences successful. Dr. Vaishali Deshmukh is MD, DNB gold medalist in internal medicine, and she has done her DM in endocrinology. She's working as an assistant professor in endocrinology at Sassoon General Hospital and BJMC in Pune. She's the consultant and head for Dinanath Mangeshkar and Deshmukh Clinic, Pune. She is also invited as a faculty for about 932 CMEs, webinars, interviews, and conference. She's the founder and secretary of the NGO Sphere. Her awards include the Gold Medalist Award, the Proficient Woman Award, Kranti Surya Pratishthan Award, Adarsh Mahila Puraskar, Jeevan Gaurav Puraskar. She has 22 publications. She has also authored 4 chapters in 4 books and press, and she has published 60 global phase clinical trials in endocrinology and NBM research. I would like to hand over the mic to Dr. Vaishali.
Thank you, Dr. Madhura, for that kind introduction. And I would like to represent as a secretary of Sphere as to what activities we have been doing, and we would like to reflect on this. So I would like to share my presentation. Can I share my slide, please? Yeah. I hope my slides are visible. Yes. So, as we heard Dr. Chetan mentioning that Sphere stands for an acronym. The acronym is SPHERE, and of which P stands for Prevention of All Non-Communicable Disease. H stands for Healthcare for All. Then E stands for Education of Community, Doctors, Nurses, Paramedics, Organizations, Societies, Industry, and Institutions. R stands for Research in Non-Communicable Disease, Endocrine Disorders, and Cancers. And in this, we have a common motto of women health and mind health coming into all these categories. So that's how we landed up with Synapse. And our journey has taken the footsteps through conceptual framework, operational framework, translational framework, training and education. So we have been working on these fronts simultaneously right from the inception. So laying the concept was a difficult task, and I should thank all the mentors and the patrons who have supported me in this cause right from Synapse 2020. And CBM Trust has been very proactive in terms of taking this concept ahead at various stratas in the society. So these were the three conferences, the Synapse 2020, Synapse 2021, and 2022. So the initial first conference was mainly to lay this concept of mind-body medicine in endocrinology and diabetes, because it was not described in books till then. And even now, literature has very few documentation on this whole concept. So setting a context of getting this concept into the generation which is practicing diabetes and endocrine was the first thing. Second is that how you help the lifestyle intervention in a very practical fashion. This was what was taught in the second conference. The third conference, which was done last year, was mainly focusing on how to improve quality of care adherence. And now we have moved a step ahead in terms of giving this kind of therapy as an adjunct to pharmacotherapy. So we are talking about pharmacotherapy as the therapy for illness and adjunctive therapy of mind-body medicine as adjunct therapy for wellness of those ill patients. So it is like illness covered with diabetes control and wellness of a diabetes patient being dealt with mind-body techniques. So it is like a synergism of these two therapies. So this conference is mainly going to focus on this synergistic combination of pharmacotherapy and adjunctive role of these mind-body medicine. So what concepts have been brought about by Synapse was mind-body medicine, then putting diabetes as a network science disease where integration is a must. Then psychoneuroimmune endocrine model was described first time. And apart from that, we have come up with certain new assessment of health strategies, especially the CGI health, the CGI, the comprehensive global assessment of diabetes, and then the concept of autonomic health and autonomic hygiene. So all these concepts have been the cornerstones on which the organization in collaboration with CBM Trust is working, and Indian Psychiatry Society has been very cooperative in this endeavor. So as I said, this not only was it preached in conferences, it was also practiced in our clinics, and it led to design of two important questionnaires: the Mind Health Assessment Questionnaire, the PNI questionnaire, then the CGI Health Assessment Questionnaire, as well as the CGI Diabetes Assessment Questionnaire. And these four questionnaires were implemented. Their studies are being published for these, and we will have soon data coming out with these studies, which are long-term prospective studies. So what has eventually happened is that we have been able to get into the society, to a general practitioner, the concept that mind-body medicine can be useful right from the primordial prevention level to primary and secondary prevention in terms of improving compliance and adherence to therapy, and in terms of tertiary care, that is improving the resilience and the survival and quality of care of terminally ill patients. So all this like a pyramid that we usually follow for any NCD, mind-body medicine forms the base of that pyramid, and that is what we are trying to look, that this has to be offered to the masses beyond what we are giving as pharmacotherapy and other lifestyle interventions. As far as the research and the operations are considered, heart rate variability studies are in progress with cardio-autonomic studies, the CGI health, the CGI diabetes, and yoga and autonomic nervous system studies are in place with various collaborators. Now, patient workshops and mind-body clinics have been an integral part of our activity right from the beginning. But first time in an institutional setup, mind-body clinic has been started by Dr. Leena Fadke and Dr. Priya Mardikar in the physiology department of SKNMC Pune. And I think that's a huge success of this whole story. And I would like to congratulate the team on that. In publication, our various processes, we have chapters on PNI in health and disease in the ESI textbook, which is awaiting publication. Yoga for diabetes prevention, which is also awaiting publication, and prediction of micro and macrovascular complications in type 2 diabetes using heart rate variability is now sent for publication. So these are the publications which are in place with all the activities that have been done so far. As far as the autonomic health aspect is considered, digital innovative health solutions have been looked into, and with the help of technology, we could come to this concept of this Chronovisor Tele HRV, which is a digital health solution for easy detection of the cardiovascular risk in diabetes. And this is indigenous. I think it is 1st April today. It's not only April Fool Day; it's also DIY Day. So do it yourself. And this is the first technology in India which is indigenous in nature, which is easy to use, and that whole team involved in this R&D has been useful in designing this technology, which has been very handy and non-invasive in nature and at the cheapest cost. So you can see that this technology is non-invasive, the skill requirement is low, the cost is low, however the sensitivity is high. So as compared to all the other tests which are quite expensive and invasive, we have been able to design this standardized test for cardiac autonomic dysfunction detection. And it's just this handy device giving us a clear picture of the autonomic status. This data was presented by us at RSSDI Ahmedabad way back in 2018, and now it's a time where we are implementing into the society. It's already been presented in the ESG and the artificial intelligence methodology using this data has been presented in USA also. The technology has received numerous awards for innovation, and now we are planning to take this technology to every physician and every general practitioner who can assess the cardiodiabetes vascular risk. So coming to the operational framework, the my 2-minute mind body health questionnaire was designed by us, and which was published in the American Association of Clinical Endocrinology in 2022. And this questionnaire was forwarded to the team of collaborators, and Dr. Kirti Samudra from our team, Dr. Pradeep Kumar Modi have designed their own strategies for psychosocial counseling, and we'll be hearing more from them as to how they have taken this ahead. And HRV studies are being undergone for cardiac autonomic assessment. So as I said, that patient education and patient centricity is our goal, and that's why we go to the community every now and then with these concepts. And the reason why we did this fellowship was the same, so that we could take it to the interiors of the country, and we had people coming from all over India, even from outside India, for understanding this concept of mind body health. The first fellowship program which was done last year, it was well appreciated. It was a 4 days workshop, and this was the first batch which passed out. So this year we have this workshop on 20th to 24th July in Pune, and I welcome all of you to be a part of this. So the future is, what we are looking forward is opportunity for health promotion in diabetes. We're looking at yoga as a neuroscience technology, looking at concept of autonomic health and hygiene, identifying autonomic arrhythmia as a marker of stressors, then corrective strategies to help this autonomic arrhythmia, and to get a uniformity of health assessment and illness assessment in diabetes as a CGI, and making mind-body medicine as an integral part of diabetes and NCD management. Of course, it's not an individual work, it's a team of collaborators who have come together, and it's not only a national team, an international team working in the background. So that's all. And before I end, I would like to say that knowledge is telling the past, wisdom is predicting the future. So this is what we want to share, the wisdom of all the eminent people, and that's why you see the faculty is such that they would be sharing their pulse of wisdom with the whole audience, and I'm sure you'll enjoy that. Thank you so much.
Thank you, Dr. Vaishali ma'am, for that enlightening reflection of the past work of Synapse. So since we are done with the first part of our conference, I would like to hand over my duty as a moderator to our next moderator. Can I please have the CVs for the moderators? Thank you. So here I am introducing Dr. Umesh Nagapurkar. He's an MD and diploma in psychiatric medicine. He's a consultant psychiatrist. His medical education background is from BJ Medical College, Pune. He's the ex-lecturer at MIMH, Pune. He's a practicing psychiatrist from Nasik since the last 26 years. And he's the president of Indian Psychiatric Society, West Zonal Branch. Can I also have the CV for the next? Okay, so we have Dr. Nagapurkar here. Sir, I would like to hand the mic to you now.
Thank you so much. The first session, I think the interest has been created enough to go ahead with the second session of today, that is early identification of allosteric load. Can I have the first? So we have three speakers for this: Dr. Leena Padke, Dr. Prashant Daspure, and Dr. Aruna Datta. Yeah. So to start with, I would like to introduce Dr. Leena Padke, who is going to talk on makers of allostasis. Dr. Leena Padke is Professor and Chair, Central Research Lab, and Coordinator of Incubation and Innovation Center at Siagarh Medical College. She has received special training in cardiac autonomic function test and heart rate variability assessment. Founder Secretary of Research Society of SKNMC Pune. Principal investigator in many multidisciplinary research projects. She has more than 30 national and international presentations and publications. She has been faculty at various national and international platforms. And important issues that T2DM and preeclampsia and National Sepsis Neuroscience, Yoga and Exercise Science. Over to you, Dr. Leena.
Am I audible?
Yes, yes.
Yes.
Are you able to see the presentation?
Yes.
Yes. So let me first congratulate Dr. Vaishali and the team for organizing Synapse 23, a unique conference with a special focus on mind-body medicine, and it is for consecutive 4 years now. So I must congratulate to her. And in fact, this time she has given me the responsibility of an opening batsman. So I will try to make a good foundation for the to my best. I can lay a good foundation for this conference. So today's topic is on which I'm going to speak is the marker of allostasis and the overview. So let's first begin with a little bit theoretical concepts. All of you, right from the beginning in first year, you know the concept of homeostasis, which is a physiological response to a stimulus to maintain constant conditions in internal environment. And this internal environment actually is what is the natural design, all the physiological set points with which we are born. So body tries to maintain these internal conditions as far as possible to maintain homeostasis, and it's important for survival also. And what we actually try to maintain is all kind of physiological parameters like blood pressure, set points, pH, temperature, So far, so on. And the allostasis is basically an adaptive physiological response to maintain homeostasis whenever body is exposed to stressful stimuli. So you can call the allostasis as an extension of homeostasis, where the stimuli is perceived as a stressful and then the body responds to that stimuli. And all of you know that no biological system is 100% efficient. So whenever we are exposed to any kind of stressful stimulus, the body responds to it. And when the stimulus is withdrawn, there is a natural homeostatic recovery that occurs. But as the biological system is not 100% effective or efficient, there is always an incomplete homeostatic recovery occurs, and therefore some amount of error always remains. So when we are repeatedly exposed to stressful stimuli, this amount of error, it builds up. So allostatic load is nothing but this built up error in the physiological system. So you can call it as an allostatic load as a multi-system physiological dysregulation, especially the regulation of PNIE, that is psycho, neuro, immune, endocrine axis. And that's this dysregulation sets in due to incomplete homeostatic recovery whenever we are exposed to repeated chronic stimulus that is perceived as a stress. What is the consequence of this? The consequence, you can see it in this slide. It is the gradual shift of physiological set point. So here you can see that whenever the stimuli is there, initially there is some allostatic response. When the stimuli is taken away, then you find there is a homeostatic recovery. When we repeatedly give us a stressful stimulus, you can see over here, the allostatic response it goes on increasing and the homeostatic recovery is incomplete. And then you can see that the physiological set point with which we are born with, they already shift to a new set point level. So this gap or this difference between the set points with which we are born and the new level of set points, which the chronic stress has, any chronic stimuli has shifted to, this is called as allostatic load. And this allostatic load puts actual natural load on this design. So we have to work now with this, all the organs we are born with to a higher set point levels, which is definitely a load to the body. So here now we can see that how this allostatic load, it is associated or related with the health non-communicable disease spectrum. Now here you can see that the allostatic load, it starts to build up even in the pre-disease condition. So it's not that only when we'll end up in disease or disease complication, the allostatic load is there on the body. Even in pre-disease states, the allostatic load starts building up. And all of you know that this non-communicable disease, it's you can say one of the first killer of all kind of diseases. About 41 million people die each year, because of which constitute about 71% of deaths globally. And the cardiovascular diseases, out of this and all deaths, they account the most, and approximately 14 million people, they die because of CVDs. And the next to it is the diabetes complications, cancer, and so on. And the allostatic load is a major contributor for this global burden. Now, what actually causes or what actually leads to this build-up of allostatic load? So it is basically the disturbances in 4 pillars of health, which are also responsible for increasing the allostatic load. So if there is a disturbance in the sleep rhythm, GI rhythm, which includes hunger, satiety, energy and physical activity rhythms, and the psychological construct, comfort, meaningfulness, optimism, self-control. If there is any kind of disturbance in that, then it adds up in the already established allostatic load. And moreover, the disease process itself increases the allostatic load. And actually this sets up the vicious cycle of this allostatic load built up. So you can see over here in this previous slide that if we don't control the stage at the pre-disease or disease state, the allostatic load will go on increasing, and thereby the stages, you can see the non-communicable disease spectrum, it more shifts towards the complication. So it starts with pre-disease state, and over a period of time, it shifts to disease complication. So now how to address the issue of this allostatic load? What we should do about it? We know that there is allostatic load. How to go about it? So as it's for any medicine, it's a good assessment is a half management done. So if we know how to measure the allostatic load, we will know how to resolve this. So the quantification of the, so basically allostatic load measurement is based on the quantification of the representative markers from this psychoneuroimmune endocrine axis. So what are these markers? So there are 4 primary mediators which were originally studied whenever this concept of allostatic load has come in 70s. So initially the markers were all biochemical markers, and they represents the PNIE axis, and most important and most frequently studied is the cortisol. Then noradrenaline, adrenaline, and DHEA. After that, 2 newly added markers, which were newly included in the primary markers, primary marker category, are heart rate variability, which is, you can call it as a new vital, because it's a very, very important marker, which we will discuss over a period of time. And most importantly, out of this all markers which I have shown, heart rate variability is only the one which is a biophysical marker. Rest of them, they are the biochemical markers. So they represent body as biochemical structure, while HRV try to represent the whole body as a physical, biophysical, in a biophysical construct. So this is what is the basic difference, you can say. Then there are secondary markers which are there, and 6 secondary markers are there. They represent the structural remodeling of the receptor sites. So there are some cardiovascular markers like systolic blood pressure, diastolic blood pressure, heart rate, and pulse rate, pulse pressure. So these are cardiovascular markers. Then there are metabolic markers like high density lipoproteins, cholesterols, West to hip ratio, glycated hemoglobin, BMI, etc. And then immune markers like C-reactive protein and interleukin-6 and fibrinogen. So you can see all the components representative from PNIE axis. They are included in the allostatic load markers. So once you, what you have to do is that you have to measure these markers, and then the calculation of allostatic load index. That is done by standardized practices, and the most common method which is used to calculate allostatic load is to dichromatise the biomarker based on either the quartiles or based on the clinical cutoff. Like 0 code is given if the markers are in the normal range, and 1 means they are in a higher range than the accepted norms for that population. So we have to use the accepted norms for our population in order to calculate the allostatic load index. And a high allostatic load means 3 or more biomarkers are in a high risk range. So this gives us the idea that how much is the allostatic load on the body. More the markers out of range, more is the allostatic load. Now coming to this heart rate variability, which is a marker for the allostatic load. It's as I have already mentioned that it's a new vital. It's a very, very important parameter. Why? Because first, it is non-invasive, easy to measure, and cost-effective marker of cardiac autonomic activity. So all these 3 qualities makes it to be more scalable marker. You can use it at a different population, in different population at over a wide range. Then a wide range application of this marker. It's used for diagnostic purpose, for screening, prognosis, and most important, now what we are seeing is that it's used in prediction, especially prediction of build-up of allostatic load. So this is a very good and most promising marker. Autonomic nervous system, and why this marker is important, because it measures the cardiac autonomic activity. And all of you know that the autonomic nervous system, it's an important component of PNI. It regulates all internal organs and has a multi-system effect, including on HPA axis and immune system. So autonomic, by its afferents and efferents, has a direct effect on regulation of HPA axis as well as on the immune system. So you can call it as ANS as a candidate for a final common pathway for development of many diseases, mainly the NCDs. So that's why it is the HRV is the more robust and most important marker, because it is depicting the influence of ANS. Then autonomic dysregulation, especially progressive sympathetic overdrive, it is known to precede before the development of NCDs. So progressive sympathetic overload is considered to be an important in development of NCDs. Then autonomic dysfunction and reduced heart rate variability, both of them are shown to be associated with many NCDs, especially in metabolic syndrome spectrum, right from obesity to the complication of type 2 diabetes. And as I have said, that HRV represent the biophysical construct, a different dimension to look towards body, as against to the normal representation in biochemical format. So we must also have to look the body in a different perspective as a biophysical construct. So our experience with this HRV and allostatic load is that we have conducted many studies, right from predictions of diabetes complications to predictions of coronary artery. We have also used this as for prediction of preeclampsia and diagnosis of CAN in type 2 diabetes. And because of these studies which we have conducted, now we are able to give services to the patient for predictive, especially we are using it for tests to refer the diabetic patients for the CAD referrals, then for diagnosis of severity of CAN, that is cardiac autonomic neuropathy, isolated orthostatic hypotensions, and POTS. So these are the services which over a period of time now we have started providing. The data speaks, because why I have shown this, that approximately 1,350 HRV card tests up till now we have done, and which included all diabetic patients which are referred for coronary angiography. So we have included all these types of patient pre-eclampsia studies. We have conducted almost 113 samples. So like that, we have a lot of experience in conducting this kind of HRV card test. And these are our very, you can say, cardinal kind of papers which we have presented. ESD Berlin, where we have presented this heart rate variability indices in patients with micro and macrovascular complications of type 2 diabetes. It was initially an observational study, but over a period of time we are successfully convert this into the service, and where now we are even referring the patients who come to CART HRV test, the diabetic patients especially who show reduced HRV and without any clinical symptoms, and if we find that HRV is too low, then we definitely refer this patient for the angiography evaluation. So HRV in type 2, you can see over here that mean SDNN is a marker of HRV indices, and it's without complication, it is much more compared to the diabetes with complication. So if we get a patient without any kind of other screening test, and if we find that their heart rate variability is reduced, this is the right candidate to send for further evaluation of micro and macrovascular complications. So this paper we have presented at ESD Berlin. Then we have also seen the importance of this HRV, as it captures the allostatic load, and which is better than the heart rate marker. So as you know, the cardiovascular marker is also heart rate. Allostatic marker is heart rate. So here we have observed that the HRV captures the load better. And you can see over here in this slide that the heart rate of all these patients is almost in the same physiological range. However, their variability is totally different. In the first left upper graph, it shows the variability in a normal person with a heart rate of 73, then a person with a diabetes with a heart rate of 80, then a diabetes progressive, uncontrolled diabetes, and then followed by diabetes with complications. In all these cases, you can see the variability is markedly reduced from normal distribution to the complication, and for the almost in the heart rate in the range of physiological range. So you can say that HRV actually captures the load better than the heart rate. Then we have also seen that HRV differentiate the extent of allostatic load with disease complications. Especially we have seen it in CAD, and that is coronary artery disease, and with heart failure, without heart failure. So here you can see that the variability is better with the patients who are actually referred for angiography, but they turned out to be CAD negative, and they were also not having the feature of heart failure. So their variability is much better compared to the patients who are having coronary artery disease as well as heart failure. So you can see there is a gradual progression of the HRV reduction from the non-complicated to complicated stages. Then we received the different awards for these studies, like we have received the award at International Diabetes Summit in Pune in 2018. Then we have also presented the study with especially Association of Cardiac Autonomic Dysfunction with glycemic status and disease duration in patients with type 2 diabetes in RSSDI 2018. Then also published, also presented the study, Association of Prolonged QTC Interval. Prolonged QTC is also a marker of autonomic dysfunction. So association of this prolonged QTC with cardiac autonomic dysfunction, again at RSSDI Ahmedabad. The salient finding of first study is that if there is a reduced HRV indices like SDNN, TP, LF, with the presence of CAN, which is assessed by a standard EVIX battery, and HbA1c greater than 7, duration of diabetes more than 5, and prolonged QTC, then these patients are at high risk for macro and microvascular complication. And even without any clinical symptoms suggestive of CAD, they are the patient we should refer for the angiography. Then we have also used artificial intelligence and machine learning for allostatic load quantification and prediction. We have presented this study at the International Conference for Machine Learning and Cybernetics in US. Then these are other publications related to the use of artificial intelligence. So technologically also we want to go ahead with this. Now the question comes, yes, we can measure the allostatic load. We know the markers. How to decrease the allostatic load? That's a very important question if we want to treat our patients. So the answer is the resilience building, that is to develop the counter mechanisms along with managing the disease so as to break this vicious cycle of allostatic load development. So along with disease management, if we start to build up some counter mechanism which can counter the allostatic load, so this will help to break this vicious cycle of disease and the allostatic load built up. Now, we have used this HRV even as a biomarker for resilience. So we have conducted a series of yogasana and HRV studies. So here we initially I would like to mention that what this resilience means. So really, resilience is the capacity and ability to recover from the difficulties or adapt quickly, or its toughness. So it's an opposite of allostatic load. Allostatic load tries to take you towards complication, while resilience tries to take you away from this complication towards healthy states. And improve HRV, it indicates better health and resilience. So HRV is a very good marker both to detect the allostatic load as well as to see whether, as it is a prognostic marker also, so we can use it to see that whether there is a improvement in resilience or improvement in health. So how, because there are a lot of studies which are already been done where it is shown that exercise improves HRV. So it's one of the original article meta-analysis randomized control trial, which has shown that exercise, all kind of exercises, they have used all kind of different types of aerobic exercises, and they have seen that over a period of time, HRV improves with exercise. There are a lot of other studies which have conducted, which have taken yoga as a measure. And this review article also demonstrated that this yoga improves HRV. So definitely these kind of techniques, they have a lot of impact on the resilience building, and they might be very, very helpful in our goal of patient treatment. So our own experience with this HRV resilience studies, we have conducted a lot of studies, especially the process studies where ANS modulation was observed or measured during the specific exercise or asana. We have also seen the effect of autonomic modulation in yoga naive individuals, in yoga trained individuals, how the autonomic nervous system it modulates in these two different group of people. Then if you do the asana in a proper yogic way or in a exercise way, how the autonomic modulation differs. So you can see over here a lot of experiments that we have done, direct comparison of yoga with aerobic exercise. The same person is doing yoga as well as exercise, and then directly we have compared the autonomic modulation in these individuals. Then this, whether you are doing yoga in a proper relaxed way or in an exercise way, the HRV differs in these groups. So if we want to have some kind of yogic benefits, then we have to do the asana in a yogic way. Then modified asanas and aerobic exercise in yoga naive individuals, and we have compared their modulation with the experienced yoga practitioners. What we have observed, our important observations are that definitely yogasana have a training effect on autonomic modulation. Here you can see the at baseline 6 months and after 1 year. So we have tracked down the individual up to 1.5 years, and then we have measured their responses during yogasana. And what we have observed, that mean RR, when we compared with resting and with Tadasana, the heart rate, the resting heart rate is less after 1 year of training. So definitely it marks that there is increase in vagal tone or parasympathetic modulation. Secondly, less increase in heart rate after 1 year of training indicates that circulatory demands are met at lower heart rates. So that is what is the marker of resilience, that you are able to do any activity, but the heart rate remains low. You don't require to pump the blood at very high speed. Even a little bit increase in heart rate, and that will sufficient to meet the demand. So these activities are more relaxing in nature. It also indicates that you don't require much of energy. So they are quite relaxing asanas. Then here you can see the HF is a typical marker for vagal modulation. And what we see with the training is that less vagal withdrawal during Tadasana. So it's a very important observation. Why? And we are thinking that it's very useful for finding for the patients who are having orthostatic intolerance. So if we are able to train them for the Tadasana, the less vagal withdrawal is, I think, is the first very good step for them not to land up in orthostatic intolerance. Then high vagal influence during Sarvangasana compared to resting. This graph you can see where compared to baseline, where when the person is doing Sarvangasana, the vagal withdrawal was much, much more. And after 1 year, instead of withdrawal, there is a augmentation in the vagal response modulation. So this is a quite interesting kind of finding, that after 1 year of training with this Sarvangasana, there is actually vagal augmentation during asana. So here it is possible that with few asanas, we are able to withdraw our vagus. With few asana, we can augment the vagus. With few asanas, we can train, we can little bit rise our sympathetic modulation. So by giving us different kind of postural possibilities, we are able to modulate our autonomic nervous system. But the most important thing to remember from this is that it takes at least 1 year for you to develop this kind of modulation. So yogasanas or any kind of this mind body techniques, though it start working immediately, but the persistent effect or the actual learning effect you observe after at least 6 months of training. So you have to do yogasana for at least 6 months to train your autonomic nervous system. Then with this graph, you can see that we have, it's a cross-sectional study where we have compared the resting heart rate variability of trained yoga practitioner and with that of the patients with complication, without complication, yoga naive individual. So you can see that over in these groups, the HRV is actually reducing. The overall variability reduces. So it's high variability is much higher in yoga practitioners compared to those who are having diabetes with complication. So this also indicates that if we are able to do such kind of practices, if we are able to give such kind of practices to our patient, then there is a possibility to counter this allostatic load which the disease itself is building. And the health pillars which are disturbed in patients, they are also contributing. So we have to look for all those mechanisms if we are able to improve the sleep, because sleep also has an effect on HRV. So if we are able to improve the sleep, if we are able to improve their digestive cycle, if we are able to improve energy cycles, and if we are able to modulate their autonomic nervous system in a different ways, so definitely there is a possibility to improve their HRV and resilience, which will be very useful to the patient. So on one side, there is a disease management, and on the other side, we are trying to improve the resilience of the patient by giving all these methodologies. And the most important, this is the effect that we have observed is few asanas, they actually cause sympathetic stimulation, and few asanas, there is a parasympathetic augmentation, like the asanas shown in green color. These are Sarvangasana and Shirshasana. So exactly opposite tilt of what normally we are in a standing position. So standing position are more like an exercise, while the inverted postures are more relaxing. This is what the study shows, which is under publication, which we have also presented at Indian Science Congress in 2015. So the salient finding of all these studies is what is I can see is the step towards evidence-based medicine for mind-body medicine. So based on these evidences, what people need, accordingly, we can provide them these techniques. So if you want to improve their, most of the time it is because of the sympathetic overdrive, which increases the overload, which actually is responsible for the allostatic load. So we have to give all those kind of techniques which either decreases the sympathetic drive or improves the vagal modulation or vagal drive. So any combination of these techniques can be used in order to reduce the allostatic load. And it requires time. It requires time to build resilience. It's a long duration activity, but it's definitely a helpful activity. So I thank all the audience and everyone for patient listening, and I'm there to answer any queries or questions. Thank you very much. Thank you, Dr. Vaishali, for giving me this opportunity to talk on this much interested topic of allostatic load. Thank you.
Thank you, Dr. Leena, for dark load. What is it? How to identify simple methods like HRV and countering that allostatic load. How to build up resilience. Thank you so much. Any questions? Sorry, I don't see any questions here right now. So can we go ahead with next presentation?
Yes, sir.
Yeah, thank you, Dr. K. Now coming to the next important presentation of this session, is clinical management of sexual dysfunctions in males and females. Very important clinical topic in day-to-day practice. And to guide us on this topic, we have Dr. Prashant Basturi, who is a psychiatrist, is expert in sexual medicine. He has been workshops on sexual medicine, avid researcher. I know him as a psychiatrist, also as a sexual medicine expert, and his role as a medical. So I present Dr. Prashant Basturi. Over to you, Dr. Prashant.
Hi, good evening, everyone. First of all, I would like to thank Synapse team to give me this opportunity to come on this platform and speak on this topic. So the topic given to me is that clinical approach to sexual problems in males and females. So I understand it is a vast topic, there's a lot to tell and a lot to discuss, but not sure how much I can justify this. So without wasting time, I will go through the basically the next slide. You can see here the linear model described by Master and Johnson. Basically, we all know that Master and Johnson, they are the pioneer in sexual medicine, diagnosing sexual disorders and the treatment for the same. So they studied a number of men and women, almost 10 years, and they found that there are some sexual physiological changes in men and women, and they came out with the concept of sexual response cycle, and they have explained here. You can see this linear model where they have described in like excitement phase. There are different phases: excitement phase, then plateau, then orgasm, and resolution. So next slide, if I talk about the Kaplan's model of sexual response. So Kaplan, we all know that she's like a pioneer in sex therapy. So she has added a few more dimensions into sexual response cycle in this triphasic manner. Triphasic means there are three phases she has explained, like desire, excitement, and the orgasm. So why I have directly started with this presentation directly with the sexual response cycle? Because when we understand the basic these phases, like desire, the excitement, and the orgasm, then it is easy for us to classify the different sexual dysfunction. For example, if we see the desire the phase, if someone has issue in the desire phase, then it is desire disorder. Someone has issue in the excitement phase, that is excitement disorder, and that's arousal disorder. And someone has issue in the orgasm, so it is classified as orgasmic disorder. So here we can see I have entered these sexual dysfunctions accordingly in different phases. If you see, first of all, we'll discuss about the sexual dysfunction in men. So I have divided in three phases. Desire phase. So what sexual dysfunctions are covered under desire phase? So first one is hypoactive sexual desire disorder. So as name indicates, so there is a less sex desire. So whenever there is a persistent lack of sexual desire, lack of fantasies, and lack of sexual thoughts, that is called as hypoactive sexual disorders. And extreme form of lifelong hypoactive desire that leads to asexuality. So almost 1% men they come under asexuality. So next one is hyperactive sexual desire disorder. So actual name itself indicates that the person would be having the repetitive obsessive sexual thoughts, which he get distressed, and it impacts his day-to-day activity and his functionality. So next one is sexual aversion disorder, where there is a persistent and recurrent aversion or avoidance of sexual contacts with the partners. That's what is called a sexual aversion disorder. So that we cover the desire phase. So three sexual dysfunction comes in the desire phase. Next one is arousal phase in men sexual dysfunction. So erectile dysfunction, it represents the arousal disorder. So erectile dysfunction is one of the common sexual dysfunction. We all know that. And basically, if you see, every man has to go through this phase at least once in his life. So basically, it is that common. And the next coming to orgasmic phase. So all ejaculatory disorders are covered under orgasm phase. So because that is a peak point, and we'll start with the premature ejaculation. So premature ejaculation, I feel it is the most common sexual dysfunction in men. So premature ejaculation means someone is ejaculating before the penetration in the vagina or within 1 minute of penetration and against his will, which is distressing for him as well as his partner. So that is called as premature ejaculation. So almost 30 to 40% men are suffering from premature ejaculation. And if we talk about the classification, so premature ejaculation is classified into the lifelong premature ejaculation and acquired premature ejaculation. So what has been the lifelong premature ejaculation? It means someone is ejaculating from very first sexual experience, that is called as lifelong premature ejaculation. And what is acquired premature ejaculation? Means someone is performing well for first few years. However, later he started ejaculating quickly. So that is why it is called as acquired premature ejaculation. So next one you can see here, the delayed ejaculation. The delayed ejaculation means the persistent or recurrent delay in the orgasm, that is called as delayed ejaculation. Unejaculation means the person is not able to ejaculate at all anytime in his lifetime into vagina during intercourse. Then retrograde ejaculation, the last ejaculatory disorder, whenever there is a failure of closure of bladder neck, that results in semen being pushed in the bladder. So that is called as retrograde ejaculation. So that was all about the sexual dysfunction in men. Now coming to sexual dysfunction in women, again it is divided in the same three phases. The desire disorder, it is the same as in men, that is hypoactive sexual desire disorder and sexual aversion disorder. So we already understood the definitions of these two disorders. So I'm not going in detail for this. Then coming to arousal phase. So arousal phase in women is a little bit different for the men. In men, it is the arousal disorder is very evident. Whenever there is no erection, it is an arousal disorder. But in women, arousal disorder is not that evident. The lack of lubrication represents the arousal disorder. So the lack of lubrication is the hallmark in female arousal disorder. Coming to orgasm phase in women, there is female orgasmic disorder. So whenever the woman, there is inability to have orgasm even after normal desire and normal arousal. This woman experiences desire phase, arousal phase, but not able to get the peak pleasure and not getting the orgasm. That's why it is called as female orgasmic disorders. The other dysfunctions are covered under pain during sex. The first one is dyspareunia. It means the pain during coital act. The next dysfunction is vaginismus. It is very common in women, and we get on daily basis so many couple becomes and women would be having vaginismus. So what is meant by vaginismus? Basically recurrent or persistent involuntary spasm of musculature of outer 1/3 of the vaginal muscles, and that is interfering with the penetration. So that is called as vaginismus. As I was saying that many people they come and woman would be experiencing the vaginismus, and that leads to unconsummated marriage. So we get so many cases, so many couples who are struggling to consummate their marriage like 17 years, 15 years, 10 years, just because of this vaginismus problem. Then the last one, the phobic fear of penetration, where the woman has fear of penetration. She may not experience pain. However, she has fear. And because of this fear, because of this phobia, she will not allow the male partner to penetrate in the vagina. So, so before going to the next part, I would like to discuss here the probable etiologies, because since we have less time, I'm not giving the etiology for every disorder separately. It is I have just covering in common probable etiologies here. So this for all sexual dysfunction overall. So if we talk about the common causes, then we'll go for the organic causes first, because there are organic causes, psychological causes, and lifestyle causes. So let's talk about the organic causes. So mainly organic causes, if we talk about them, the metabolic diseases are very important. For example, the first one is obesity. So obesity itself, it is independent risk factor for sexual dysfunction. And if we tell the obese person, even just to try to reduce the weight, so the weight reduction improves sexual dysfunction by 30% without any medication also. Then the next risk factor is hypertension, and half of the elderly men with erectile dysfunction, they have hypertension. It is that common in hypertensive people. Then coming to diabetes mellitus, and we all know that this is one of the leading cause for different sexual dysfunctions. And diabetics having risk of having ED, that is erectile dysfunction, 3 times higher than the non-diabetic people. And diabetic people may need a treatment for lifelong with PDE5 inhibitor. And we have seen that diabetics, maybe they are resistant for this treatment, and they may need the higher dosage of PDE5 inhibitor compared to the normal population. Then coming to next risk factor is the cardiovascular disorders. As we know that the heart is the organ who pump out the blood and gives blood supply to all the body organs. So any disorder, cardiac disorders obviously leads to different sexual dysfunctions. So now we spoke about the organic causes, the metabolic diseases. Now, what are the psychological causes? So mainly, as a psychiatrist, we diagnose lot many psychiatric disorders like anxiety disorders, general anxiety, even the panic attacks. Even we see the ovulation anxiety. Specifically, ovulation anxiety means the person would be able to perform other days, and their couple is really trying hard to get conceived. But whenever they know that this could be the ovulation period, the man is not able to perform. Man is not able to get erection because there is a huge ovulation anxiety he has. Then next psychiatric disorder is major depressive disorders, and obsessive compulsive disorder also leads to desire disorder and erectile dysfunction in men. Relationship definitely matters. So lots of interpersonal conflicts leads to the desire disorder and the arousal disorder. And nowadays we see that a lot many men, if they found that his partner is having extramarital affair, so that leads to desire disorder and erectile dysfunction. Even own extramarital affair itself causes the less desire having sexual contact with the partner. So any negative thoughts or negative views or negative attitude towards sex, that also leads to lack of desire and arousal disorder. And we have seen in many families, the families are very conservative, and there is a strict environment in home. So that also the people may develop into the desire and arousal disorder. I have seen many women who come to the clinic, they would be having the body shaming for even though everything is perfectly all right, but there is a body dysmorphic disorders. They don't like the body. That itself causes the arousal and desire disorder. So many young men, they come in the clinic with masturbation dependency history, and that leads to severe guilt. Severe guilt secondary to masturbation itself causes erectile dysfunction. So these are probable psychological causes for different sexual dysfunction. Now, lifestyle factors, if we talk about, so nowadays after COVID, so the life has changed a lot. So mainly most of the people, they're working from home. And they're working for 12 to 14 hours a day non-stop, and they're continuously with the system. So obviously, there is huge work pressure that leads to all this sexual dysfunction, the burnout, they get burnout, lack of rest, lack of sleep. This kind of lifestyle definitely affecting them, their sexual life, right? So these were the sexual dysfunctions, and basically the probable causes in men and women. So next part, so one more cause is like that iatrogenics. So means we prescribe lot many medications to patients for different disorders. In psychiatry, we prescribe different SSRIs, which can, because of the mechanism of action, that causes sexual dysfunctions. Even antiepileptics has a role in sexual dysfunctions. The alcohol, different substances, very common. in young generation nowadays. So that also leads to different sexual dysfunction. So that is iatrogenic cause. So till now we discuss about the sexual response cycle. We discuss about the different sexual dysfunction classification and the probable reasons, probable risk factors, and now another important aspect of the presentation is history taking, which is very important. And we all know that when a patient as history taking is really art. It gives lots of information to diagnose the patient. So whenever patient comes to the clinic, it is very important that usually I recommend my every patient to come as a couple, so to get maximum information from the partner also. But many times they come alone, so accordingly we need to take the history. So why history taking is important? Because around 75% of diagnosis comes from the detailed history. 10% diagnosis comes from the clinical examination, and remaining 15 to 20% diagnosis comes from routine investigations or some specialized investigation. That's the reason, if you see the percentage, as I said, 75% comes from the history taking. So it is that important. So what is included in history taking? So general information, basically a patient's age, what is his or her occupation, the marital status, that the patient is single, married or divorced. It gives lot many information to you. The medical history, personal history, that comes under general information. The problem for profile means problem is in one partner lead to dysfunction in second partner. For example, it is very important to call them as a couple to get the proper history. Just single person cannot give complete picture, right? So for example, why it is important, I will tell you. For example, if the woman is suffering from vaginismus, but that may, if it is persistent, that may lead to erectile dysfunction in men. So obviously, it is one partner ended up into having sexual dysfunction, another partner. Similarly, the man with persistent premature ejaculation, that lead to loss of sex desire in women. That's the reason. It is a proper profile. It is not just one partner. The second partner also can suffer from this sexual dysfunction. Then the sexual profile. If you see, there are different points here during the sexual profile. So orientation is very important. The good history taking only give the orientation, because it's very difficult to make patient comfortable, and usually they don't open their orientation. But unless until you know the orientation, whatever treatment you give, that will not work. So asking orientation with open-ended questions and closed-ended questions, that helps you to get the orientation. Then gender identity, where the man feels that he is a woman but strapped under a man's clothes. On the other hand, woman feels that she is a man but strapped under the woman's clothes. So to get this history is very important, so that accordingly you can decide the treatment plan. The masturbation, the frequency of masturbation, the method of masturbation history is very important, because we see on daily basis that the man masturbating with normal technique, that is holding in hand, may not end up into having sexual dysfunction. However, the man who is masturbating by rubbing against the bed or rubbing against the bed or surface may end up into having the biliary ejaculation or the ejaculation problem. So the history only will give you the proper way to diagnose the patient. Then premarital history. Nowadays we see that young generation people, they have multiple relationships before their marriage, right? So this history is very important. How many partners he or she was with, and the sexual practices, and how frequently they change these relationships. Because I have seen that they were doing very well before the marriage, but however after marriage they're not able to perform in bed with the partner. So this history will help to guide them properly. Then marital sex, yes, the marital sex, the frequency of sex, how many times it's happening, because nowadays life is so busy. So I have seen a young couple, if I ask them when was the last sex they have, so they said that after 3 days back, 3 years back, 4 years back. That is the real example. The frequency is also important. Then extramarital sex, as we discussed. Then the fantasies, basically the person having weird fantasies before marriage, and when the person get married, so he will not get the same stimulation in the marital life. So obviously will not be able to perform. So understanding the fantasies, getting this history is very, very important. That is possible only when you get proper history from the patient. Some people, they would be dependent on some sexual material like porn, watching porn. That history is very important so that you can decide the treatment. And the contraceptive procedures, we know that, for example, the oral contraceptive pills itself notorious that they reduce the sex desire. Then you get a lot many men who come to the clinic and say that doctor, I'm not able to maintain the erection. I lose my erection. Then I put condom on. So that is a very common example. So that so this history is very important. So next point is history of sexual problem. Means the onset of problem is very important, whether it is acute or it is chronic, because that will differentiate the organic versus psychogenic cause. If it is really acute onset, so that could be psychogenic probably, and if it is chronic, that could be a organic sexual dysfunction. Then whether the sexual dysfunction is situational or global, as I discussed, that is ovulation anxiety. So if only the person is not able to perform during ovulation, that is situational. Global means for every attempt is having the sexual problems, that is the global sexual dysfunction. This is possible only after getting good history. So that was just some brief idea about why the history taking is important. But little bit the strategy means how we should be equipped taking this history. First of all, whenever patient comes, it is very important to introduce yourself, because many times maybe they will go to the Google and they know the clinic name, but they may not know your name. So it's very important to introduce yourself. Then explain the confidentiality. How much ever your clinic is posh, but I have seen that most of the patients, they are really not comfortable when they sit on the chair. They're a little bit paranoid. They don't know where I came and whom am I talking with. But when you tell that person, taking into confidence that whatever we discuss, it will be confidential and that will be between you and me only. Please do not worry, just sit comfortably. You can see the facial expression changes immediately. That's the reason explaining confidentiality is really important. Then listen to patient empathetically, though don't be in a hurry, and because don't show sympathy, but showing empathy is really very important. And we should tell the patient that, I understand you are giving me a lot many information, but I may ask you few more questions to get the clear picture. So this idea we should give the patient so that the patient is ready. He knows what is going to happen. Also, you can add one more sentence that few questions may be awkward, but it is important for me, because otherwise tomorrow patient should not blame that the doctor is asking unnecessary questions to me. So if you make aware that there could be some awkward questions, so the patient, I have seen that patients are really comfortable for that, and then they give each and every information to you. Also, whenever they are discussing with you, you should give clear picture what exactly going to happen in the clinic. You tell them, I'm going to take history, I'm going to examine you if it is required, and the investigations if it is required again, and if you are trying to refer that patient to somewhere else, for example, neurologist or endocrinologist, so it has to be given clear idea to the patient. And don't forget to thank patient to keep that happen. I will just try to move fast. So the communication skill also involved. Don't ask close-ended questions, because we will not get complete picture of the problem. So ask open-ended questions. So that will help you to get the more information. For example, I've seen that. So you see a very happy couple sitting in front of you, and you assume that the relationship is really good. So you can ask that, I hope your relationship is good. So they may say yes or no. But when you ask them, tell me something about the relationship, that is open-ended question. So they start revealing the things happening between them, and you find that there are so many issues in terms of conflict. So open-ended questions will help you to get more information. Then asking patient gender, it is difficult, but it's very important. Even the partners, how many partners he or she is involved with, right? And avoid medical jargon. Means you don't give them, just tell them about the diagnosis name. Then that was about the open-ended question, but sometimes the direct question is also very important, because many times patients not comfortable telling their problems, so they will take you on tour, very vague complaints, and you will not be in the position to get the proper appropriate information at the stage of time. Sometimes direct questions also will help you. For example, you should ask about the sexual partners, that do you have sexual partners at the moment? Because the patient may come, a single patient may come to you with the with the complaint of erectile dysfunction. Doctor, I have erectile dysfunction, but then you assume that he is in relationship, he's sexual active, and you'll go on asking other related questions. But when you ask, do you have really partner? He tells that no, I'm single. It means he is having problem, he is having erection problem while masturbating. So asking some direct question is very, very important. So the next slide talks about the differentiation between psychogenic cause and the organic cause. You can differentiate if you ask few questions like, for example, if the onset of problem is recent, that would be psychogenic sexual dysfunction. If it is chronic, that would be organic. And if we ask about the early morning erection question to the patient, he may say yes, then he is getting early morning erection frequently, then whatever problem he is having, it is because of the psychogenic issue. But if he says that, doctor, I'm not seeing erectile dysfunction or morning wood since long years or many months, I'm not getting that, it could be organic. But again, don't consider only early morning erection is patient is not getting, that is organic cause. I have seen that patient with huge stress factor, the sleep deprived, highly anxious patient, even those patients also, they don't get early morning erection, even though the sexual dysfunction etiology is psychogenic. So after taking history and related information, now the clinical examination also very important. So basically, you have to go through general examination. General examination means you have to see whether the patient is obese, check the blood pressure, secondary sexual character, that gives a lot many information. The systemic examination involves multiple examination, like for example, the cardiovascular system, abdominal system, then CNS you have to examine, and sometimes if you suspect any prostate pathology, then the project examination, digital examination also you need to do. Then the last, but very important, that is genital examination is also very important, so that you have to, for example, in men, when you examine genitals, so the glans, head of the penis, the prepuce, the shaft of the penis to find out some lumps are there, in the scrotum to see, to examine any swelling or any accumulation of water or hydrocele. For that, all the genital examinations are really important, so that will help you to end up in having diagnosis. After examination, the investigation is important. The general lab investigations, like you have to get patient's hemogram done, the urine test, then fasting blood sugar. HbA1c very important, because I was seen in my clinic, the patient came with the history of the erectile dysfunction, but the patient didn't have any diabetic symptom. But when you investigate, the HbA1c is 10.5, so that is very high. So they don't have any diabetic symptom, but they end up your clinic with only erection problems. So these investigations, general investigation also helps you to diagnose patient properly. The hormonal assay, so obviously different hormonal tests like testosterone very important, thyroid is very important. For example, the hypothyroidism usually causes the premature ejaculation, and hypothyroidism is associated with the low hypoactive sexual desire disorder. That's why hormonal assay is very, very important. Then semen analysis, if some couple, they're trying to conceive since long time, and even though without using contraception, but they still they're not able to conceive, the woman is not able to conceive, then this semen analysis is indicated. Then vascular function assessment test, for example, the Doppler test can be advisable. The Regis scan to just to differentiate between the psychogenic versus the organic cause, and treatment these are the same vascular function assessment test. So management strategy, I will since we have let's short. Sorry. So I will talk about the oral management, because if you take every sexual dysfunction separately, it is very detailed. So you need to explain how the healthy lifestyle is important, because only pharmacotherapy is not important. The healthy lifestyle helps a lot about different sexual dysfunction. So yoga, meditation, or whatever cardio exercise we explain. Then treatment of the lifestyle diseases, for example, diabetes, hypertension, that is one of the root cause. So treat hypertension, treat diabetes, ultimately there could be some improvement in the sexual dysfunctions. The hormonal correction, just now explained about the thyroid, testosterone. If during investigation you found that there is issue with these kind of hormones, you correct them, so probably they will be getting improvement in their sexual problem. The root cause, for example, in psychiatry patients like depression, anxiety disorders, if you treat this is the root cause. If you treat them, obviously the patients start getting desire and desire back and erection back, and even the relationship issues. If you fix it, that will also help, and even the family issues. So root cause, once you find out and you treat that will help to come out of this problem. The iatrogenic sexual dysfunction, I told you, for example, different medications in psychiatry, we prescribe different psychotropics, antipsychotics, and SSRIs for depression, antipsychotic for psychotic disorder. That is because of the mechanism of action itself induces the sexual dysfunction. But when you change the medication, you need to choose the medication very wisely. You need to choose medication which can treat the depression without creating much problem in the depression. So that will also, the iatrogenic sexual dysfunction, that will help. Pharmacotherapies, there are so many medications for different sexual dysfunctions. I'm not going into detail. However, in erectile dysfunction, we use the PDE5 inhibitors, different PDE5 inhibitors available in India. And in premature ejaculation, we use different SSRI, and there are so many other, even tricyclic antidepressant can be given with different dosages. So my favorite is paroxetine in premature ejaculation. So pharmacotherapy definitely helps a lot. And different devices like in case of vaginismus, the dilator therapy, and in case of even vibrators, that helps. Even delayed ejaculation vibrators also help. So that comes under devices, and the psychological methods. So different the CBT and even the sex therapy. If you find that this patient is, this couple is suitable for sex therapy and the CBT, so accordingly you can take the sessions on frequent intervals, and that will definitely going to help to patient to come out of this problem. So that was all about the clinical approach towards male and sexual dysfunctions. I hope I have covered at least important points here. So if any questions, I'm open for that. Thank you very much.
Thank you, Dr. Prashant, for very nice presentation on sexual dysfunction, especially importance of history taking, which is an integral part of psychiatry. You have highlighted very well and short. Thank you very much. Now, I request all the presenters to be online. We are going to have question answer session after all three presentations. Our next topic is very interesting, sleep as medicine, and Colonel Professor Dr. Karuna Datta, who is physician, sleep and sports medicine, FMC Pune. She is going to present on sleep as medicine. Over to you, Dr. Datta.
I'm very thankful for giving me this topic of sleep medicine today, because though we know that sleep and obesity coexist, or lack of sleep and obesity coexist, and OSA and metabolic syndrome coexist, and diabetes is often associated in insomnia patients, but I've come across any CME or workshop where we think about sleep as medicine. So first of all, congratulations and thank you so much. And let's start with how we can think of sleep as medicine. So before I start, let me just take a few slides to describe the sleep as such, and then we'll go on the therapeutic model. So as you know, that states of being we can have non-REM, REM, and wake. And the individual goes through various stages where REM and non-REM are further divided as non-REM into 4 stages, and 3 and 4 stage are actually categorized as N3 according to the ASM criteria. And as the night advances, the REM sleep is covered more, whereas in the initial part of the night, it's the non-REM sleep. And functions of sleep can be protection from metabolic injury, restorative function, hormonal regulation as such. In fact, there are some hormones which are totally dependent on sleep, like hormone. Some are linked to the circadian rhythm and hence related to sleep, because if a person is not sleeping at the right time of day and night, there may be a problem. And some are like associated because they are as such generated because of the hormones which are directly proportional or directly related to sleep. So a whole lot of hormonal homeostasis comes from sleep, and sleep state as such causes an energy consumption reduction by 15%. Also, it's known to have an effect on brain growth during fetal life in childhood, neurogenesis, memory consolidation. Sometimes discharge of emotions has been long ascribed to sleep, and now it's known that sleep and emotions have a bidirectional link, in the sense if I'm not happy, I might have a problem in sleep, and if I am sleeping too much or too less, I might have an emotional derangement. So with this, how much should one sleep and how much should one exercise is always a question on our mind. Rather, I would say, how much of lifestyle interventions. So today, since we're talking about sleep, let's talk about what does sleep actually depend on. So it's about, photo period, that is the seasons, age, quality of sleep. If your sleep quality is bad, you might sleep even for longer hours but not feel refreshed. And how do I know if I'm sleeping fine? Are you fresh when you wake up after sleep in the morning? Do you need a nap at daytime more than 60 minutes to keep you going in the evening? Did anybody tell you that you snore or move abnormally at night? Are common symptoms, are common questions. If you ask your patient, you can get the answer instantaneously. And some other simple questions can be, on an average, how many hours are you able to sleep at night during weekdays and weekends? And here lies the crux, that if there is a difference between the weekdays and weekends, means maybe during the weekdays he's having a sleep debt which he's trying to cover up in the weekends. Also, how many hours do you nap during daytime, during weekdays and weekends? Again, a similar thing. How much time does it take for you to sleep after lying in bed to sleep? So that's a direct kind of a link to your sleep onset latency, subjectively, of course, because the person is telling you here how much has he done. You're not objectifying it. Do you have any sleep breaks? And in case yes, then how many times? And how many times do you wake up? Approximate time that you spend in these sleep breaks can be taken easily from a patient. As compared to the best sleep you've had, what was your quality? I like this question because sometimes when you ask this question, suddenly the patient will look at you and say, yeah, I think it's just 6. Although I was thinking that it's very good, but maybe from the best times that I used to sleep, it's just 6. So that's where he himself, gives you an answer, and you can come to know immediately that he's whether sleeping better or not. This is a self-help book for patients which I have written, available, and this also you can use it for your patients, for them to identify if there is a problem and try to find out their own solutions if they can. What happens when we do not sleep on time, and what happens when we do not sleep the right amount? Both are sleep. There are effects of lack of sleep. The next day, of course, the effects of staying awake at night, like excessive sleepiness in mood, stress hormone will increase, sympathetic drive increases, glucose handling is affected, metabolism is affected, genetic alterations might happen. And that is so evident because so many things that we see now with sleep deprivation is quite can be understood. Effects of loss of sleep depends on various factors like basal sleepiness, amount of sleep restriction. Individual susceptibility here is very important. Then age, as you age, it becomes more. Motivation, because if you are with friends, maybe you will not like to sleep or you will not have those many effects, but motivation can always play an important role. And similarly, if you're not motivated, obviously you will feel worse. posture, and arousal influences. Arousal influences being activity, bright light, caffeine and drugs, and group effect. So if you're in a group, unlikely to have a problem or less problem as compared to when you are alone if there is a loss of sleep. Neurological effects, learning, memory, cognition, even effects on EEG have been reported where microsleep episodes at times, alertness gets affected. And there is this study which has proven that blue light is, so important, where there has been a separate system which has been found out, which is important for the actual perception of light and its control on the circadian rhythm. That's how we to say that this exposure, this amount of blue light exposure is important, or I would say should be reduced before sleep. So how do you know if it's a sleep disorder? Now, common manifestations that you will see is increased sleepiness during daytime, inability to sleep and wanting to sleep, problems in the transitions of REM to non-REM, non-REM to REM, or when person, the sleep quality or quantity may be altered, abnormal behavior, movements in sleep, manifestation due to other comorbid disorders, abnormal anatomy or physiology, and which might lead to some manifestations which have been mentioned above. So monitor sleep using your sensors, which can be only for staging of sleep, or maybe just to record the respiratory effort, flow, snow rate, or a combination of all of these with heart rate, ECG, SpO2, movements in the legs. Of course, video can add on, which will be the best or the gold standard. Now, in front of you is a diagram taken up from my book, which is Making Sense of Sleep Medicine, published. And this just highlights an algorithm which you can decide. Patient comes to you with excessive daytime sleepiness, again, a very, very common symptom. And so let's say there's a patient who comes with excessive daytime sleepiness. You divide into two, ask for history whether nighttime sleep duration is reduced or normal. And then, you can think of an algorithm. So if the nighttime sleep duration is reduced, then maybe it's bad sleep hygiene, which you should work on. We all know the hygiene principles, sleep hygiene principles. So you must tell them. I've written them down too. Or it may be sleep deprivation, that you are not enough opportunity to sleep. Some external factors which may be causing a person to not sleep properly. But when there is a normal nighttime sleep duration, that's the time when there's a worry, because either it is a disorder which is disruptive sleep, like obstructive sleep apnea, the central type, periodic limb movement, even mixed sleep apnea, periodic limb movement disorder, parasomnias, epilepsies, GERD, endocrinology disorders, respiratory disorders, substance abuse, cardiovascular disorder, or it may be something like disorders with increased sleepiness otherwise. So you can have a stroke, neurological, narcolepsy, and this is where cardiovascular disorders and some psychiatric disorders and endocrine disorders also come. So what is actually happening here is that there are some common sleep disorders which you often see. And I'm not going to go into the detail of it, but maybe just take insomnia in OSA, where insomnia is adequate sleep opportunity. Patient is giving adequate sleep opportunity, but then is not able to sleep, and there's a day function. And remember the 3 rule for chronic insomnia, that is 3 times a week he's having a problem at least, and for 3 months. Differentiated from insufficient sleep syndrome, which is a sleep deprivation, where a person is not giving himself adequate opportunity to sleep. This is predominant, typically, and what in these cases you want to do is basically counsel them, help them out. But insomnia, you'll have to think of how to get rid of insomnia. Obstructive sleep apnea, where so many comorbidities apart from diabetes are very, very common. And we all know that the problem also may be related to obesity, where fat has deposited around the neck, and intra-abdominal fat, which may be pressing on the diaphragm. Because as you know, the neuronal control of the genioglossus muscles and the intercostals in the diaphragm reduces from awake to REM to non-REM to REM. So in awake, it is the best. So the airway passage is most available. And slowly it reduces, and in REM, it's the most compromised. And you might find REM onset OSA in many people. Diagnostic criteria as per the International Classification of Sleep Disorders is presence of one or more of the following, that is sleepiness, non-restorative sleep, fatigue, insomnia symptoms, waking with breath holding, gasping or choking, pet partner or observer reports habitual snoring, breathing interruptions, or both during the patient's sleep. Patient diagnosed with hypertension, mood disorder, cognitive dysfunction, coronary artery disease, stroke, congestive heart failure, atrial fibrillation, or type 2 diabetes mellitus. And B, which when you do a polysomnography, you find 5 or more obstructive respiratory events or respiratory effort-related arousals. And another criteria can be that if on polysomnography you get 15 or more, then you don't have to have one. The C, 1A is not, the A is not important, that C is good enough. So it's either A and B or C, with which you can diagnose OSA. And why we're talking about OSA here is because this hypoxia, which the OSA causes a disruption in the sympathetic drive, because of which the glucose dysregulation happens, leads to insulin resistance. And if you see both the sides of the balance, if all the endocrinal, the food intake, the glucose tolerance, and the hormonal changes, everything gets disrupted. And finally, what you get is a glucose disrupted state, which is as it is happening with OSA. And the OSA leading to hypoxia. Also, the OSA now causing a lack of sleep because the quality of sleep is not good. And again, that is a vicious cycle. So what are the self-help measures? Now, how do I use sleep as a medicine? First of all, I should find out whether there is a problem. So these are the questions which I just said before. You can ask your patient. You can find out some common disorders if the patient is suffering from. You can differentiate between insufficient sleep syndrome and chronic insomnia, OSA, parasomnia. You can find out what's the reason for that unfreshness, or patient is not fresh when he wakes up in the morning, or he's not feeling, as if he slept well. So now you can have some self-help measures, and that's where that book really helps the patient, that if he's able to do it on his own. But in that book, I've also written some red flag signs where he should reach out to a doctor. So self-help measures should not be that you just keep on doing it at your home and you don't reach out. So it's very important. And that's where sleep diary helps, and relaxing yourself, doing mindfulness meditation. I've made a video on declutter your mind. It's basically a progressive muscular relaxation technique, which is a video. We'll put the YouTube link to. And specific problem, if there is, if you have a cardiovascular disorder or any other causative or causative disorder which may be along with the conditions that needs to be addressed, like GRD, or like even for that matter hypothyroidism at times, sometimes craniofacial abnormalities for OSA has to be addressed. This is how a sleep diary looks like. You have to fill it up 2 times a day. 1 to 8 is filled up just before sleeping. So you're writing about your daytime routine, where you write about exercise, naps, alcohol, if you took tea and coffee, feelings of the day, food and drink, medications or sleep aids, and bedtime. And the second part you write when you bedtime, waking up time spent in bed initially, trying to sleep after lying down. So that's your sleep onset latency. Sleep breaks, the number, and what variation probably, the quality of sleep, and other comments, and overall rating of your sleep out of 10, which I mentioned earlier, how it's very important. And finally, you take out the sleep hours by finding out the time between the wake up time and the bed time, and remove your sleep onset latency and the sleep breaks duration. The sleep breaks will contribute to the VASO, which is wake after or sleep onset. And now you find the total sleep hours. Now, it's important to actually have kind of a instruction given to the patient that the patient should not be seeing a watch. All this is to be done by a subjective idea that the patient has of his sleep. That's very important, because especially in an insomnia patient, he will be so stressed out about not able to sleep that he will actually not be able to sleep for the rest of the night also. So please make it a point that you tell them that write this down without your watch. Just note down the bedtime and then do not watch the watch unless you get up in the morning. There was this, actually my PhD was on non-pharmacological approach to insomnia, and there I used Yog Nidra, and I have put the YouTube links here. And actually when I had done some trials using non-pharmacological approach where I used progressive muscular relaxation and Yog Nidra. And also I tried to find out as a scientist in me that what happens to Yog Nidra during the practice. So this is an article if people who are interested. Then this is the model which I wanted to share with you, so that if you want to do Yog Nidra for these people using the video, please follow the approach for management of chronic insomnia model, because you tell the patient to Yog Nidra, they are not interested. They will not be able to do it. But you should know the nuances. You should know how to do it, how the patient should be able to do it. And that's all there in my video, all these instructions, everything, because in COVID times, we had to do it online. So you can just check that out. And the link is also there in the book if you happen to see it. And in the end, I would like to say that if there are any any burden that you have that you're not able to follow, this is a easy to read book, more so because it's meant for the primary care physician. So of course, as a specialist, you will really benefit from it. It is somebody who's not a sleep expert, so anybody will benefit from it. And all the best and take care.
So is Dr. Nagapurkar there? Yeah.
Yes, yes, yes.
Yeah.
Thank you,
Do
Dr.
we have any
for-
questions for the speakers? Dr. Karuna Datta has given an excellent talk. So, Amol, do we have any questions from the audience?
No, ma'am.
Okay, so I had a question to Dr. Karuna Datta, if she's there in the audience, in the platform.
Yes, I'm there.
Yeah, okay. Ma'am, we have a lot of menopausal women who have a lot of sleep disturbances due to various reasons, hot flushes and sudden change in sleep pattern. Do you think that these patients or these normal subjects need sleep therapy as such from a sleep medicine perspective, or do they need to follow the practices that you have described, or what would your suggestion be for this population?
As you said that they are having a problem. So if the problem is more than 20 minutes, they're not able to sleep, it categorizes not as normal, but as a disorder again. So like as I told you, the 3 rule. So if they are a frank disorder, they require help. And in case it's just that it's coming intermittently, it's not 3 times a week as per the criteria, but sometimes it happens, sometimes it doesn't happen. Any kind of non-pharmacological approach will help them. So I think the first thing would be to write a sleep diary, because not only does it help the clinician to find out the problem, but it also helps an educated people to understand themselves. Sometimes, some meal time or some exercise too close to bedtime is just making it more aggressive. So that is one. And second is any kind of a non-pharmacological approach which they are able to do. Like I have mentioned some YouTube video links also, that would help. But in case it doesn't help by self and it still continues, it's better to reach out.
Okay, thank you so much, ma'am.
Thank you.
Any other questions from the faculty or the audience for the speakers? Dr. Nagapurkar, you have any queries, questions?
No, no, no.
Okay.
Thank you. I think it was a beautiful deliberation.
Patwardhan sir has
And
something.
thank you so much.
Yeah.
Vaishali, this was very good session. And I want to ask Prashant as to what is the definition of hypersexuality. He has told about hypoactive sexuality. What is criteria to say hypersexuality? Is he here?
Dr. Baspure, is you here? Yeah, he's there. He's muted. So probably Dr. Nagapurkar can answer that if at all from a psychiatric perspective.
Yes, hypersexuality, it can be there as a normal, and in case of some central disorders, basically related to hormone or CNS pathologies, patient can become hypersexual. So hypersexuality is very difficult to define as such, but because what are the norms, they are very difficult to define. It differs individually. So when there is excessive, I think it is regard with the partner, and if the sexual desire is much more than usual, then we can call it as hypersexuality as such.
So I had a question for Leena, madam. What is the applicability of autonomic studies in a clinician's practice? If she's there here, I would like to get to know as a clinician, what is the importance of doing autonomic and identifying the allostatic markers?
Madam, as I have mentioned that the HRV has all the utilities, right from diagnostics to screening to prognostic marker to the predictive marker. So all kind of information is possible to get from the HRV. Like HRV cart is recommended by ADA itself. American Diabetic Association has given recommendation that at least in type 2 diabetes, for assessment of neuropathy should be done. Cardiac autonomic neuropathy should be started as soon as the person is diagnosed with type 2 diabetes and once a year then. So it is for the neuropathy purpose. But to have an idea about the autonomic dysfunction, because dysfunction precedes the disease also. So in the preclinical condition also, you can have an autonomic dysfunction. So HRV is a very good marker to measure that autonomic dysfunction in that stage. Because like GTT gives you an idea about the glucose tolerance, the HRV can give you idea about the autonomic tolerance or how the autonomic dysfunction is there, how much is the dysfunction that is there. So definitely it helps a lot. And of course, then as we have done the studies and what we have seen is that in different diabetic patients, with depending upon the duration and the control of diabetes, if you find that HRV is reduced below certain cutoffs, which we have observed, so these are definitive markers for sending a patient for the CAD referrals. Because sometimes the patient is not having any kind of symptoms, so whether to send this subject for stress test or not, the clinician has a dilemma about it. So, but if you find that with this non-invasive test, if you find that HRV is reduced too much, and even if the patient is not having any clinical symptom of cardiovascular coronary artery disease, then this is the right patient to recommend for the evaluation of coronary artery disease. Because see, if we are able to preserve the heart, I think that is what the prevention is. So if the person is having a clinical symptom, that means already the muscle is damaged. So if we are able to pick up the individual earlier before the damage to the heart, then I think it will be of very, very useful for the clinicians also to recommend their patients for at the appropriate time for coronary artery referrals or even for any microvascular complications.
I think this whole session was a very enlightening session, and I thank all the three speakers. And yes, sir. Yes, sir.
I would like to add to Umesh's answer.
Yes.
Regarding hypersexuality.
Yes.
So as he rightly said, the increased desire, but where commonly we see it, there are some psychiatric disorders like, say, for example, mania, wherein the desire is quite higher and chances of promiscuity are there. So the complications. Some organic disorders, again, dealt with either neurologist or psychiatrist. Early in dementia also, the desire is increased. There is one syndrome called as John Doan syndrome, wherein they have hypersexuality. So the desire is definitely more than usual. Actually, normal desire you cannot define. For that purpose, normality itself cannot be defined. But definitely it is more than an average. So these are the three listed conditions in literature. Thank you.
There's one question for Dr. Karuna Datta in the chat box. What is the validity of ambulatory polysomnography?
Yeah, so that's a good question. Now, see, an ambulatory polysomnography can be done at any level. So, if the level is just including the respiratory sensor and just the heart rate monitoring ECG or something like that, then I don't think that's a valid study. It may be good for screening. But the gold standard of a polysomnography, if it is being followed without a video polysomnography, also can be considered for diagnostics. Like, for example, I have seen patients where, let's say, they feel claustrophobic in a lab. Now, in such kind of a case, or they are aged and they are more comfortable at home, in such kind of a case, if you're able to put up the entire montage, that is for scoring of sleep, EEG, EOG, EMG, and for other physiology of sleep, that, like I mentioned, that you have your snoring sensor, your chest leads, your limb sensor, and your SpO2, and you do the entire montage as per the ASM criteria, that may be good enough. So it depends at what level you are doing and what is the indication. But if, I have seen technicians sometimes just putting a snoring sensor and a respiratory thing and saying polysomnography is over. That is wrong because you can't stage. Or if you have not put the entire EEG, EOG, EMG along with the entire other things, then you will not be able to pick up what is the cause. You will probably just find snoring happening or whatever the problem is. So I think it should be done as per the ASM criteria if it's for diagnostics.
Mhm.
And if you have a special case where you can't do a video, then maybe you can allow without the video, but use the full montage preferably.
Thank you, ma'am. I think that
Extend
answers
it.
the questions.
In
Yeah.
fact, I would say extend it. If you're suspecting a seizure or a nocturnal seizure, extend it using an extended video PSG, where you can even have more channels, because the entire night of the patient is being recorded, and if you're not able to find out the exact cause or the effect, it's not right for the patient.
Thank you so much. And thank you, Dr. Nagapurkar, for that excellent moderation. And in spite of his busy schedule, he could make time to be in this session. And thank you, IPS, for being a partner to this program too. So now I hand over to my co-organizing chairperson, Dr. Arun Barwale, sir, for the further conduction of the session. So to introduce Dr. Arun Barwale, sir, can I have a CV slide, please? Yeah, so sir is professor in psychiatry at MGM Medical College and Hospital, Aurangabad. He is the vice president, come president-elect for IPS West Zone in 2022. Then he is the member of Board of Studies of Medicine and Allied Subject in MGM IHS. He's an ex-honorary treasurer of the IPS. He's the ex-member of the Board of Studies of Psychology, Aurangabad, organizing chairman of PGCME West Zone, Aurangabad, the organizing chairman of NCYP Aurangabad, and organizing secretary of Midterm National CME. And he's been very proactive in organizing Synapse with us and with Niemans Bangalore too. So over to you, sir.
Thank you, Vaishali ma'am, for giving this opportunity, for moderating this session of Synapse 2023. Am I audible? Hello.
Yes, you are audible.
Yes, sir, you are audible.
So this session is basically inaugural session as well as a message from our very senior director, ex-director of TIMHANS and presently chairperson of NMC, Dr. B.N. Gangadhar sir. Actually, Synapse is this is the fourth year we are conducting under guidance of Vaishali and her team. And the very first was a big success, which was in physical form. Because of Corona, 1 year we could not do that. But later, consecutive, this is the third year we are able to manage Synapse. So this year, she has given very nice topics. So let us have introduction of Dr. B.N. It is not necessary actually. He is known to almost all of us, but still, as a formality, I would like to say a few words about him. He is President of National Medical Commission of NMC, New Delhi. He is former director and senior professor of National Institute of Mental Health and Neurosciences, that is NIMHANS, Bengaluru. He is honored by the President of India in 2020 with Padma Shri for the contribution to the mental health sciences. He is fellow of Indian Academy of Medical Sciences, Indian Academy of Sciences, and Royal College of Physicians, Edinburgh. He is member of International Brain Research Organization, BRO, globally renowned researcher in neuromodulation interventions, served on the editor board of several international journals. He pioneered the neurobiology of yoga research, further father figure of integrative medicine of India, and patron of mind body medicine. Basically, he has started this integrative medicine in NIMHANS, Bangalore. It's a separate department now. One of our speakers is now HOD of that department. So let me have the first slide, please. CV slide. Hello. Oh, yes. So let me hand over this to our respected B.N. Gangadhar sir.
So should we have the lamp lighting before we start with sir's address?
Yeah.
Yes.
So I request all the dignitaries to be there for lamp lighting, particularly B.N. Gangadhar sir, Vaishali, and other team.
I would request Dr. Shashank Joshi sir, who is our orator for today. Then Dr. Patwardhan sir, who is the Maharashtra Endocrine Society President. Dr. Sanjay Phadke, CBM President. Dr. Chetan Deshmukh, Sphere President, and all the other dignitaries, including the faculties, to open up their screen and be present on screen for the lamp lighting. So welcome to all of you, and we are honored to have you all. Dr. Gangadhar had prior commitments, so he could not be here. So he had a nice half-an-hour recording of his done yesterday with us. And I'm thankful to Dr. Gangadhar sir for his time spent and mentoring our whole group. So Darshan, can we have the lamp lighting to begin with? Thank you so much. And you can now start with sir's message, Dr. Gangadhar sir's message.
the outset, let me thank the organizers of this symposium, Synapse, on mind-body medicine, for inviting me to be in the either inauguration or one of the meetings to share my thoughts on this subject. I understand this is the 4th meeting. Heartiest congratulations on this event. We just had Sri Ramanavami with the blessings of Sri Lord Rama. Let me start to share some of my viewpoints on this issue. The growth of medical science has made an impressive impact on the overall health of the community. We have efficiently curtailed many of the infectious disorders, although 1 or 2 of them continue to haunt us, hoping that with the drive that has been put on tuberculosis, by the coming 2 years, we would have contained it. A few other viral diseases, and recently what we went through, the COVID, will perhaps haunt us now and then, although our machinery is very efficient to contain these disorders. So that's it about the infectious disorders where we have made a great impact. We have had the best network of what we call as the primary health centers and health services at the primary care to be able to reach out to everyone at the earliest and contain the disease progression. Early intervention has been possible, although we have a lot of scope to improve upon it, but we have moved from a grade 0 level before the independence to phenomenal heights in terms of providing healthcare services. Multiple health insurances have come up at state level and at the center level. The recent one by the center, the Ayushman Bharat scheme, is something that is going to make it will be a game changer in terms of providing healthcare and containing the costs from one's pocket with respect to acute illnesses which he will or she will reach for treatment at the hospitals. Containing the infectious diseases, reaching out to early intervention, but yet there is a big chunk of diseases which have cropped up in the last maybe couple of decades. What we have been talking about, the non-communicable diseases, which is something that I would say the bread and butter of most of the physicians, psychiatrists, and a few other groups of people, specialists, where we have to handle many of these conditions, the metabolic disorders, psychiatric disorders, cancer, and of course, susceptibility to infection, and most importantly, age-related disease conditions of the nervous system. These, as you know, that the longevity has increased, and correspondingly, the age-related, not just the brain disease, many other physical diseases also are going to be seen more often. I'm not saying that old age is a burden, but nonetheless, the change of demography, we should also be prepared for a different case series, case scenarios, or health conditions that we perhaps have to handle. So in this background, the recent move by the Government of India Health Department to make a shift from illness to wellness. The wellness centers which have been launched by the Union Health Department, close to about 1.5 lakhs have been situated at different places all over the country, where while treatment of the disease itself is not the focus, although some first aid, of course, is available there, but most importantly, promoting wellness and, of course, continued care of many of the other conditions are the responsibilities which would happen at the wellness centers. So the very word wellness centers is a shift from what we may call as a clinic to hospital, hospital to just a health center, the primary health center, what we used to call it, and now the wellness center. So this wellness is well above that of normal health. That has to be promoted. So promotion of health is the ultimate. When health is promoted by whatever it be the means that we adopt to, health promotion would perhaps lead to reduction of disease burden. So with this concept, the health wellness centers have come up. So the movement from illness to wellness is something that we need to keep in mind. In this process, we have also realized that the non-communicable disorders have origin in the psychosomatic domain. In other words, a great deal of contribution from our psychological conditions have an impact on either the genesis of these conditions or its progression or worsening as well. While there are, of course, a host of other environmental lifestyle factors that operate, but the behavior of the lifestyle and the very emotional state that we reach out, both these things, the behavior is under our own control and the emotional state may be or may not be under our control at some points of time. These contribute substantially to the contribution and worsening of these non-communicable disorders, which we are now seeing as a national, perhaps silent epidemic. I keep hearing sometimes that we could soon become the world's capital for diabetes. We could well be very high in terms of suicide rates in the country. And mental disorders, we are no lesser than many of the other international countries, populations, where we also contribute to some, with the very huge number of our population, mental disorders come into a very important size, which we have to handle. So put together, this spectrum of psychosomatic conditions would be a focus of attention to general physicians, primary care doctors, psychiatrists, endocrinologists, and a host of other medical specialists who will have to be called upon to attend to this, including pediatricians for that matter. So we have a wide spectrum of clinical clinicians who will be called upon to manage these conditions. So in this process, how does promoting wellness have an impact on this spectrum of psychosomatic conditions? I can illustrate by virtue of being a psychiatrist, I can illustrate some of the biological examples of how the mental state can have impact on the physical health. I'm sure many of us would have read it during our MBBS days. Older amongst us would have read it as psychosomatic disorders, and newer amongst us would be talking of stress-related mind-body diseases, metabolic syndromes, and so on and so forth. So a wide range of these conditions which have had a root in our mental state required to be managed by way of whatever we think is an evidence-based effective lifestyle intervention. In fact, lifestyle medicine has been a fad these days. Many centers running lifestyle medicine courses, diplomas, certificate courses, and some boards are also giving this recognition to these courses, if not in our country, elsewhere. And so the lifestyle medicine is something that has cropped up in the recent years. So also the mind-body medicine that has cropped up, and there are societies handling these two conditions, although they're not very much different on two different labels. People talk about how to impact health, promote wellness using approaches which are, as they claim, evidence-based approaches in lifestyle management and, of course, in improving our psychological status. So having said this, let me illustrate how there is a biological evidence that stress has a place in causing or contributing to the non-communicable disorders, and how some interventions can actually not just reverse the psychological condition, but also in quotes, correct the underlying pathophysiological status that has been caused either by the psychological situation or be the cause themselves for the psychological condition. I don't want to differentiate that issue. That is a different argument altogether. But what remains to be understood is a biological correction is also possible by some of the interventions. You have heard of many of the long-term studies which have talked about lifestyle intervention, improving coronary heart disease, preventing them, making their outcome better, talking about yoga in hypertension, meditation in hypertension has been discussed. And recently we saw a diabetes-free India, and we had a series of national level trials on yoga in diabetes, showing substantial benefit of practicing yoga in terms of improving diabetes, reversing diabetes. Just today, I had an opportunity to visit a friend for a lunch, and they were describing, family was describing to me, somebody who had a hepatic fatty liver was able to manage his diet and some discipline. The reversal of process is happening as demonstrated by some of the investigations. So much so, a very senior physician handling liver diseases was surprised as to how, without any treatment, this reversal has been made possible. And it was explained to him, apparently, by the person who was affected, that a lifestyle management discipline and keeping a diet which is totally different, which is tailored to improve this condition. So we have had interventions that are possible, pronounced, made available in the public domain, in publications, evidences has been built. What I will probably share is something to do with depression, where again biological changes happen which are not healthy to one's, which are not good for one's health. Take, for example, depression. Depression is a condition which you will see very commonly. It is an ubiquitous condition, affects from children, adolescents, middle-aged people to older age people, although it is commoner in older people. And there are several other causes for depression. I'm not going into those things. But what typically happens in depression, depression is a form of a mental stress. Of course, mental stress also can cause depression by way of many societal changes, interpersonal stress, financial stresses, job stresses, education, and a host of those things can also contribute to depression. But depression itself is also a stress. Feeling continuously low, not being cheerful, not able to enjoy life, having a very low self-esteem, and not able to finish tasks because of this low self-esteem and slowness in the mind. All put together, the stress accumulates. And we know one of the common stress physiology is the release of cortisol. And this release of cortisol happens in depression and quite well demonstrated, and is also resistant to suppression by oral dexamethasone. In fact, oral dexamethasone suppression test was almost had almost become a diagnostic test, although the sensitivity and specificity continued to be discussed. What remains to be understood is the levels of cortisol increase and remain elevated for a long time in depressed individuals because it is a chronic stress. Unlike acute stress, where also, of course, cortisol levels can go, but it will soon return with the individual getting back to normal condition. But continued stress of a depressed individual for a long numbers of days elevates cortisol, and a cortisol has it starts a cascade of events. One of them is its effect on release of what we call as the brain-derived neurotropic factors. On one hand, second thing is directly affecting the glucocorticoid receptors, particularly in regions which are very sensitive to memory, hippocampus, and such areas, where by virtue of the glucocorticoid receptor agonist activity of this cortisol, there are some neuronal damage that also happens. Neuronal repair is prevented by way of the brain-derived neurotropic factor release being stopped or reduced or attenuated by way of increase of cortisol. And we know that in depressed individual, the repair mechanism suffers because of low levels of brain-derived neurotropic factor. Multiple studies have demonstrated low levels of brain-derived neurotropic factors in depression, which gets corrected after the depression gets better, if not totally, and that people who have a treated condition versus healthy subjects, the differences get very much narrow. We also found that this condition of low BDNF, increased cortisol, has another effect, as I said, the direct brain damage. And people have shown elsewhere that chronically depressed individuals have loss of gray matter, and which is typically what we keep hearing in our earlier Subhashitas, Chita Dahati Nirjeevam, Chinta Dahati Jeevanam. So you're continuously stressed. These cycle of events contribute to your own loss of some very important critical neuronal cells, the gray matter, and in turn you go on to become diseased with respect to brain. Your memory functions come down, and with chronically depressed individual, one could even end up with significant cognitive dysfunction as well. So this cycle of events have to be reversed. We, of course, treat depression. As I said, the treatment of depression, cortisol drops in some people, if not consistently demonstrated. The brain-derived neurotropic factor increases. Have people shown whether there is also recovery in terms of gray matter loss? I'm not aware of such studies yet. So antidepressant drugs work. We also had an opportunity to offer people yoga as a treatment for depression. Very interestingly, yoga also produced reductions in depressive symptoms leading to remission. At the same time, the blood levels of cortisol also came down in depression, and corresponding increases in brain-derived neurotropic factor also happened. In fact, there was a good association in those people who lost cortisol. The brain-derived neurotropic factor levels was actually higher at the end of a 4-week intervention with yoga alone in depressed individuals, and they remitted as well. Although I wouldn't say it is a demonstration in a randomized clinical trial as one may seek at this point of time, there is a effect of this. We also were able to demonstrate yoga practices prevent age-related loss of gray matter, particularly in the hippocampus. So one of the intervention, which is a lifestyle intervention, yoga, which in the studies which I mentioned, use the yogasana and the pranayama, was able to demonstrate not just the clinical reductions in the stress level, one of them demonstrated by reduction in the depression scores, but also a biological correction with respect to reduction in cortisol, increase in the brain-derived neurotropic factor, and in other individuals, of elderly individuals, improving the gray matter loss. In other words, attenuating the gray matter loss, but also perhaps increasing the size of the hippocampus. So there have been studies which have accumulated over this period demonstrating the effects of yoga on several other biological parameters which are conducive to health in this spectrum of conditions which I talked about. Some of the examples include it improves the GABAergic transmission in the brain, it increases the heart rate variability. All these things have a contribution to different systems of our body, which will promote healthy or promote wellness. So given this scenario, one of the lifestyle introductions in mind-body medicine could be yoga. Not just yoga, asana and pranayama as these studies I mentioned. There could well be the yoga lifestyle, which includes the yama and the niyama, the don'ts in our life and the do's in our life. If we can put these things together and add it and blend it with the Ayurvedic concepts of our diet, which is related to different seasons in the year, and not just different seasons in a year, depending upon one's nature, which is called as the prakriti. With that, if you can blend you can create a cocktail of lifestyle which has yoga, perhaps in addition some more of dhyana, not just yogasana and pranayama, and a yogic other behavioral lifestyle which includes the yama and niyama, and together with the physical lifestyle which is recommended in the traditional Ayurvedic literature of the food in sync with the nature outside and the nature inside, you will perhaps achieve a more holistic transformation of a lifestyle which would contribute to promoting wellness, and this could well have had an impact on these spectrum of non-communicable disorders. Research is going on. We have to build evidence. We have to build evidence for a long-term cohort studies as well, which at this point of time are lacking. And here we are in this symposium. There could well be many younger faculty, younger postgraduate students, much younger doctors who could perhaps take this initiative and take it forward in your workplace and be able to develop and synthesize this idea into a long-term research design. In fact, from the National Medical Commission, as you may have seen, one of the regulations of the internship, we have facilitated one of the Ayush subjects that could also be taken up by MBBS students during the internship as an elective subject. Which means we are legitimizing some exposure during our formal internship period to these interventions that could well be from the Ayush, either yoga or Ayurveda or whatever that is available in that given hospital, given institution, given medical college. So with this change that is happening, and with the Yoga Day having made yoga far more acceptable than what it was, the mind-body medicine and the traditional interventions of yoga and Ayurveda cannot be separated, and it has to be blended. And these conditions, these interventions, which may not involve medicine or what we may call as herbal products, which they have to take it for disease. Without these things, making a change in lifestyle, it is possible with one's own self-control and one's own getting empowered into practicing this. So the community at large is going to benefit from improving their wellness, and in turn, a better mind-body harmony, and so fewer mind-body disorders. And one of the preventive strategies in the mind-body medicine is achievable using these traditional interventions. So I wish all the participants good luck. I wish also the organizers all success in this symposium. And once again, let me thank each one of the organizers for inviting me to participate in this fourth symposium on mind-body medicine. Thank you very much and wish you all the best.
Thank you, sir. Thank you very much for the insightful message on particularly on chronic stress causing changes in neurohumoral response, raising cortisol and reducing BDNF, and that's how causing the mental illnesses. Thank you very much for that. After this, I hand over the mic to Dr. Vaishali.
Thank you, Dr. Marwai sir, and thank you, Dr. Gangadhar sir, for always being a guiding mentor for us. And we could come to this stage with his guidance and with his help. And I'm sure that we have still many more things to learn. Now we come to the V.A. Lokhandwala oration. Dr. V.A. Lokhandwala sir has been my medicine guide. And he's been my teacher, and he is one of the reasons why I am into mind-body medicine. So I welcome you all to this oration. And it was started last year in his memory when we lost him in the COVID period. His full name was Dr. Wajiuddin Abdul Hussain Lokhandwala sir, born in 20th August 1943. Sir was a double MD of his time. He was MD in chest medicine and MD in internal medicine from BJMC Pune. He functioned as a teacher from 1969, beginning as a lecturer and retiring as a professor and head of unit in 2004 at BJMC. An astute teacher, a very grounded person who believed in simple living, high thinking. During his career, he has mentored 75 students from all over the world who are eminent doctors in various roles worldwide. He was a person with great foresight, vision, and guided all of us to be the best, whether it is studies, profession, or business. He always believed that being content, achieving peace of mind, then loving every soul who entrusted in him as a doctor was more important to a doctor than materialistic gains and perks of being a doctor. He had special empathy towards economically weaker class of patients and treated most of them free of cost and earned a lot of goodwill and blessings from them. He was a deeply spiritual person, a man of strong mind and faith. He led a minimalistic lifestyle and always nurtured humility, simplicity, mental peace, service to humanity, punctuality, and self-discipline. A doctor of great acumen who could diagnose DKA or lung abscess just with a sheer sense of smell or probably a sixth sense. Even with his small build and height, he would sustain prolonged Ramzan fast for nearly 90 days at a stretch without hampering his routine work. A God-fearing and complete human, believing in positivity of mind and health and physical fitness, all imbibed into his students, and the root of mind-body medicine lies with him. We shall always remain in gratitude towards you, sir, and your noble family. So when we decided that who should we select for this oration this year, we remembered that last year we had started this legacy with Sarita Bajaj madam, who is a woman of substance in endocrinology and who would be succeeded by none other than Dr. Shashank Joshi. He would be the only successor who is a man of equal great caliber and you can say a man of substance. And Padma Shri Professor Dr. Shashank Joshi sir, we welcome you here for the oration. We know that he has a strong resemblance with what I spoke of Dr. V.A. Lokhandwala sir, and an astute physician, endocrinologist, an excellent orator, an all-rounder, a get-to-go person, a great, still very humble and simple, still very profound in his knowledge and very true and pure at heart. So I believe that words fall short to describe him, and it is very difficult for any person to gauge his greatness. He has been a guiding inspiration to everyone in endocrinology, and not only in endocrinology, in practice as physicians, as students, and he continues to do so to so many. So just to have a formal introduction, this is a slide which we have put up. Padma Shri Professor Dr. Shashank Joshi is MD DM in endocrinologist. He's the fellow of American College of Physicians and Royal College of Physicians. He's also a part of the American Association of Clinical Endocrinology. He belongs to the Department of Diabetology and Endocrinology at Lilavati Hospital Research Center, Mumbai. He's the president of two important organizations, the Indian Academy of Diabetes and the Endocrine Society of India. He's the former president of the Association of Physicians of India. He's the RSSDI and the All India Association of Advancing Research in Obesity. He is involved with the activities of ACE. He's serving as chairperson of its India chapter. He's a recipient of International Clinician Award received at 21st American Association of Clinical Endocrinologists. Senior editor of Endocrine Connection, delivered more than 200 oration. He's the receiver of the Padma Shri, and he's been very active in the COVID times. He has been one of the forefronts in Maharashtra COVID task force, and we look upon him as our esteemed mentor and guide. And when we started this MBM group, I remember on Telegram he had a lot of intellectual text which used to be posted, and I have people in the group who have still saved those posts and they have been benefited with his wisdom and wit. So today it is my pleasure to present Dr. Shashank Joshi sir with the prestigious Dr. V.A. Lokhandwala oration. Over to you, sir. So I think sir is live, if he can come up, or we start the presentation which he has recorded.
So, Vaishali, you can start the presentation. I'm grateful to you and the organizers for feeling me worthy enough for this talk. And I'm recorded my talk for 26 minutes, after which we can have a dialogue or a discussion. Thank you so much.
Yeah, thank you, sir. So, Darshan, can you just play sir's recording?
So, at the onset, let me thank the organizers of Mind Body Medicine. And I'm really going to talk on subject of impact of lifestyle, gut microbiome, ancient wisdom and modern medicine. I don't have any conflict of interest for this talk. I anticipate what you listen to me, you will learn, and what you learn, you will adapt. My talk is divided into multiple components, and it is a cross-section of lifestyle medicine. So first thing which we learned, as we have seen in the post-pandemic times, is rebooting life and building resilience. And I'm going to talk a little bit on that. Then I'm going to talk on biological clocks, chronomedicine, sleep and lifestyle. Then I'm going to switch gears into gut microbiome, how gut health is at the center stage back. Maybe a few lifestyle mantras, including Surya Namaskar and Gayatri Mantra, and maybe one or two take-home messages. So that's the overarching theme of my talk. So we all need to reboot our lifestyle. Clearly, refresh by reconnecting, connect with yourself, and we have a lot of reboot priorities, and we really need to reboot and reconnect. We also need to be emotionally agile, because when we reboot, we forget emotions, and we know that life is very fragile, but it's also very beautiful. So remember, beauty and fragility go hand in hand. And it's important to recognize the need for hope, because ultimately we all live on hope. And it's very crucial and critical that we never forget hope in our paradigm, in our prescription, in our mantras. And it's important to recognize that we all live with hope, and hope is the center stage of the universe. But we are always in a storm. And the best example to negotiate a storm I give, whether it is disease, whether it is external storms, whether it's body storms, mind storms, every storm has energies. Now remember, how does an eagle, they use a negative energy of a storm to fly even higher. And I think that's a big motivation for all of us. Simultaneously, we are all warriors. We are trying to, the fate will tell you, we always blame it to fate and we blame it to destiny. And fate whispers to the warrior that you can't withstand this storm. And the warrior says with a whisper that I am the storm. So that's how one needs to really negotiate storms and bravely face them. I'm a hormone specialist. I'm an endocrinologist. And obviously, we have endocrinology closely intertwined with our metabolic clocks, hormone clocks in every cell. But in endocrine biology, we clearly recognize the role of circadian rhythm. And we clearly recognize the role of the endocrine system, the peptides and the steroids when we look into our biological clock. And when you look at the human circadian biological clock, we know that our best coordination is 2:30. Fastest reaction time is at around 3:30. 5 o'clock, which is prime time, has the best cardiovascular efficiency and muscle strength. Highest blood pressure is 6:30 in the evening. Highest body temperature is 7 o'clock in the evening. And around 9 o'clock, our melatonin secretions kicks in. And deepest sleep is 2 o'clock. Lowest body temperature is 4:30 in the morning. And then you get that rapid blood pressure surge early morning. And then, of course, melatonin secretion stops by around 7:30. And then, of course, we have the highest testosterone secretion, cortisol secretion at 8 o'clock in the morning when you are alert and fine. So sleep is a crucial component. That if you sleep less, the tissue perfusion by CSF, if you are awake all the time, there is reduced interstitial space. There is restricted CSF flow and the metabolites accumulate all the time. So clearly the sleep is the housekeeper of the brain, and recognizing that you need to sleep adequately is very crucial, because if we restrict and sleep less than 5 hours, our human transcriptome is getting restricted and you will downregulate and cause disease biology. So sleeping too much or sleeping too less is not good for human health and will lead to diseases, including cancers. And we have studied this from our ancient wisdom. We have learned that light and life, with moonrise to sunset and sunrise to moonset, we clearly recognize it from our ancient wisdom. And our ancient wisdom clearly recognizes that the course of time is understood through the changes brought about, whether they are the rays of the sun or the moonlight. And that's really the chronobiological clock, which is engraved and ingrained in all ancient wisdom and ancient literature. Blood pressure is the most classical example of circadian rhythms. We all know the evening blood pressure rise. We know that when you sleep, there is a nocturnal dip. And then we know that there's a pre-awake surge and there's a morning surge, which is very well recognized. So as I told you, that our circadian rhythm or biological clock is a basic quality of human physiology. And in healthy humans, heart rate, blood pressure are the best examples, which increase during the day and decrease during the night. And the sleep, wake, rest, exercise changes clearly recognize that. So is cardiac output, so is catecholamines, which rise during the day and fall at night. And various organisms, including human beings, need to adapt to the higher activities when they are up. The most classic example was the intra-arterial monitoring by Milliard-Clark, which is a very old experiment which showed the BP is lowest at night, the nocturnal dip, and rises before awakening, the morning surge. And we all know that when there are cardiovascular events which are crucial, there is absence of nocturnal fall of blood pressure, the non-dippers, the early morning blood pressure surge, which is why you get acute cardiovascular events like heart attack, stroke, sudden cardiac death, and ischemic assault early morning, and the blood pressure variability, which is linked to vascular damage, cardiac damage, renal damage, retinal damage, and mortality. This is again very well known. If you look at our ancient wisdom, and that's why I said I'm trying to see how we can marry ancient wisdom to the modern medicine. The pitta, which is red, the kapha, which is blue, and the vata, which is yellow. You can clearly see that the biological clock timings, various early morning events like thrombotic strokes to sudden cardiac deaths, to the blood pressure surges, to the rheumatoid arthritis flare-ups, to the rhinitis and the migraine flare-ups, to the epileptic seizures. And then when we move from that kapha pravrutti to the vata pravrutti, you get asthma, Prince-Bentley's angina, apnea, congestive heart failure going in the course of the day and when you sleep. And then, of course, as you get up again, you have the whole biological clock. So it's all ingrained. And long time back, our ancestors understood the sleep-wake cycle, the sun and the moon cycle, the earth, fire, water, metal, food, and fire cycle. And they were linked to various organs. For example, heart and intestine, small were the fire organs, the water and was the bladder and kidney, the fire was pericardium, and the triple burner was the endocrine metabolic organs. The wood was the liver and the gallbladder. The metal was the large intestine and the lung. The stomach was the spleen and the stomach. And this may all look crazy. In fact, we have genomes, we have microbiomes, which I'm going to talk about, but we also have electromes now, which talk about positive and negative energies. And all these can be measured now, because we can actually measure the sympathetic system activity, which is the red graph here, and we can measure the parasympathetic activity, which is the blue graph here. And we actually can plot chronocardiograms. We can do pulse beat analysis, and we can clearly do the FFTs, which is the beat to beat control, and we can do heart rate variabilities. And we can actually then, using modern gadgets, actually plot the human circadian time structure. So it is plausible, it is feasible to look at the ancient literature and try to put some evidence base to it in a more granular way. We are now chronotypes. When we sleep, we need to recognize that there are dolphins, there are bears, there are lions, and there are wolves. The lions are the ones who wake up early, get tired and in the early evening, and they are most productive in the mornings. The dolphins are the light sleepers. They have trouble staying asleep the whole night. Their peak productive hours are mid-morning. They are the bears, which have energy circles which rise and fall with sun, and their peak productive hours is during the daytime. And then we have the wolves, which stay up and sleep late and fall asleep, and when the lions are awake. And the world can be mapped in these 4 chronotypes. In fact, there could be 6 of these chronotypes coming up. And the sleep has a lot of phases. It's, of course, the reticular formation, which is responsible for wakefulness. But then you have N1, N2, N3, which are the part of non-REM sleep. And of course, then you have the REM sleep. And clearly, the sleep-wake regulation is hypothalamically controlled from the suprachiasmatic nucleus. And we know that the serotonin makes us feel energized, and the melatonin makes us feel sleepy. And it's the balance between serotonin and melatonin, which is what is the light and the dark. And that's how the whole sleep axis works. And we have all these neurotransmitters for sleep, melatonin and serotonin at the pecking order very high. Of course, we have GABA, adenosine, dopamine, orexins, acetylcholine, norepinephrine, and histamine. But it's important to recognize that we can think clearly, be vigilant and alert, and sustain attention. And we need to be wakeful and cognitive. Healthy sleep is very important for mood and mental health, but for cardiovascular, cerebrovascular, and metabolic health. Sleeping less than 6 hours or too much sleep, more than 10 hours, can impact outcomes and mortality. And optimal sleep duration is the key. And we can measure sleep by scales. We can measure sleep by apps. We can measure snoring times. We can look at sleep alarm cycles. And we can also look at melatonin. You know that it's the blue blocker glasses. It's a chemical signal of darkness. There's a whole science of melatonin called functional endocrinology, and there are protocols on in rehab medicine. We all knew that this was a isolate from the Yale University professor Aaron Lerner, who discovered melatonin. And clearly we recognize that the tryptophan, which gets processed to serotonin, which becomes ultimately melatonin, and clearly regulates the entire circadian apparatus. And we have a lot of sources of melatonin naturally. Dark chocolate, cocoa, cherries are a few examples, more than 70%. Simple things like ginger, bananas, wheat, cereal, oats, rice, barley are very good sources of melatonin. Peanut butter, walnuts, almonds, cashews, pistachios, spices, herbs, green teas are all very good sources of the melatonin, which we see every day. But it's very important to give right sleep advice and have a very good sleep hygiene. For example, the light emitted by phone and television screens shuts off the pineal glands, and therefore from making melatonin, and makes us very difficult to fall asleep and you get insomnia. It's very, very important that your bedroom lighting, particularly for insomnia, should be red, because that's having the least impact on the hormone melatonin, and the bedroom light should be always there. We should avoid coffee, tea, colas, because they shut off melatonin, and we should have an early dinner, and that's very important. So as I told you, the do's and don'ts of sleep hygiene are very important. 6 hours at a stretch, maintain a regular sleep and wake time, wear loose clothing. People who find it difficult to fall asleep, take a bath before going to sleep. Take your medications on time. Try to keep in a cool, dark environment. Try to have a pre-sleep routine and listen to some music. Don't push sleep. Don't have alcohol or nicotine. Avoid coffee. Don't have a heavy dinner or a junk food. Avoid electronic mobile phone, laptops, and try to avoid all these red lights from alarm clocks, street lamps, DVD players, which keep you awake. Do some yoga. Yoga is so crucial, Balasana, the Uttanasana. the restorative poses of the chair on the leg, the winding down pose of the rock or roll by rolls, the Ardha Uttanasana, the Supta Baddha Kosasana, the Vipratikarani, the Savasana, all of them are excellent yogas. And then we have so many superfoods for sleep. You know that tryptophan, which is the basic substrate for melatonin and serotonin in the body, both induce sleep. And carbohydrate foods which make tryptophan, for example, in yogurt, we used to have curd rice at night fundamentally to ensure that there is right tryptophan so that you get good quality sleep. And that has been there ancestrally through our generations, which has been passed on, that the good health habits, and even herbal teas like with the valerian extracts, the lavender extracts, simple things like a pinch of nutmeg can give you good quality sleep. And we need to avoid things in sleep like chocolates, fatty foods, spicy foods, alcohol, midnight snacking, coffee, drugs which are containing caffeine, and try to cut our fluids. Listening to good music is equally healthy. And then, of course, we now recognize that sleep has got its place even in the ADHD guidelines. Last year, we had this excellent 5 S's coming out for people living with diabetes, sitting, and sitting is the next smoking, and we need to break up prolonged sitting. Walk every 30 minutes, sweating, stepping, strengthening, and of course, sleeping appropriately. So we need to break your sitting every 30 minutes. Sitting is the next smoking. So you need to keep, breaking your sitting. We need to sweat it out. We need to build muscle. We need to recognize muscle mass loss is the key, and we need to overcome sarcopenia and frailty. Even if you do 500 steps a day, you can drop 2 to 9% of your cardiovascular morbidity and all-cause mortality. And clearly, 5 to 6 minutes of brisk walk per day can add 4 years of greater life expectancy in your life. And if you do resistance exercises, including activities like Surya Namaskar, Tai Chi, yoga, with flexibility and balance, you can make a difference. And don't sleep more than 8 hours. Don't sleep less than 6 hours. It negatively impacts even A1C and life. Try to have a good quality of sleep and try to have a morning phenotype. Like go to bed early, get up early, rather than a late phenotype. And that's so crucial. Switching gears from sleep medicine and sleep hygiene is the gut microbiome. As I said, there is a genome, there is an electrome, and there is a microbiome. And microbiota are at the center stage of health as we go in. We know that we are more bacteria than human beings. Human being is a home to microorganisms 10 raised to 14, which means 10 times more cells, more bacteria are inside our body in human cells. And this largest diversity of microbiome is in the gut. And the microbial abundance increases from stomach to colon in the hierarchical order. And there are 4 groups of microbiota: the firmicutes, the bacteriotes, the acinobacteria, and the proteobacteria. And this was a very elegant article from one of our scientists from Chennai, that they said that the health is not directed to how rich financially you are. It is how rich your gut microbiota is. And that there is a lot of claim and lot of truth in this metagenomics, that you have to have rich gut microbiota to live long and live healthy. And this is very true. This statement was made by Bala long time back. It was almost in 2014, almost 9 years back. And clearly we recognize that intestinal hotspot flora are the hotspot, including diseases like diabetes, which are linked to it very closely. And we have harmful bacteria and helpful bacteria. For example, we have the Pseudomonas, the Proteus, the Staph, the Clostridia, the Enterococci, the E. coli, which are harmful to our body, make toxins, pain, diarrhea. And then we have helpful bacteria, like the probiotic bacteria, the lactobacilli, the bifidobacteria, which modulate immunology, modulate gut and digestion, modulate motility, and synthesize vitamins for us. So the gut microbial ecology has pathobionts and symbionts, and the healthy gut microbiota will ensure that the gut permeability is modulated, the endotoxins don't enter our body, the pro-inflammatory cytokines are not produced, the beneficially active modules like short-chain fatty acids, indoles, are improved with insulin sensitivity. So gut is directly proportional to our cardiovascular health, metabolic health. And it's important to recognize that when we have high fat, high sugar, fast food, when we have stress, when we take antibiotics, we are actually distressing and disturbing and distracting our healthy symbiont gut microbiota, which are anti-inflammatory and generating pathobionts. And therefore, healthy lifestyle and prebiotics, probiotics, and even fecal transplantation now is emerging as a treatment option in life, in medicine, very closely. We clearly recognize that dietary fiber, we are fibrogenic individuals. They modulate gut microbiota. They modulate the short chain fatty acids. These actually upregulate receptors like the GPR43, 42, which modulate GLP-1, peptide YY, which improve satiety, insulin sensitivity in the intestinal tract. They also modulate the adiposity downregulation, insulin secretion, energy expenditure in the sympathetic ganglion, and blood pressure regulation. So clearly, diabetes, the role of, and obesity, the role of microbiota are very, very well established. And all the metagenomics in type 2 diabetes suggest that there is a link between type 2 diabetes is nothing but a state of moderate gut dysbiosis. There is a decrease in butyrate producing bacteria and increase in various opportunistic pathogens. So clearly we recognize that when we look at diabetes and the gut microbiota dysbiosis, we see that all these bad bacteria are producing butyrate, and their concentrations are lowered, and we are explosively having the wrong expression of microbiota genes and creating oxidative stress and a pro-inflammatory signature. And that's not good for our body, and we're depleting vitamins. So when our gut microbiota are altered, the intestine becomes leaky, and then you get metabolic endotoxemia, and the insulin signaling through the toll-like receptor 2 and 4 is altered, and we are not able to use our insulin efficiently. It's not just important for metabolic health, but the gut microbiota through various host pathways, including the trimethylamine pathway, the TMA, the trimethylamine inoxide pathway, the TMO, the short chain fatty acid pathway, and the bile acid primary and secondary pathways. They are linked to heart and cardiometabolic diseases. We also have seen that when we use blockers, like say alpha glucosidase inhibitors like acarbose, they allow more polysaccharide to reach the intestine. I generated this hypothesis in a group of people way back, 8 years back, that they push the polysaccharide to the colon, they increase the colonic bacterial mass, they facilitate production of short chain fatty acids and hydrogen gas by fermentation of polysaccharides, and that improves the healthy tissues and suppresses pro-inflammatory cytokines like IL-1, TNF-alpha, IL-6, and their cardiovascular benefits. And clearly that data has been shown with the drug. It has been shown with lifestyle modification. It has been shown even this hypothesis from Japan that sometimes flatulence may be good because the molecular hydrogen which is generated by the flatulence actually acts as antioxidants and might reduce the cardiovascular events which was seen in the Stop NIDM trial. And even agents like metformin, we know that metformin increases the abundance of Akkermansia. It's a mucus degrading gram-negative bacteria in the gut, which is associated with the T regulatory cells inside the gut, which reduces the tissue inflammation in the gut as well as adipose tissue in obese animals. So clearly it can combat obesity and diabetes, the gut microbiota. So gut microbiota are important for metabolic diseases. The gut bacteria make polysaccharide substrate, which make short chain fatty acids and hydrogen gas, which can be anti-inflammatory in nature, and they can be very useful. Finally, as we learn, we need to adapt, and we need to also embrace our past. We have seen and we have learned from Maharishi Charak, who is the author of Charak Samhita, that following ancient traditions of travel by sages, because Maharishi Charak traveled extensively and wrote a Charak Samhita, the greatest treatise on medical human body. We need to pick up the right things from that. And one of the right things is that we are having sarcopenia, our muscle mass is less. And we had embraced a form of an exercise as a complete physical exercise, which was then propagated by the king of Ond and, in the 20s by Iyer and Krishnamacharya, which is Surya Namaskar. And this is something which we recognize very well, that Surya Namaskar is a very holistic and complete comprehensive physical body exercise, which will strengthen our muscles. It has a form of resistance exercise and balances. And we have a lot of mantras and postures. For example, we have a prayer pose, a raised arm pose, a hand to foot pose, equestrian pose, a mountain pose, a salute with 8 parts pose, a cobra pose, the mountain pose. And then you can see through this pathway of 12, with chanting of various mantras, it is a process. And it is a part of balancing the imbalance between parasympathetic and sympathetic nervous system. So we know that there is an imbalance between rest and digestion, flight and fright. We know that the parasympathetic activity dominates when we take rest and when we are doing digestion. We know the sympathetic activity dominates when we are frightened or when we are, fighting. And we need that right autonomic balance. And some of these asanas like Surya Namaskar can restore that balance between sympathetic and parasympathetic nervous system, which is manifested in lay people literature as stress. And these are de-stress mechanisms, which not only will help you from a psychological standpoint, but will also help you from a medicinal standpoint, muscle mass standpoint, correcting their sarcopenia standpoint, and correcting cardiometabolic diseases in general. So clearly we need to generate evidence. Because when we talk of ancient wisdom and when we talk of ancient science, they were not born in the era of evidence-based medicine. So we as scientists need to recognize these are some of the papers which my collaborators from Calcutta, Dr. Chammo Samajdar, Professor Tripathi Santanu, we have done work. For example, we reduced anxiety of young athletes and improved their attention, memory, and mental state by Gayatri Mantra chanting. Or by Om chanting, we were able to improve quality of life with COPD patients. Or in COVID times, particularly in the elderly, by doing yoga prescriptions, we were able to improve lung compliance. So you need to generate science. You need to do randomized control studies to prove what is already known in the ancient literature and try to put an evidence base to it and a high level of hierarchy of evidence. Finally, as I conclude, we need to understand a couple of things in medicine. That we are all here to stay and live long. And our mantra should be to eat slowly. Don't eat fast. Because we know when we eat fast, we contract our beta cells. Eat less. Don't eat too much. Because caloric restriction makes us live longer. Eat on time. And don't skip meals. And eat the right food. Eat sattvic food. Don't eat tamasic or rajasic food. Do a lot of physical exercise. Do your 10,000 steps. Do yoga, do pranayam, do Surya Namaskar. Do chant the Gayatri Mantra. Sleep well and sleep on time. And try to be smiling. Because it's very, very important that we are in best of times, as Charles Dickens said, but we are in worst of times. And try to do 1 hour of digital detox every day. And try to ensure that we are committed to health and happiness for all the people around us in the community, for all the people with disease states in our community and people around us. So it's very, very important to rationalize and put an evidence-based construct in mind-body medicine and try to have a happier life, a mentally stable life, a digitally detoxed life so that we can have a better future. I really appreciate the opportunity given to me by the entire team, particularly Dr. Vaishali Deshmukh and our entire team. And I'm grateful to all of them so that we could at least try to adapt some of what I have said in our modern day practices. We should practice what we preach so that we can help people living with diseases and even with pre-diseases and even community at large so that they can have a healthy life, a happier life, and they can live long without any comorbidities or complications or multimorbidities. Thank you so much for a patient hearing.
Thank you, sir. And that was, I think, what I was referring to. It's difficult to gauge the depth. I think the depth of your knowledge is also so vast and so intense. So would you like to give your special comments or anybody from the audience? We have Dr. Shekhar also with us, and we have certain eminent personalities with us. So anybody else who would like to share their views? Dr. Joshi, sir, you?
I think, Vaishali, I'm grateful to you that you're doing this meeting and putting lifestyle, mind, body on focus. As I said, that we need to generate evidence base from our ancient wisdom to modern medicine. It's a journey and a path. We are all like-minded. let us all come together and generate some high quality, impactful science and reboot what is already known in a more structured and a scientific way. And I'm certain that our own ancient practices had a lot of science and a lot of wisdom. And let us ensure that it is put in the current perspective so that the world benefits. We are the leaders of G20 today. We believe in the concept of Vasudevam Kutumbam. So, we really are one earth, one family. So I think it's not just, and we are the largest country probably in the world in terms of population now, because, there are 8 billion people on planet Earth. There are 1.4 billion people in China and equal number in India now. So more than 1/7 of the world population lives in our country, and our rich heritage has to be translated into rich science. We have seen that we are now leaders in space science. I'm certain that if we are able to get our lifestyle practices invigorated in the modern medicine science, I think the preventive health and promotive health will benefit a lot. And I'm really thankful to you, Vaishali, for leading this initiative persistently and consistently. So I think my congratulations to you and your entire team for persisting with this and continuing this, because normally most people start and then they peter off. And thank you so much.
Thank you, sir, for your precious presence, and thank you for your guidance. And I am sure that the future will be guided by what you will be mentoring us. So we definitely need your support to carry this forward. And we agree with you that it needs to be an integration of the traditional medicine with the modern medicine, and so that it can be more applicable to our population. So, Dr. Shekhar, you had something to comment upon? Yeah. Hello.
Dr. Shashank, hi. He is a great friend of mine, and every time I meet him, I tell people, when Dr. Shashank speaks, you listen. When he stops speaking, you start practicing what he spoke. Thanks.
Thank you, sir. I think I agree with you. I can't deny the fact. So thank you so much. And thank you, Joshi, sir, for being here. And we now move on to our next session. Our next session is moderated by Dr. Sharvil Gadve. And Dr. Sharvil Gadve is an eminent endocrinologist in Kolhapur. He is the director and chief endocrinologist at Excel Endocrine Center, Kolhapur, and is the joint secretary of Maharashtra Endocrine Society with 8 research publications, 1 chapter, multiple phase 3 trials. He's conducted more than 150 awareness programs in urban and rural Maharashtra. He has trained more than 100 physicians in diabetes. He's organizing secretary of Maha Endocon 2023. He's a very proactive endocrinologist and a very dynamic person by himself. And I think he'll do justice to the next session. So over to you, Dr. Sharvil.
Thank you, Vaishali madam. It's very kind of you to introduce me. Good evening, everyone. So after that wonderful talk by Dr. Shashank Joshi, we move ahead with the next session. So we have another 3 wonderful talks now lined up. The first is by Dr. Sanjay Fadke. You can see his CV on the slide. So he's a senior consultant neuropsychiatrist at Jahangir Hospital, Pune. He is the chair of Indian Psychiatry Society Task Force. He is the chair for behavioral medicine and collaborates in neurosciences at for yoga. He is formerly associate professor at and co-investigator in ICMR research. And we welcome you for next presentation. The topic of Dr. Sanjay Fadke will be novel concept of wellness assessment in patients, CGI health. So over to you.
Thank you. So can I load my PPTs?
Yes, sir, please.
Okay.
Yeah, the slides are visible.
Okay, so my slide visible.
Yes.
Thank you. So thanks to the organizers. It has been a pleasure to be a collaborator with this activity. Now, it's 4th year of this particular conference, and I'm very happy that Dr. Vaishali was very thoughtful to put my presentation after some of these esteemed people, Professor Gangadhar, Dr. Joshi, Dr. Leena Phadke, Karuna Madam, and Prashant, who brought in already the various aspects of the health and wellness to the fore. So it makes my task that much easier. What am I going to do next few minutes is that I am going to talk about these 4 headings. So first is what is the evolution of the concepts related to health and wellness over last several years, and how do we measure health, and what is the implication for clinical practice and clinical research, and then about this particular method of measurement called as the clinical global impression, which is predominantly there for measurement of illness, and a new development in the form of adopting this scheme of clinical global impression for the measurement of health as well. So all of you will appreciate that we all grew with this WHO definition of health. Given to this year, we have the 75th jubilee of this definition, the Amrit Mahotsav of this definition, 1948 definition, that health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So although this definition has been there for a really long time, and as I said that as medical students and as later as medical practitioners, we all have grown with this definition, but this definition itself had its own positives and negatives. The most important positive to my mind is that this definition basically sets up a higher bar. So it sort of tells the doctors, the medical people, the healthcare people that don't just be satisfied with illness control. So strive for health attainment so that you make efforts so that your clients attain health and not just illness control. But while this positive is true on the conceptual side, there have been a criticism, that it had certain limitations, this particular definition or this approach, that it did not really give a very practical way of assessing health. So it did not really tell people. In concept, it seems fine that we shouldn't just have a freedom from illness, but we should have a very positive state of being. But it did not really give a practical way how to assess that. So in the end, we couldn't really move much beyond illness control in our clinical practice as well as even in our research. And moreover, despite World Health Organization 75 years ago emphasizing the different dimensions and facets of health, we know that the mind-body dichotomy still persisted despite that. So the dichotomy between the disorders of the mind and the disorders of body, they get treated in a separate way. And somewhere down the line, therefore, as a consequence of all these, we got lost in an array of lab tests. On one hand, physical lab tests, on the other hand, certain psychometry, and people continued to work in silos. So although the definition opened up some very good idea for us to move forward, it could not really deliver practically so much on the ground. After this initial effort by the World Health Organization, and in fact, it is a part of their preamble. If you read the WHO website, it's part of the preamble of their constitution, about this whole ideas about health and health as a resource. So the which developments came thereafter is a first one, you can say, important one milestone is a Ottawa Charter of 1986, which emphasized that good health is a very important resource, and therefore effort should be to attain good health. Then came in, after quite a gap, you can say in 2009, a conference called as the Dutch Roundtable Conference, and in which again a lot of experts from all around the world, they gathered for this roundtable conference, and they suggested that instead of talking about the state of health, let us move towards a more dynamic one based on the resilience or capacity to cope. And if you remember, speakers before me, whether it is Dr. Shashank Joshi or Dr. Leena Fatke, they already spoke about resilience, significance of resilience. That health should incorporate the resilience or capacity to cope and maintain, restore one's integrity, equilibrium, etc., and the sense of well-being. And therefore, the preferred view on health was that the health is the ability to adapt and to self-manage. So not just actually a state of positive being, but somewhere a individual's effort and the ability to adapt to one's own external internal milieu and to self-manage oneself. Of course, then other groups also worked on these ideas over a period of time. And we find that the American Heart Association, they came out with a concept called as ideal cardiovascular health, and wherein they put some metrics in place consisting of several factors, which includes some biochemical factors as well as the biophysical ones. And very interestingly, this idea finds good support across the specialties, in the sense that it doesn't only predict heart health, but is also useful to predict the brain health. So people who enjoy ideal cardiovascular health, so to speak, and this was, I would say, one of the first efforts to operationalize this idea that what health could be. Then in 2017, another researcher, Card, he came out with the idea that health is the experience of physical and psychological well-being, and that good health and poor health, they are not merely two categories, so it's not that the entire humanity is in the two buckets of all the people who have the good health and the people, those who have the illness, but it works basically as a dimension, so as a continuum. So people, those who are distributed on it. And then in 2017, another researcher and a thinker, he spoke about that the health must have some kind of a natural design to it, so it's not just that you can say a very superficial feature of organisms and human beings, but it's something which is very deeply imbibed natural design. So this kind of a different set of, as you can see here, concepts as they came along over a period of time, basically reflect, people's zeal and the desire to operationalize the ideas which the WHO came out with, so that people can use it in a practical way. Of course, then there is a body, as previous speakers, they mentioned, on the side of biological research, the laboratory research, as well as very elegant epidemiological and clinical research, which essentially showed that the mind and body, they are very intimately connected. And the neuroimmune and endocrine systems, the neurological substrate, as well as the hormonal and the immune system, they all are interlinked, and they basically sort of provide a biological basis to this mind-body connection. Another important milestone while all this was happening, people on the clinical side were doing, there was also a very interesting theoretic work, more on the mathematical engineering side was also happening. And these people, Glass and Mackey, they came out with a very elegant idea wherein they sort of systematically looked at the rhythms of life. And then they found that the healthy rhythms of life, they fluctuate within a range, and what technically is called as that the biological system has a non-linear sort of a dynamics. Now, what it implies is that there is a nice flow of these rhythms, and there is a healthy fluctuation within that. Professor Karuna as well as Dr. Shashank Joshi, in their presentations before me, they emphasized actually a great deal, about the sleep and other rhythms. And also Dr. Leena Fatke in her presentation mentioned this, making use of this idea. Harvard cardiologist Goldberger, he looked at actually what is the healthy cardiac dynamics, and this also fits it, that it has a nice healthy fluctuation. So put all these ideas together, there was a, you can say, motivation for us to venture into this domain of measuring health. And two particular occasions sort of motivated us more. Our mentor, senior mentor, Professor Bhavsar, we were celebrating his 80th birthday a few years ago. And then there was this Vaibhav meeting. Vaibhav is the acronym for the Vaishvik Bharatiya Vaigyanik. This was a meeting which was organized by the Prime Minister's office of consisting of Indian scientists as well as the other global scientists. And the idea was to look at that how to make further strides into the integrative medicine. And the question which came up during that meeting was that, do we adequately capture health in our clinical research and intervention studies? Or do we really measure only a very small part of the illness, or do we really sort of in a good, nice way able to capture about the patient's health in all our clinical research as well as intervention studies, means clinical trials, whether the clinical trials of new medicines or clinical trials of non-pharmac interventions. And the answer was that no, our whole assessment itself is very limited. So when we assess an individual, a patient, a human being, we only tend to look at, we have a bit sort of a biased assessment which only looks at the disease and disease complication part, and we don't really look at actually the entire part of this individual's health. And you can call it as a low ceiling effect, which means that the ceiling of our measurement itself is very low, so we are unable to comprehensively assess an individual. And because we are unable to do that, so we are not really able to understand, whether our efforts are really generating a positive health for our clients. So with these motivations, we sort of tried to synthesize a concept of health, and I have put as bullet points some of the, you can say, key features of this synthesis. So the first point naturally is that health is whole. So mind and body, they are inseparable. There's no point to be sort of entertain this dichotomy, mind-body dichotomy any longer. So mind and body are inseparable, completely clear by the research evidence. And also that health is dimensional, so humanity cannot be just put into these two buckets, that people, those who have illness and all those who don't have illness are automatically healthy, but it's a dimensional thing. And of course, then it has a natural design, the rhythms, the order, the rhythms being in order, that is the natural design for the health. And that health is dynamically created among interaction in the external and internal milieu. Just before me, Shashank Joshi sir, he spoke about the internal milieu and its interaction with the gut microbiota. So not just the milieu outside us, but also the milieu inside us, that how very critical to creation of health. Now, health is a aspect of subjective experience. We should be able to feel it. And last but not the least, very importantly, adapt and self-manage. To be resilient, is also important part of health. So health is all this. There's the dimensional approach. On one hand, you have the disease state and the complications, but on the left-hand side, you also see that there could be varying degrees of a healthy ordered system and even a resilient system, which is more resilient, to which can have a better ability to recover from difficulties or adapt to change without really being affected. So it effectively tells us that people should have, with good health, the ability to regulate whatever they can and to endure, whatever they cannot. Now, coming out of this whole conceptual understanding, that where World Health Organization started and where a lot of other researchers and wise people, how they tried to make this concept, take this forward so that it could put to more practicality. Let us look at some of the, you can say, important frameworks that how we measure. One such, you can say, very important scale, an idea of measurement which is employed in the clinical trials of new medicines, new interventions, is called as a CGI, the Clinical Global Impression. It's typically, of course, used for clinical global impression of illness. And it was authored by a guy in 1976. So this sort of a measurement scheme has been there for a long time. And what does it exactly measure? So it not only measures the illness severity, but it also measures or assesses what is the clinical impact of this particular illness on the patient's functionality, the real life functionality. So both the illness severity as well as its impact on the patient's functionality. It's a very well known, validated scale, relatively straightforward. Of course, it needs training to be able to clinically assess that. So what effectively is done is that a clinician has all the data available from the history from the clinical examination as well as all the lab tests together before her or him. And then the clinician is able to assign a rating to the patient's current situation as to how severe and impactful the current state of the illness is. It is clinician rated. And as I said, clinician considers all the data available for making the rating. Initially, it was used more commonly in research related to the central nervous system. So in psychiatry, neurology, neuropsychiatry, pain medicine, but subsequently it has been adopted for use in many other illnesses, as well as for evaluation even in clinical practice. And people also later thought that instead of just having one single measure, putting the entire illness in one place, it is also useful to have subscales in some instances. So there is a CGI for measuring the illness severity, and for clinical trials, there is also a version called a CGI improvement, so that you can see that before the treatment, how is the patient's CGI overall global rating, and with the intervention, how much the improvement has taken place in the patient. And as I said, very important outcome measure, which is used at part of the clinical trials. Here is you can say this rating scheme. So normal, not at all ill, borderline ill, mildly ill, moderately ill, markedly ill, severely ill, and among the most severely ill patients. And of course, all these have clear-cut definitions, which are called as anchors, so that people can get a training, and then they are able to have a very good inter-rater reliability. So even if different raters are rating the same patient, they can come to the same conclusion about the patient's clinical state. We thought that we should adopt, it's a wonderful scheme, we should adopt it for the assessment of health as well. And the anchors, as I said, are the description or definitions for each rating useful for accuracy of rating. And we have also put, unlike the CGI illness, we have also put the category for positive health, which is over and above the normal rating. So compared to, as I showed you here, that one is a normal rating, normal, not at all ill. So we have put a category which is above the normal rating, which is about adaptability and resilience, which is the main consideration for rating positive health. It is assessed on 8 points, which can be seen as maybe you can call them as pillars of health, and which all have emerged through research evidence. And as I said, I'm really thankful to all the speakers before me, because they have already highlighted these pillars of health. This whole research evidence is summarized in this particular reference, which I have put here. Is a book chapter which we have written called as Mind and Cardiovascular Disease, Mechanism of Interrelationship. So this entire research evidence from laboratory as well as epidemiological and clinical studies, which we have used to describe these pillars of health, is summarized in this particular publication. They have been clustered under vital rhythms and the mind or positive psychology pillars. So these 8 we have clustered 4 + 4 in 2, and they are the ones here. The 4 vital rhythms as part of the clinical global impression of health. First one is sleep. I need not overemphasize the significance of sleep. There was a whole full-fledged presentation on this this afternoon. And then the digestive cycle and nutrition. Dr. Shashank Joshi already spoke about that. And energy cycle, exercise, fitness, overall the vitality also has a lot of significance in this all modern literature, already touched upon by the speakers before me. And Dr. Prashant, again, a full-fledged presentation on sexual and reproductive health, and that how it contributes to the overall health. Then the mind pillars. First one is a feeling of comfort, as a positive feeling, positive state of emotionality. Then psychological engagement with daily activities and work. Very important finding emerged through a lot of elegant research, particularly regards to occupational health, that people's health is dependent to a great extent, on their engagement with life on a daily basis. Shashank Joshi sir already mentioned this. Optimism and hope, very important pillars of health. He already touched upon that. And the self-control, which includes freedom from addictions and treatment adherence. So we put, you can say, these 8 factors together as the, you can say, indicators of health. And then we made this scheme that how to rate them. So as I said, that over and above the normal, we have the positive and regulable and positive and resilient categories, so that the entire dimension patient could be rated on this entire dimension. So people having a positive state of positive health, people having a so-called normalcy, people having a mild problems, and people, of course, having identifiable clinical and more severe problems. And how this is rated, of course, this need a bit of a training to do that. But the most important instructions are considering your total clinical experience with this particular population. How healthy is the patient at this time? So instead of asking that how ill the patient is at this time, you ask yourself this question, that how healthy is the patient at this time, and make use of all the information as well. In order to make clinical judgment, please use information available from all the sources: patient self-report, information from relatives, case notes, clinical examination, and lab investigation. So in other words, you are summarizing all the information available at your disposal to make to a clinical judgment as to how healthy the patient is at this time. In case there is a health problem, consider its frequency of occurrence, severity, distress, functional impact to assign the most appropriate rating. Make use of the anchors provided, and specify if the health which the patient is currently enjoying is supported by any medicine or treatment, and ask about resilience to assign rating of higher state of health. And of course, then come to a considerate judgment about it. As I said, needs a little bit of a training about this. This is just an example from one of the points, how to assess the sleep, that how to assign, when to assign the positive and resilient rating, how to assign, when to assign positive and controllable rating, when to call it normal, when to call it borderline mild problem, when to call it a moderate problem, when to call it a severe problem. This is all completely aligned, as I said, with this internationally standard tool called as CGI. So there's a proper structured way of doing this, and it yields reasonably good information to complement the illness information. Let me just summarize it before I close, that this idea, CGI health, is a way of measuring health in a practical way. And as I said, our journey started with that WHO came out with this concept, but the practical way was lacking. And that's why CGI health somewhere tries to fulfill this agenda. It gives us a tool, a simple clinical tool in the hands of clinicians as well as researchers, in which we could measure the patient in a very comprehensive way. CGI health also has a version for self-rating or self-assessment by patients, what is called as a PGI, patient's global assessment of his or her own health. Now we have a good experience of using CGI-H and PGI-H in diabetes population, rheumatology population. I'm sure that some of our colleagues, they are going to make presentations about that and going to present some empirical data to you. And this experience has been very encouraging, to say the least, because the combination of CGI illness and CGI health, it provides a very whole picture of patient. By the way, the meaning in Old English, the health stands actually for whole. So a combination of illness and health, if we assess the patient from both the perspectives, it gives us a real kind of a good holistic picture, and which I think Leena madam said in her presentation. Very famous, someone made a sort of expression that good assessment is half the intervention done. So if we are able to comprehend patient, our clients in a better way, we are able to offer them a better intervention, and thereby fulfilling the dream which WHO floated 75 years ago, that we are not looking at just end of illness, but we are looking at the beginning and betterment of health. And this is the last one, why we need to do this, why we need to shift our attention just from the illness to, let us not be illness obsessed. Let us try to look at the illness and health in a more balanced way. Because this famous person, and I use this slide in many of my presentations, because he said that doing the same thing over and over again and expecting different results. So if we are really seeking health, we also need to look at our own methods by which we are making the measurements, the assessments in a different way. Because continuing with our ways which we used up till now, is not going to allow us to have any different or better results. So it is therefore necessary that we all need to think about that. We have all gone through this training, wherein it is imbibed in our mind that we need to something better for our people, not just freedom from illness, but aspiring to help them get their health. So thank you so much. And it was a wonderful meeting so far. And my best wishes for the speakers who are going to follow. I think this time this is going to be very substantive and very interesting, because different speakers are adding kind of a great value, as I said, to all these ideas. And I hope that this whole experience will help us move forward on this agenda in a more very practical way this time, rather than merely discussing about these ideas in conceptual form. It will help us to translate them in our day-to-day clinical practice, as well as the research that we do, a new thinking. Thank you so much. Thank you.
Thank you, Dr. Sanjay Phadke. After that wonderful talk, all of us need to move ahead with this novel concept of wellness assessment in patients.
Excuse me, sir.
And, yeah.
So can you stop your screen, sir?
Yeah, sure.
Yes. Yeah. Yeah. So we, after having discussed in details this novel concept of wellness assessment in patients, we move on to the next talk. Is also very interesting. Medicate or meditate. So that's the conundrum in type 2 diabetes. And to talk on this, we have none other than Dr. M.A. Shekhar. Sir is Honorable Vice Chancellor of the Adichanagiri University. He is the former Director of Karnataka Institute of Endocrinology and Research, Bengaluru. He is the former Professor of Medicine and Head of Department of Endocrinology at Mysuru. He is the Director and Consultant Diabetologist, Apurva Diabetes Foundation, Mysuru. He has been the Member Governing Council, Mysuru Medical College and Research Institute. He has a number of achievements to his credit. He is invited faculty at various conferences, CMEs, universities. He is author of chapter and editor of books on diabetes. He has published papers in peer-reviewed journal. We are indeed honored and privileged to have you, sir, as speaker today. And over to you, sir, for your talk.
Thank you, boss. Well, good evening, everyone. It's my pleasure to be a part of this great activity that's going to happen for 2 days. For that, I'm extremely grateful and I'm thankful to Dr. Vaishali, Rachi, and Harpreet, who literally have held my hand and took me to this place so far in the last 10 days. Thank you all for this. And let me share my slide, okay? Visible?
Yes, sir, visible.
Thank you. Now, this is where I am the Vice Chancellor presently, Adichanagiri University. I bring greetings from the university, Jai Shri Gurudev. I was asked by Dr. Anish Bail, a very good friend of mine who stays in Mysore with me, about this concept of, mind over matter, or mind-body concepts, etc. And these three concepts or these three phrases that have been used are fantastic. The first one is synapse. Today, we are probably encouraging synaptic activity between many of the brains that are going to take part in this through mind, body, whatever you want to call it as. It's fantastic, I tell you. Brought by sphere. It's a full circle. Start here, sphere takes us around and it's a full circle. And when the circle is built, synaptic ramification shall happen. Beautiful concept. Dr. Vaishali, fantastic. Hopefully, I will do justice to what is going to happen in the next 25 minutes. Look at this picture. Can you find out where the boy is sitting? What is the boy's or the man's legs and the female legs? Sometimes when you look at it, you get really confused. Same thing here. head and a black shirt of the man, or is it a pink shirt of the man? We get confused. Classic example is happening with the so-called evidence-based medicine that we are facing. We have been focusing mainly on one thing: medicate, so that we can probably bring down all the ills of the diseases that we are faced on. This is the exact problem that we are facing. On a bird's view, this is going to happen. Let me clear some of the ideas for you. This question, it's a false dichotomy. Meditate, medicate. Can you imagine our ancestors, as Shashank was talking about? They did not have TVs, they did not have lights, or they did not have any other things except hunter, gather, sleep, get up, and be happy. So meditation probably was predating to medication, if you really look at our evolutionary activity. So it's a false dichotomy, whether to medicate or meditate, whatever it is, because it's not a matter of either or, because meditation is a very valuable addition in general to our life. Meditation, it's not 24 hours meditation. We'll speak about it later. And to therapeutic processes in particular. In general, meditation is very important for our life, a proper life, and in particular to the therapeutics that we are going to use. You know, when there is hardly any health issues or a minimal change in our health, probably meditation is good enough. You meditate, heal thyself. Man, heal thyself. When the health issues are easy enough to handle, when it goes beyond a certain level where you cannot handle with yourselves, probably medication comes in. This is the socio-economic privilege, being where the concept of recommending meditation over medication comes. Recommend meditation over medication comes because health issues are not that easy just with meditation or medication. It's more complex. We will not look at evidence-based activity for that. But once even today can continue with medication, yes, but meditation should be an integral part of whatever we do. I'm not going to give much about it. Why? Because we all know low-bar pneumonia is caused by a bacteria or a virus, etc., etc. But what happens in that particular individual who gets this bacteria or this virus, and there is a lobe that is involved in the infection, is not just about the so-called biological component. There is a psychological factor for that and a social factor. So this angle G, need for a new medical model, is very, very, very important if you ask me. It is called psychosocial model of health and illness. So I think we should really give much importance here. I'm not going to delve very, very deeply into this. It's already there: psychological factors, unemployment, financial stress, etc., etc. Socio-economic status, educational status, interpersonal. So many things are there, and biological factors we all know about it. Unless we put all these three in the middle, we are not going to succeed in treating our non-communicable disease component of the problem that we face. So can you treat psychological factors with medication? Can you treat social factors with medication? Can you treat biological factors with medication? Think again. The second concept is, we, the modern medicine specialists, are very happy and proud to say that we have increased lifespan. In India, lifespan has gone from 30 years to 40 years to 70 years to 69 to 72 years is the lifespan. But is it equal to health span? Have we ever thought about it? Earlier, why we were not seeing many diabetics? Probably most of them were dead with a cholera or some pneumonia or some influenza. By the time they were 20, 30, probably 40 years. Now that we have increased the lifespan of our patients or our population, they are going to live till 70. Imagine they develop diabetes at the age of 45 or 50. If the lifespan is up to 70, they have 20 years of life where they have to safeguard their health. This is where we have to introspect and say, do we equate lifespan with health span? This is very important, because I feel in our day-to-day conundrum of treating a type 2 diabetic. Health span is as important as lifespan. Lifespan has increased, yes, 79 years. It's a US-based activity, but health span is only 63. They develop diabetes at the age of 40, 45, 50, up to 63, 64 years on an average, they are very healthy. Then kicks in microvascular, macrovascular, heart attack, kidney failure. But with so-called, technological explosion and scientific discoveries, we can still make them live. But up to what? With very little help. So this is where we introspect. We should also see that lifespan and health span come very, very near to. The health span is 68 years and lifespan is 70. It doesn't matter. 1 year, it doesn't matter to your patient, right? You agree with me, I hope. Now, diabetes is fundamentally a chronic metabolic disorder. We all agree. Yet it has established psychological connection with consequences. I was talking about psychological, social, and biological. I want to bring in that connect because the most important component is diabetes distress and coping with this distress. And you have all these components of burden of living with chronic disease, fear of failing, keeping up with diabetes care, fear, angst, despair, living with, all these things leads to diabetes distress. How does the person with this diabetic distress cope? Is very important. Can he or she cope with, the diabetic distress that we are talking about it? Can he or she cope with just medication? Think again. These are the sources: powerless, negative social, concepts are very much available. All you have to do is take a textbook, take a journal, Google, you get all these things. I would like to draw your attention to this. Diabetes is non-communicable disease, chronic metabolic disease, agreed. But there is a psychological and a social significant component which leads to diabetes distress. And the best way to cope is not just medication, you need to go beyond. I want to tell you is meditation also. Okay? Then, quality of life, you all know so many things, significant issues and challenges at physical, emotional, psychological, social, occupational, and interpersonal level. All these things put together, there is a burden on the diabetic. Quality of life goes down. It's this is again theory, constant monitoring, maintaining normal blood glucose, whether your wife, your husband will look at you suspiciously, or doctor will keep talking, what is this? I've been telling you to take care of yourself, you're not doing. Constant, input that you should take care of your diabetes. Consistent use of anti-diabetic drug every day in and out. Fear of especially hypoglycemia. All these things add on to the distress, which leads to a decreased quality of life. And one more component I would like all of you to really look at your type 2 diabetic from today onwards is diabetes associated cognitive decrement. There is cognitive decrement which is associated with hyperglycemia, not necessarily only with advancing age, which many times it is called as minor cognitive impairment and probably ignored. Keep this in mind. Hyperglycemia, tell them your cognitive decrement is going to happen with hyperglycemia, which will lead to you forgetting certain things, you ignoring certain things, enhancing diabetes distress, leading to quality of life going down, vicious circle. Okay, keep this in mind. The result, decreased quality of life in whatever way you want to talk about it. Result, distress increase. Result, outcomes are bad. Result, health span is going to shrink. Added to that are the personality characteristics, psychosocial issues, peer pressure, family dynamics. Everything gets into the conundrum of helping a type 2 diabetic. It's not just medicating them. 5-factor model, I hope all of you know about it, or you please make your homework about this 5-factor model of personality characteristics. Openness. Doctor should be open with the patient. Patient should be open with the doctor. Everybody knows. Conscientiousness. Extraversion. It should be a little bit, Shashank was telling, smile. Put a smile on your face. Half of your problems may come down. Agreeableness. Please agree with what's happening around you. Accept what is going to happen and go for them. To a certain extent, don't laugh. Neuroticism. You need to be a little bit neurotic. that inner thing that has to be brought out that you're going to do well. Why I brought this is the classic antipsychotic problem that happened in neuropsychiatric prescription with metabolic disorders. You all know AP-induced metabolic alteration, AIMA. AP, that is antipsychotics induced, leading to appetite dysregulation, obesity, dyslipidemia, type 2 diabetes. It's very well known. Weight gain is significant with antipsychotics, and that pushes them towards type 2 diabetes or known type 2 diabetic. Weight gain, very bad. Blood sugar control, upregulate, downregulate, upregulate, appetite inducing peptides. So you start eating without your knowledge. Downregulate anorexigenic peptides. Again, these are all theory that why I'm trying to tell you is the drug, that medication also leads to these diabetic distress, abnormal outcomes that we are talking about. And what is the, physiological and neurological substrate? You all know hypothalamic nuclei and, ventro, all these, ventromedial nuclei, everything that comes into picture. Animal experiment, neurophysiological substrate. Finally, it is energy homeostasis. What is this? Allostasis, very fantastic lecture that happened. Insulin, insulin-like growth factor, all these hormones, 8 or 9 or 10 hormones, try to keep a homeostasis. There is abnormality because of psychosocial, because of biological abnormality. Allostasis goes on, and after some time, homeostasis goes for a 6, leading to all this problem. So, this one thing I just wanted to insert, it is way out of my purview of talk about. A lot of interest has been shown in this particular path towards research called as transient receptor potential system, TRP, not your, all those, how do I say, TV TRPs, various subtypes of TRP channels, which are basically influx of cations such as sodium and calcium. Keep this in mind. Remember verapamil and type 1 diabetes emerging, it's going to protect. You're probably looking at TRP. TRP channel family comprises 30 different, group 1, group 2, everything is there. Just I insinuated this because this could be a very potential field of research in future. Lastly, I come to meditate versus medicate. I have deliberately put a gap here because this is where a conscientious doctor like you and I, or every one of us, walk in, called as mediate. Meditate, medicate. In between, there is what is called as mediate. The person who mediate is you. You need to understand it in a proper manner. Okay? Meditation process, I'm not going to talk much about it. I'm not an expert in that. But 5 minutes, 10 minutes meditation, calm about it. Anybody questions? How I meditate, I'll let you know. Mediation is something you really have to understand. Practice of working with someone trustworthy. So it is bi-directional. You trust your patient, the patient trusts you, and if that practice of working with someone trustworthy, balanced and impartial will support you, the patient, support physician also. Keep in mind, mediation is you initiate and it is a bi-directional activity. Referred to as CPR of conflict resolution in psychology. Okay? Now, look at this slide. What do you understand? Everybody is smiling, looking at this matriarch or patriarch of the family who has reached the heavenly abode. Do you think this is the inner thing that you have? Looking at this, they are posing for a very nice photo. But are they very relieved that this old person died? Or they are celebrating this old person's long life? This is where you really have to think about how you respond. I didn't understand this picture. Please explain. That's what I'm trying to tell you. Please respond in a proper manner to your patient's needs. trust in patient-doctor relationship is the final thing that I would say and stop. Okay? Many theories, few measures, and very little data. There are plenty of theories. I can talk to you about this for 45 minutes. Very few measures, how you can go about bringing down the distrust in a patient when a doctor is concerned. Absolutely very little data is available today. But issue is, patient doctor trust me, I'm your doctor. Trust me, please. I want to do the best for you because doctor knows best. That is literally gone from the concept. The concept of trust today is top level commitment, risk assessment, undertake control measures, systemic review, monitoring and enforcement, training and communication. Trust is classically relevant in non-communicable diseases, especially so in type 2 diabetes and hypertension management. So, trust principles, start internalizing. Don't say doctor knows best. Think of how you react with your patient. Things are done. I decide for you, paternalistic model, not anymore. Deliberative mode. In addition, I tell you my preferences. Then I give you facts, informative model, and I give you facts and help you to find your preferences, interpretive. Today, a doctor has to don all these four. Paternalistic model with trustworthy patients who trusts you till their death. Deliberative model when the patient is a little bit doubtful about your standards. Informative model when patients are highly educated, they come with Google University or WhatsApp University degrees. And interpretive model is what we are talking about, doctor-patient. Paternalistic, deliberative, informative, and interpretive. Interpretative manner probably would be the way to go. But you have your patient for the last 20 years, paternalistic. I decide for you, don't worry, let me take care of it. Yeah, it still works. And it's complex illness and treatments, interactions are changing, healthcare systems, increased patient expectations, blame and complaint culture, litigation, diversity, resource limitation. All these things are just theoretical consideration. Plenty of theories are there. Very little measures to take care of this complex illnesses and treatment measures. That's why you need to talk about building trust with your patient. It's a cycle. You should be competent as a doctor. You should be dependable, honest, and considerate. Empathy, all those theoretical phrases that you can use. If you have competency, you are dependable to your patient, you're honest enough in telling them what's going to happen, what I know and what you should know, and you consider it for their psychosocial needs, you will definitely be a trustworthy doctor as far as your patient is concerned. Medication is the outcome of process when we give another person the power to make a decision on our behalf. The patient, I'm talking about the patient gives the power to the doctor to make a decision on their behalf to medicate, and they have to follow, and that's another conundrum we are talking about. So the decision-making person goes through a process of analysis, diagnosis. That's you, doctor. The decision-making person decides by analyzing evidence which has been presented in legal proceedings. This is nothing but history taking, general examination, systemic examination, tests, that, this, and all that. But decision-making person, why? The patient has put complete trust in you, have given you the power to decide for him or her to give a prescription for medication. So the decision-making person prescribes an answer or a solution at the end. That's your problem. That is medication. How do you do that? Please meditate yourself. Help your patient to meditate. Mediate all these things that I've just mentioned. Then start medicating. Win-win situation for both patient and doctor. Finally, you take medicine. Please tell them. Finally, with all these things that you have done, you take medication. I can't take medication for you, my dear patient. You take the medication. Remember, medication is likely to be, fill up the blank, problematic, the most expensive option. So to meditate, you don't need plenty of money and you need all sorts of things. To mediate, all you need is a good heart, good understanding brain. Medication is probably the most expensive option that you can think of for your patient. Keep this in. Okay, build and maintain trust. These are all theory, don't worry. These are the some of the things, you can ask them to give these two very good topics that they have dealt in meditation and meditation as medicine. You can go ahead. Finally, ladies and gentlemen, put a smile on someone else's face today. I hope I put a smile on you all. Thank you.
Thank you, sir, for that wonderful talk. We all get to learn from your talk, and we all get the take-home message for ourselves as well as what we advise to our patients. So we move on to the next talk. Another very interesting concept. Can you? Yeah. So we have Dr. Sandeep Ruder. He is clinical endocrinologist, Life Fourways Hospital from Johannesburg, South Africa. He is honorary consultant at Charlotte Mackenzie, Johannesburg. He is associate lecturer at University of Witwatersrand. He is student of philosophy at Vedanta Academy, India. He is a public health advocate. He is author and co-author in local and international journals on topics of diabetes and philosophy in medicine. His public health advocacy has been for sugar drinks tax in South Africa, which I believe is very important and is the need of the hour, looking at the health hazards associated with certain foods. So without wasting time, we are very interested in listening to Dr. Sandeep. Over to you, Dr. Sandeep.
Good afternoon to all our friends attending Synapse. I've been given the topic of a new BMI for endocrinology. I'll tell you what the meaning of BMI is in a second. It's a novel approach. What I'm going to be telling you here today is nothing new. If anything I say sounds fresh, it's not an original idea. I happen to be a student of endocrinology and a practitioner of endocrinology for a good part of 15 years and a doctor for over 20 years. So I have the medical background, but in association with that, I've been a student of Vedanta philosophy in India for some 12, 13 years now. And it is the study of Vedanta that has put a spotlight on the way I practice medicine and redefined a new need that I think is necessary in medicine at the moment. And anything I convey, as I'm saying, is not new. I have gratitude to pay to my teachers and gurus and even physician teachers in my medical education. And this is just a culmination of some thoughts around that for you to contemplate in a time when I think there's a pressing need for a change in the way we approach medicine. Because as Einstein said, we cannot solve our problems with the same thinking we used when we created them. And we need to look at things in a different light. I've put on some quotes from Western scholars and scientists. This to warm the mind up into the idea that knowledge systems of India may not particularly give you the individual solutions for today, but the knowledge systems that I've been studying for the last 12, 13 years have given me a way to think about things. And I think that's the gift of Indian knowledge systems to the world, is that especially Vedanta, Veda means knowledge, Anta means culmination of knowledge. So the knowledge knowing which everything can become known. And you can see astute scientists like Erwin Schrödinger, who you don't get a higher physicist than him. He and his buddy Niels Bohr and Heisenberg all came up with a theory of quantum physics, which is a very high level of science, but they elude their ability to see the connections between conventional physics and the new ideas of quantum physics to reading ancient Indian scripture, Vedanta. And it was their delving into these deep systems of thought that brought about a new way of thinking in the physics space. Here, William James, also another Western scholar, says from the Vedas, we learn a practical art of surgery, medicine, music, house building. They are the encyclopedia of every aspect of life, culture, religion, science, ethics, law, cosmology, and meteorology. So there's a lot more than this. Niels Bohr, Heisenberg, and many other scholars, which I don't have time to go through already. But these were Western scientists. And science is nothing but the intellectual and practical activity encompassing the systematic study of structure and behavior of the physical world, the natural world, through observation and experiment. So science is about measuring the gross world that we know, the world outside of the body, and the body itself, which is part of the world, physical structure. And the only way we can do science is by using our five senses: eyes, ears, skin, taste, touch, etc., nose for smell. And then the scientific apparatus we use these days are merely extensions of those senses into the microcosm and macrocosm. And with that, we've made many amazing advances in science and technology. And you look at how evidence-based medicine has been driven today, a lot of new pharmacotherapies that have changed the way we treat, especially the so-called endocrine diseases of lifestyle and non-communicable diseases like diabetes and obesity. But there still seems to be a problem that even though our intelligence and knowledge seems to be improving, and the technology with that appears to be improving, are we really advancing? Is scientific knowledge really making us healthier? Because at the middle of it, there's still this human being with the dilemma of choice. And around him are all these products of the modern technological world, which we don't know how to relate to. It's an interesting concept. And it seems that as we advance with knowledge to provide solutions for humanity, it seems the problems seem to get worse. So it's like the numerator and the denominator going up in parallel. And we have to agree that the dilemma of choice is a human species problem. And it seems like there is a decision-making problem where we don't know the basis on what we have to choose anymore. In the animal kingdom, in the national parks of the different regions of the world, you don't see generally lifestyle diseases. There's no overweight, there's no underweight, there's no generally hypertension, cholesterol, diabetes. The animals will stop eating when they are full and they walk away. There's a sense of proportion in nature. So it seems nature protects other species by physiological limitations, but then the dilemma of choice is given to humans. And since we are the apex of creation or evolution, the question becomes, how do we choose in our current environment correctly? Because it seems incorrect choices in relationship with the world is linked to a lot of the diseases we see. So the need of the hour, the theme of Synapse this year is pharmacotherapy and beyond. I think we're making excellent advances in pharmacotherapy, but that approach has perhaps become a bit lopsided or one-sided, and we need to look at that more deeply. What is depth of thought in medicine? Means, do we just go the pharmacotherapeutic approach only? Is it going to come to a point where human beings have to carry, 20 to 30 medications just to sustain homeostasis? And where is medicine going in its current format when we completely buy into the narrative of medicine as it stands? Is it going to lead us to some fulfillment in what we're trying to achieve? It's a question I put to you. I'm not here to give answers, but to stimulate thought. And then science and the direction is going. Who directs it? There was a time when science was quite independent. Benting and Best created insulin and sold a patent for $1. But they did not want to profit from it. They did it out of a selfless purpose. But today, a lot of science is driven by the corporate industrial complex, the drug makers. And we have to have the ability to ask the question, are we objective in our approach to science and medicine, or is our narrative being largely driven by interests of the pharma industry and corporate bodies? Is a question. It's a fair question, and it's something we must answer for ourselves. When did it become so difficult to maintain human homeostasis? It's another question I would ask. And what does it actually mean to be human? What are we trying to achieve? Every day, everybody wakes up looking for one thing, happiness and bliss. But it seems in the desire to achieve happiness and bliss, we're getting the opposite: disease, dejection, depression, sometimes divorce. So where is it all going? So the desire for bliss and happiness is not incorrect, but perhaps we've gotten our means wrong. So this is the background to why I got into looking into different avenues of looking at human health, human wellness, human bliss. How do we achieve it really? And the narrative of my talk is based on this. one of the influences in my life, Claude Bernard, who wrote the book Milieu Interieur. He was a physician and a philosopher. And milieu interior simply means internal milieu, how to maintain homeostasis. And he said very smartly that human beings, the higher animal, has to live with a close and wise relation with the environment. And what we're trying to do is maintain equilibrium. Now, there's always a delicate compensation when we extend ourselves a little more, but perhaps today we're extending ourselves over the limit of the body to maintain equilibrium, and extensively so, which is why we see all the modern pandemics. The question is, why do we do that? And what is behind the body that drives it to do what it does? Is it purely physiological, or is there something more there? So these are the questions I hope to try and give some direction to. Now, all things in the universe, there has to be a causality, a root cause. It's so deeply embedded, the concept of causality in our minds, that it's been thought of as immediately evident. You know, diabetes is caused by consumption of too much sugar. It's not as simple as that, because if you go back, what causes someone to imbibe too much sugar? So it could be wrong understanding, wrong knowledge, wrong ideas about food. It could be an impulse to gratify oneself because they're feeling agitated. They want to feel happy, so they imbibe sugar. But if it feels pleasant now, it becomes unpleasant later because we develop diabetes. So what is at the mind level? What are the desires that are driving our behaviors that lead to the problems? When you look at it in terms of obesity, this is the UK Systems Atlas for obesity. And you look at the causality of obesity, it's linked to individual psychology, individual activity, activity in the environment, biological issues and physiological issues. There's been a lot of emphasis here on pharmacotherapy with the GLP-1 receptor agonist, and then food consumption on an individual level, food production on a collective level. In the West, a lot of food production is driven here once again by profit. In the ancient times, many civilizations, food production was driven by purpose, with a healthy relationship with nature and farming techniques that were conducive to sustainability and human health and actualization. And then what about societal influences like social media, television? So you look at this, it's a very complex map of causality. And in the center here is one human being who achieves energy imbalance and then becomes obese and gets diabetes. So if you're going to solve the problems, it seems almost impossible to address every need in society externally to get one human to thrive. So, of course, we got to attend to these economic and other issues in the macro environment and provide support. But at the end of the day, how do we get a self-sufficient human that's able to not be influenced by an ever-changing world and maintain their purpose, their ideals, their happiness, and the bliss? Where do we get the biggest bang for buck, as they say? And it's always nice to look at old philosophy. Even Rumi used to say, what does this patch sewing mean, you ask? Patch sewing means when you put a patchwork on a area of damage on a piece of cloth or some clothing material. Eating and drinking, the heavy cloak of the body is always getting torn. You patch it with food and other ego satisfactions. It's very interesting that the world today is primed around acquisition and enjoyment. And I think ideals and higher purpose have generally been lost in a materialistic world. So we feel constantly unhappy. So we eat more, we drink more, we entertain more. And I'm not saying anything of any of these things is wrong, but when we do it indiscriminately, it can become bad for us. So with that background in mind, let's get into the deeper part of it. What is the anatomy of a human being? Now, we study anatomy in medical school as, studying flesh and bone and blood vessels and nerves and the lie of the land and, anatomy, pure anatomy. But, in the ancient books, the anatomy of a human was defined as something deeper. And what it was that the human being was made up of three components: a body, a mind, and an intellect. And these three components, sorry, it's coming up a bit slowly there, are the equipments the human being uses to traverse the world. So the body has the organs of perception and the organs of action. The organs of perception are the five senses, and the senses receive the sensory data from the world, and it gets processed in the mind. The mind is the seat of emotions and feelings. And the reaction in the mind drives the actions of the body. The organs of actions, which we act with, are the forelimbs and the tongue. So through speech and movement, we act in the world. So the mind is where all of our past patterns, feelings, likes, dislikes, emotional attachments, etc. exist. And the mind is the emotional personality, right? The feeler. Now, beyond the body and the mind, which is what we perhaps know something of, the third equivalent of the human being that we have is called the intellect. And this has to be differentiated from intelligence, which is pure book knowledge. And I'll highlight the differences in a future slide. But the intellect in human beings is of two types. There's the gross intellect, which is capable of thinking of the world. So whatever sensory data we receive into the five senses gets processed in the mind, and the intellect can observe this whole process and discriminate. So it's the thinking apparatus, okay? So the intellect, there's two parts, the gross and the subtle. The gross part is the thinker and has thoughts of the world, whereas the subtle part is what truly makes us human, that capacity to contemplate something higher than just this life. And that is the contemplator or the spiritual personality, you see? So ultimately, the human being is a hyphenated perceiver, actor, feeler, thinker, contemplator. Now, this is the anatomy of the human being. Now, the thing I want to highlight about this is beyond the physical body, the mind, and the intellect, there has to be some enlivening principle. And that is what we call in ancient scripture, in the Vedas, in all religions, the concept of spirit, perhaps, or soul, maybe, or God. Some enlivening factor. In the Eastern sciences that you are familiar with in India, we call it Atman or Brahman. Now, that is a concept beyond the five senses. In fact, it is what the five senses are reliant on. Now, ignorance of that truth leads to the formation of vasanas, which are the fragrance of the human being, the individual pattern you're born with. Then through life, we acquire more patterns, which are all in the mind. So the thoughts and desires are in the mind. And this manifests in what we call the BMI, the body, mind, intellect complex. The new BMI that I'm talking about is not really a new BMI. It's mentioned in all the scriptures, is body, mind, intellect. And I think the science we have today has been very heavy around the body. It's measuring anatomy and physiology. There's very little work done in terms of the mind, and psychiatry skirts on the border of the body and mind in terms of the physiological processes of the mind. Mind is more subtle, it's more expensive. Intellect, which is also known as buddhi, is not known to people today. It is the component of the human that, when well developed, can regulate the mind. And I think this is where a lot of the work has to be done in modern medicine if we are to develop a better approach, that we need to be aware of the full constitution of a human being. And knowing this, we can apply our science, practices, and mind-body medicine in a more practical, effective, logical, and purposeful way, ultimately. So if you look at it in a different depiction, you're all familiar with this coming from India, is that the kosha wheel. So the human personality is defined or diagramized as these circles. And what they say is at the core of your personality is that enlivening principle, which I've depicted here with the Om sign. Around that is the bliss sheath or the causal body, which then results in the intellectual sheath, which I've been talking about, is the buddhi part of us. And then there's the mental sheath or manas, manomaya kosha, which is the mind with all its thoughts and desires. And it is the mind with all its thoughts and desires, which can become turbulent in a human being. Is it not so? If the mind is agitated, we feel stressed. If the mind is agitated, we can feel angry. And I'll show you a slide on that right now. So it seems like the mental sheet, I put it in red, seems to be the area of difficulty for the human being, because that's where our thoughts reside. And as I said, our past patterns, likes and dislikes, joys and sorrows, and we are so enslaved by them that actually the human being has become a slave of the mind in modern times. So when you look at the sheet, the outermost sheet is the food sheet, which we call the Annamaya Kosha. And the food sheet, the physical body, actually is just what do you call it? It's just food. It's soil and water. It's the simplest part of us. That's why we call it the gross part of the human constitution. The subtle part is the vital air sheath, which is our physiology. And in the ancient times, they defined these physiological processes as well. Now, our focus in medicine today has been the vital air sheath. In endocrinology largely is physiology and hormones. Is that not so? So the point is that at the end of the day, the vital air sheath is the area that is susceptible to pharmacotherapy, in essence. This is where pharmacotherapy works. And when we apply those medications, it has an effect on the food sheath, you see? So if you think about the modern medicine approach, it's very limited to the outer two sheaths, yet the mental sheath remains ignored. So everything peer-reviewed is science, it's the outer two sheaths, but everything that was sage-reviewed in the past was using different cognitive systems to deal with the mind and develop the intellect. So what happened then in the past is the sages of the past found the outer approach wanting. So what they did is develop the capacity through yoga and different sciences to cognize this intellect and develop it. And as you develop the intellect, you can regulate the mind better. When you regulate the mind better, your physiology falls into place, and that will reflect in the physical body as good health, is the way they simply approach it. Of course, there's a lot more depth to it. And the whole idea at the end of the day was to rein in the mind through these practices of development of the intellect. So if you think about it, then breathing exercises at the vital air sheath level are the closest thing to the mind that we can control. So if we understand this anatomy or this kosha wheel, this is where we can understand how to apply yogic breathing practices. They help subdue the mind temporarily, but then it's got to be paired as well with intellectual development to rein in the mind long term so that it cannot be perturbed in the long term. If you're feeling agitated, the mind is agitated, the vital air sheath is affected with blood pressure going up, sugar going up, cytokine release, inflammatory markers going up, adrenaline going up, noradrenaline going up. And the constant mental agitation at the end of the day leads to constant physiological flux, which leads to constant problems with the physical body. You see, so mind-body practices must aim at subduing the mind. And in subduing the mind, we have got to apply the right knowledge systems to develop the intellect to manage the mind long-term so that it no longer reigns supreme over us. And ultimately, by subduing the mind and collapsing the mental sheath, the idea is that we merge into the bliss tree sheath, or that infinite bliss that we're all looking for, that happiness that I mentioned earlier, that the infinite bliss, Arthur Schopenhauer said, happiness is difficult to find inside here, but it is impossible to find outside. So these are Western scholars who read the old sciences and come to these conclusions that we need to go. Now, obviously, these type of knowledge systems require a lot of reflection and time. My job here at Synapse is just to introduce you to the concepts in a practical, scientific, and logical way and say, friends, there is an opportunity here for us to bring some depth to medicine, to reconsidering these concepts. Now, this is the BMI I've introduced you to, the limited body, the expanded mind. And remember, we call this the monkey mind because it usually has no direction, no dimension. Mind is very fidgety. And then the forgotten thing, which is the intellect, which needs to develop in modern humans so that we can regulate mind body. So then we get lifestyle interventions, right, when the intellect is developed. Now, this is what Sir William Osler said. So William Osler was a great physician and a teacher of medical students, and he was really passionate about it. A lot of our books are based on his approach to medical education as well. And he said the education of the heart, the moral side of man, must keep pace with the education of the head. Our fellow creatures cannot be dealt with as man deals in corn and coal. And I'll put it to you that even today's times, we seem to have actuarized the approach to healthcare. Everything is about numbers and economics and profits and metabolic markers. We can't just treat people with as a number. So knowing this anatomy now, it's very clear that if the mind is restless, we're more susceptible to unhealthy outcomes. If the mind is imperfect, less susceptible, but still susceptible. And the aim here is to get a perfect mind, a more stable mind, you see? And that is how we have to regulate the mind. So when we go into the idea of the mind, you must remember that this is how it works, that any action a human undertakes, anything we do, if you have come to attend this conference online, there had to be a desire there for knowledge. And a desire is nothing but a flow of thought. And one thought is a single thought that comes up from the mind. And that thought is based on your original vasana, your original pattern that you're born with, and all the acquired patterns. So maybe mommy and daddy said you must become a doctor, but you wanted to become an artist. And now you're sitting here and saying, I need to go figure out how to be a better doctor by attending this conference. It's a desire. And that action is you have set up your computer to listen to these talks. Or I desire sugar now because I'm feeling stressed. So a thought came up, I'm feeling stressed, I'm unhappy. And the thought flow goes towards a satisfaction by imbibing an object. That desire becomes powerful. The act is to eat the object of your desire, and it's impulsive because I just need it. But the idea is that the mind can be modified by a very powerful intellect, and the intellect needs to be developed to do that in people. So this is just to give you a little bit of depth as you zone into the mind then. So intellect can modify thoughts and desires before they become action. And this is not to say you must suppress the mind's desires or let it overindulge. Overindulgence is happening. Intellect there is not to suppress. Intellect is there to redirect things. I think this is an important part to be aware of. So you see, if your mind is left unregulated, then desires develop a force. They call it vega in Sanskrit. So that force of desire can become lust, desire for sensual pleasure. That force of desire, if it is not catered to, if you don't like what you're getting, becomes agitation and anger. If the desire is fulfilled and you like what you got, if you don't regulate it, you want more. You develop greed. When you get too much greed and power sometimes from that, you become delusional. The ego gets amplified and you believe only your worldview is correct. And with that, when you look down on people, then you develop a pride. I know better. I desired everything. I got it. I'm powerful. And anyone less than me has pride. And that will lead to a miserliness or stinginess. And this is what in Buddhism they call kama, krodha, lobha, moha, murder, and matsarya. It's in the Sanskrit sciences as well, in the Vedic sciences, sorry. So all of these, ultimately, these modifications of desire are nothing but synonyms for stress. And today the whole world is stress. And if you ask anyone to define stress, nobody can really define it. And then we start getting scientific studies that show that perceived stress will affect behavior, because when you stress, you want pleasure, you smoke. When you're stressed, your biology changes, your blood pressure goes up. When you stress, you're less likely to entertain physical activity, your diet quality can get poor, your body mass index goes up. So this is how thought, desire, and action play together. And the scientific studies here are correlating with that today. But we don't have to keep going into more scientific studies because the knowledge on the mind already exists. We just need to study it and reapply it in a modern world, I think is the answer. And this is just to show you some evidence that, stress does affect the biology. So what we think affects the physiology and the vital air sheath. And the evidence is very clear for that. So this is the point here also, that if the mind is purely left to its own devices, the human being becomes purely impulsive. This leads to insanity. These people, unfortunately, need to be institutionalized. But most people are here today. You see, if the intellect is well developed, 50% or 75% developed, it can regulate the mind. So we become less hysterical, less eccentric, more emotional, but the ultimate is a very sane person. So you see in the Eastern literature, a lot of sages and saints, even in the Middle East and Europe, very few in the West. I don't know of any American sages that have self-realized, to be honest, in history. Maybe someone can educate me. But the point is, it was all about developing the intellect to reach that infinite state of happiness within. So the work of human life is to regulate the mind, to develop a discriminative intellect that takes you to the higher truth within. And you can see the spectrum here of how that concept works. Now, there are also 3 transactions happening in the mind. I mean, in life every day. Now, if you look at it from this point of view, it will help us in understanding how policy, pharmacotherapy, etc. can work. You see, the human being is constantly receiving sensory input from the world. That's called receipt. That's the first transaction. The second transaction is that sensory input lands on the mind, in which there's a reaction. So if you like cricket and someone offers you cricketing tickets for free to go to a one-day match, The reaction is going to be excitement. The response is take the ticket, you see. So if a person likes chocolates and the reaction is, I like chocolates, the response is going to be, I'm going to eat the chocolate, you see. But that reaction may be past patterns which are indiscriminate. If the intellect can regulate the reaction, then the response in the long term can be better regulated. So you end up doing what you have to do rather than what you like to do. So if a diabetic patient uses the intellect to look at the reaction in the mind, doctors told me if I have this, HbA1c will go up, higher likelihood of amputation. I need to work. I need to look after my family. There's higher values involved. So it reasons with the mind and brings it down. And this is very important to understand. Remember, I said the mind is like a monkey mind. So the intellect is there to guide it ultimately, right? Now, intelligence is what we've been used to. And intelligence is nothing but gaining information. This is what artificial intelligence does. It's not going to make us think differently. It just gives you more info and quicker. Reliant external sources. So it means you get intelligence from outside sources, textbooks and teachers. It's about becoming informed and knowledgeable and a means to making a living in the world. This is how everybody is racing towards now, PhDs, etc. It's all university utilitarian education, which is not wrong. It's fine. But intellect is developed through scriptural ordinance, through thinking, through questioning, through parables, through logic and comparisons, and asking the question, is that so? And not taking everything at face value. And we need to do this every day for ourselves, invite our patients to do it, and start doing it from a young age. To develop the intellect is the need of the hour. I started off by saying the need of hour in medicine is to find some new way of looking at it. And I think the need is to develop the intellect here. And just a practical example of how this can be applied. Very recently, a randomized controlled trial of a behavior app on a phone improved glycemic control in adults with type 2 diabetes. And what happened here is they used an app with modules of teaching that challenged the personal beliefs of patients, their beliefs about macronutrients, their hedonic related beliefs, and beliefs about exercise. So they had all these trained old patterns in the mind, but the app served like an external intellect. It was appropriate to it. And the results were very interesting, that those that did the modules, and the more modules they did, there were better outcomes in terms of HbA1c reduction. And I don't have the slide here, but also weight and other markers like blood pressure improved. You can have a look at this trial. Now, what we're saying is an app is like a external regulator of your mind, which you got to keep engaging. Would it not be better if our own gyro, if our own app, if our own intellect was well developed and constantly doing that for us? So, you know, if you understand BMI, body, mind, intellect in the way I'm conveying it, then those scientists that are interested will develop these kinds of tools, not just to subdue the mind, but to also develop the intellect further. And I think all mind-body practices should have this aim in mind. One couple last slides just to make some points here. There's a lot of depth to the mind, and the only place you're going to find this contribution to understanding the mind is from Vedanta. It's the only knowledge system which has brought about the idea of mental temperaments. And no one human is a single manifestation of any one of these temperaments. We are all proportions of them. But if we understand them and assess them correctly in ourselves and our patients, then we know how to engage the correct activity. So tamas is inertia and lethargy. If a patient is predominantly tamasic, they are going to need some form of mind-body practice that induces action, something perhaps even firm, hard, maybe even painful, like hatha yoga and standing on one leg, to get them to become actionable. The very rajasic or passionate mind must continue to act, but they need to do a bit of karma yoga. They need to do breathing techniques daily to calm themselves down a bit and then develop the intellect through some little bit of study. And very interesting, the ancient Vedic sciences have already delineated the times of day when these are most active. And modern science through circadian physiology is coming to the same conclusions. The intellect and the serene part of the human being is most active between 4 and 6 a.m. So we must capitalize on study and thinking and reflection at this time. 6 to 6, we do karma, action, exercise, work with an unselfish attitude in service of the community. And after 6 p.m., perhaps wind down the night with some devotional practices, etc. I'm just giving a practical example of how this theory can be applied, and it requires a lot more time and reflection. And then, of course, the fourfold path of karma yoga, jnana yoga, and bhakti yoga can be appropriated individually according to the mental textures. Karma yoga for the body, the path of action, bhakti for the mind and devotion, and jnana yoga to develop the intellect. And as we develop the intellect, the mind has less thoughts and desires. You achieve a state of withdrawal and you can concentrate better, and then we become meditative. And I'll just make one very important point from a safety point of view. There's a tendency for Western sciences to extract the active ingredient of meditation and force it before the mind is prepared. And there is some data to suggest that that can cause adverse events. Whereas, meditation is just not a copy-paste practice. It must be, applied to a person who has done the preparation work, or it can be harmful because all you're doing is pushing the desires aside, and they may come back with a vengeance later, causing havoc in health and psychiatric well-being. In combination with this understanding of the BMI anatomy, we also have to start talking in medicine about higher fundamental values of life. Unselfish action should be preferred over selfish action. We must have a direction, objectivity to see things as they are. While we all have rights, our duty to individuals, collectives, families, and communities, nation, and the world trumps any rights. And we have to develop this attitude of giving and not taking. And gratitude is to be aware of everything that has been done for us, and we have to be grateful for. Sun rises and sets like clockwork. The trees are giving oxygen. The earth yields vegetation. And I think when ego is high and selfishness prevails, it leads to individual ill health and communal poor health and climate and community problems. This is where nations become demolished. And it's highlighted in this article, The Philosophy of Health, Life as Reality, Health as a Universal Value by Palgrave. Have a look at it. The reference is at the bottom of the slide. It's saying that we need to look at our decisions in a deeper way. And I think understanding the BMI that I've introduced and developing more theory of the mind and intellect to apply in modern medicine can help us become functional human beings that develop good well-being individually, but it affects our community, etc. In summary, the last slide is just showing you the BMI once again. And see, the body will benefit from evidence-based medicine and pharmacotherapy, prescriptions on diet and exercise. The mind, if it is very unregulated and the intellect's not developed, this is why we have policies on food marketing, sugary drinks tax, etc. And this is where laws sometimes need to be instituted to regulate population minds. But at this conference, you're going to hear about breathing techniques and different asanas, music therapy, etc., which were applied in the past. And these can temporarily subdue the mind and make it relax. And when it is relaxed, that's the best time to read higher knowledge, reflect, understand your constitution. And by developing the intellect through action, devotion, and knowledge, we can develop human self-efficacy, human self-sufficiency, and ultimately human actualization. So this is the BMI I wanted to introduce you to. And I think we need to do a lot more work here. My feeling is in resonance with what Plato said, and this is William Osler quoting Plato. On the account of the intimate personal nature of his work, the medical man, perhaps more than any other man, needs that higher education that Plato speaks of. That education in virtue from youth upwards. We've got to start intellectual development from a young age, which enables a man eagerly to pursue the ideal perfection. We're all looking for perfection. How do we do that? Develop the intellect, contemplate the higher truths, and let's weave it into medicine in a deeper and holistic way. And I think Synapse here is doing great work. I look forward to further engagements with all of you. And thank you for allowing the platform to convey these thoughts. Namaste.
Thank you, Dr. Sandeep, for that wonderful talk. We all will be carrying home this message of the new BMI, which includes all the concepts that you have spoken about. So having witnessed these three excellent talks, I now hand over to Dr. Vaishali Madam for further sessions.
Are there any questions from the faculty or from the audience?
So I don't see any questions.
Okay, thank you, Dr. Sharvil, and thank you, Dr. Ruder. I think your talks are quite insightful, and I think that's been the reason why you're here today. And we look forward to seeing you again at the workshop in July. So, thank you for being here. It was a pleasure to have you.
Thank you all.
So thank you. Thereafter, we move to the next session, which is again an interesting session on what Dr. Ruder said, that developing a positive mindset and positive psychology in day-to-day practice. I'm sure it's a very difficult task, but we will have our eminent speakers make that task easier for us in some form. So I hand over to Dr. Archana Juneja. She's a very good friend of mine, and she's been herself involved with a lot of activities which engage in positive psychology. So she's the right person to handle this session. She's DM, DNB, and she's completed a fellowship in endocrinology from Australia. And she's consultant endocrinologist at Kokilaben Dhirubhai Ambani Hospital, Mumbai. She's a PG guide for DNB endocrinology with special interest in neuro and reproductive endocrinology, thyroid, type 1 diabetes, and she has numerous publications in Index Journal. She's been a guest reviewer of British Journal of Neurosurgery, invited guest faculty at various conferences, national and international. She has various honors to her credit: Dr. A.V. Gandhi National Award for Excellence in Endocrinology and R.M. Patel Award for the Best Paper at Nair Hospital. So over to you, Archana, for the session.
Yeah, thank you, Dr. Vaishali, for that kind words of introduction. Thank you for making me a part of Synapse. I've been just attending a few lectures, and what an amazing start it has been. Dr. Ruder's talk was so insightful and so very true. We live in an era which we are constantly bombarded by external influences, be it the television, the mobile, the WhatsApp, the social media, and somewhere down the line, the mind just starts reacting. We just become a reactive material without even thinking, processing, and actually feeling or perceiving the event. So, and that probably what Dr. Ruder has really pointed out, and what the ancient sages, Buddha has been saying about, is what the mind stops reacting, and that's where the true pleasure actually comes down, and that probably would be the root cause of all medical illnesses which we face today. So Dr. Ruder told so well about the koshas, the Anandamaya Kosha and the Manomaya Kosha. And somewhere the mental health is what we need to start focusing on. Let's start experiencing true pleasures from within. And it's so true that when you really start looking at your emotional health, the mental health, that is your Manomaya Kosha, and you start moving upward, that is, you regulate your breathing and you regulate your food and you regulate your senses. So equanimity of the mind, which is very important. So it's very easy to talk about all these things, but how do we actually put them into practice? It's not really difficult. We just need a little refocusing of our goals and our aims. And today in this session, we have 4 eminent speakers. It's an honor and a pleasure to have all eminent senior stalwarts in this field. So for the first talk, I'd invite Dr. Shaila Sheikh, a dear friend, a senior endocrinologist from Saifi Hospital, Wokhart Hospital, and Prince Ali Khan Hospital, Mumbai. But more than that, she's a very unassuming but a very vocal lady. She is a member of the Endocrine Society of India Core Committee member. She's had innumerable publications, original research work in Ramadan and diabetes management. And what Dr. Shaila will be speaking about is hobbies. Hobbies, we all know, make us happy, but we know the theory part of it, but is there any actual science? So Dr. Shaila will be talking about all this hobbies as a positive psychology method, and how do we apply this to our practice, and what is this actual science behind it? So over to you, Dr. Shaila.
Good evening, everybody. At the onset, I would like to congratulate Vaishali and thank her for making me a part of this fantastic mind-body medicine symposium. To be very honest, I want to actually say thank you to Vaishali for thinking out of the box and making me think out of the box. When I first read the topic assigned to me, hobbies as stress busters, science behind, I was a little flummoxed. I was like, okay, what am I going to talk in this? I mean, is there some science behind hobbies? I just thought it was something you do. I mean, something that you like doing and something that you just do when you have time. Does it really help you? When was the last time I really indulged in a hobby? I started talking to a few colleagues around, and I realized that, yes, most of them do have long forgotten hobbies that they wish they could go back to, but somehow have never managed to have the time to do so. And the entire process of preparing for this lecture, to be very honest, was almost cathartic. And the reason I'm saying cathartic, because I learned so much, I read so much about it, and I think somewhere a little bit of me changed, and I began to understand that yes, hobbies are stress busters, and there is an enormous amount of science behind it. An enormous amount of science which maybe sometimes you're not able to absolutely quantify. And as scientists, which are so used to having quantification of everything, when you are actually not able to quantify it in absolute, maybe numbers, maybe in black and white, you're always having that, somewhere along the line, the query in your head that, okay, is this really for true? And I really honestly hope that you enjoy the next 20 minutes with me as much as I enjoyed reading about it and as much as I learned about it during the process. So when I actually went to something very basic, I actually went to what is a hobby? I mean, when I'm saying hobby, what am I talking about? And we realize that by the basic definition, it is something that you do for pleasure. Most importantly, during your leisure time. And an honest question, I mean, I would have loved this to have this topic in a physical meeting, because I would have actually asked all of you out there that where is our leisure time? Is our leisure time in midnight? Or is it that time also that we're looking at our mobiles and trying to see to that we keep in pace, trying to sort of, put the last like of the day for something which actually sometimes I really wonder has any meaning. But when you actually talk in concept, we talk about the concept of hobbies, this could be creative, this could be athletic, this could be intellectual, this could involve anything practically on planet Earth. For example, it could be dancing, it could be singing, it could be skating, it could be gardening, it could be anything that you actually enjoy doing. It could be meditation. I know a number of my colleagues who do Vipassana. Our chairperson over here is an expert in it, and I'm sure Archana could give us some fantastic tips on Vipassana. And of course, spending some time closer to nature. Again, I have friends who actually swear by hiking. So when you are talking about a basic definition, it is very simple. You do something that makes you happy during your leisure time. But tell me, friends, when was the last time you actually thought about a very big question? What makes you happy? Are you happy? A very, very pertinent question, I think, in present times. Is there data? You would be surprised. Apart from all those blogs that you read, there is actual data. There is a significant amount of data out there. And one of the papers which was very interesting was where it was categorically shown that yes, leisure activities which you enjoy are associated with both psychological and physical well-being. And when we are talking about the mind-body connect, we know that we are talking about both psychological as well as physical well-being, because both go in tandem. One cannot actually exist without the other. And I am glad that we're increasingly beginning to understand this. I'm glad that we're talking about this in the forefront. I'm glad that we are now, as clinicians, as a medical community, coming together to talk about both psychological and physical well-being. So when I talk about health benefits of hobbies, what would I talk in terms about? To this audience, definitely mental health, paramount importance. Our professional lives, very important to all of us, improves your performance over there, helps you solve problems better. Very, very important, builds better relationships with your co-workers. And last but not the least, makes you more empathetic. And empathy is, I would say, the second name for our profession, because unless you are empathetic about your patient sitting across you, unless you're empathetic with your staff, unless you're empathetic with your co-colleagues, you really cannot lead a fulfilled life. That is the area where hobbies do help you live better. And not only that, when you are actually doing something in your leisure time which makes you feel happy, it does reduce that enormous amount of stress that you face in the clinical world when you're actually working an actual practice. What was very categorically shown that adults, when they actually practice art, which can be any kind of art, simple art, they were more relaxed, they were more enjoyed, and they were more enjoyed and more aware of the time that they were spending in the art. And last but not the least, more helpful. What this also translated into was an increasing desire to continue improving their skills. And that's what happens. You realize that when your colleagues, you have some fantastic painters in this audience, you have some fantastic wildly artists in this audience, they have the desire to continue improving their skills and really always tell you that it really relaxes them. Cortisol, a hormone which is a stress hormone, it has always been conventionally associated with the fight or flight response. We know that when these levels were measured before and after these sessions, what was seen, that there is a noticeable decrease in this stress hormone. Don't we all want to reduce our stress levels? Is something very simple, something just below your nose, something that is easily doable to reduce your stress, really not being done? Overall well-being. What do you mean by overall well-being? This study in New Zealand actually very, very elegantly showed that when you participate in activities that bring out your creative side, which, to be honest, when I was reading this article, I was really wondering whether I had a creative side, but it did lead to an increased sense of well-being. Positivity, upliftment, less likely to feel low or depressed, happier, relaxed. Isn't that what we all are searching for at the end of the day? So what is it that still does not allow us to promote mental health when categorically it has been seen that both positive and negative psychological stress markers, when it was seen that when you looked at these markers, it was found that those who actually participate in leisure activities, they not only had a lower BP, a lower waist circumference, but also a lower BMI. In this epidemic of obesity that we are talking about, in this entire way, all the time are talking about lifestyle changes, when we are talking about medical line of therapy, when we are even talking about bariatric surgery, are we missing out the bus when we don't talk about mental health in our patients? Is this one of the major contributing factors to the increasing epidemic of obesity? Because there will be a significant number of patients out there who you would realize who do not respond to therapy in spite of following lifestyle. Is it that the hypothalamus, is it the hedonic center, is it the executive center, is it a combination of all these factors that is actually contributing to that inability to lose weight? Any kind of physical activity, especially if you take it outside, especially if you go a little closer to nature, even as minimal as 10 minutes, can improve mood and better focus. But how often do you and me do it in a busy day? We would have a number of excuses for not doing it. But are those excuses good enough? Because there are a number of studies out there which shows that people who actually take part in physical activities have fewer days of poorer mental health compared to those people who do not exercise. Again, a very pertinent question. Why are we not doing it? I think this available nights and weekends is something which is very, very relevant to us. We as doctors have become so used to being available nights and weekends. I think we almost get FOMO, and if I'm allowed to use the word FOMO out here on such an elite platform. I mean, my children always tell me, Mama, you get the feeling of missing out, and that's why you tend to look at your mobile at odd hours before you go to sleep on weekends. But what was seen is that employees who experience more psychological detachment from work when they have their off hours have higher life satisfaction and less psychological strain than those who don't disconnect from the job during non-work hours. Is this the reason why we are seeing more fatigue? Is this the reason why doctors are facing more burnout? Is this the reason why we are more tired? Is this the reason contributing to reduced lifespan in doctors? So many questions, still few answers. And I really hope that symposia like this do contribute to us actually getting answers as to what is the reason, why is it that we need to be available nights and weekends, and why is it that we cannot become more detached after work. And when it is very, very categorically seen over there that workers who are more detached after work were no less engaged while at work. Very, very interesting again. That means we need to detach. We need to not be available all nights and weekends so that we can actually recover from the psychological stress of work and be able to actually give more quality time with our patients, spend more quality time with our patients, and be able to give better output as doctors. Would short breaks help? They do. Even short breaks can improve attention. University students were given a task that involved sustained attention for 45 minutes. There were 2 groups over here. Dr. William Helton, who has done a lot of innovative work in the field of applied cognitive psychology, when analyzed these 2 groups, where one group worked for 45 minutes without any break. The other group took a 5-minute break. It could be anything. It could be simple breathing. It could be yoga. It could be taking a walk. It could be listening to music. A 5-minute break, but was given midway to one of the groups. What was seen, friends, was that all the students in the break groups actually performed better on the attention task. Why is it that the brain gets exhausted after any significant amount of prolonged cognitive effort? What is it that exhausts the brain? Is still an answer not completely, is still a question not completely answered. But the fact remains that if students are given a break during their cognitive effort, they do perform better. And that extrapolates even to us as clinicians, that if we learn to take a break in our busy schedules, we would perform much better, have much better outputs at the end of our days. Relationships. I think we all have been guilty of not really looking after relationships the way we would want to. Though doing activities in groups enhances your communication skills, it builds healthy relationships with others. But as groups, how much of activity do we really do other than work related? What was interesting is that though many people go through a sense of loneliness at different phases in their lives, if this prolongs for a long time, this can be unhealthy. And when it is prolonged, definitely it is going to result in poorer physical, mental, cognitive health. And when there is poor physical, mental, and cognitive health, we all know this is going to translate into some of the chronic non-communicable diseases like obesity, hypertension, dyslipidemia, diabetes. Now, what was very interesting when I was reading about this entire topic was that just not having sufficient social activity for a long duration, mind you, is as bad as smoking 15 cigarettes a day, an eye-opener. That means just no social activity. Is it equivalent to me smoking 15 cigarettes a day? Which is something which is absolutely taboo. Again, another eye-opening question for all of us to sort of chew over. Eustress. I found this again very, very interesting. Because even people who aren't overly stressed, I always thought that, if you have to be overly stressed and all these problems would occur. But people who are actually understimulated, hobbies are a nice source of eustress. And what do I mean by eustress? It's a healthy kind of stress where you feel excited about life, like, oh wow, I want to do this. If your life is dull, uninspiring, you just don't know what you want to get up in the morning. And often your patients will tell you, I might get up in the morning and look at the day and think, oh my God, the same day, there's nothing new. It's going to be the same routine. I just simply don't want to get up because it's the same routine. Hobbies, friend, can give you meaning, can give you fun, can break up a boring schedule. That means just the right amount of challenge for you to actually be happy in life. Actually look forward to something in life. It could be meeting your friends. It could be actually as simple as just gossiping. It could be so many things that you could be enjoying in your leisure time. And they could give you the right amount of challenge to enjoy your life, to actually experience eustress so that you can have a much more fulfilling life. Again, enjoyed reading about positive psychology, read a lot about positive psychology. And again, as I said, a lot more reading left to be done. So much of literature available out there, so much of literature available about mind flow, about mindfulness, about how do you make life worthwhile. As I said, I'm sure Archana would be able to talk much more about it than me. And you discover what actually brings fun to life. Because without fun, life has no meaning. And what is seen that if you do activities that bring fun to life, simple hobbies that incorporate pleasures into your life, your overall sense of joy does increase manifold. And this is again going to translate into a stress-free living, which is going to translate into stress busters, which is going to translate into reduce a number of reduced chronic metabolic diseases. One of the very important causative factors of any kind of NCD has always been stress, which we have always just read as one of the causative factors, but never really paid too much of attention. Never I try to understand and identify what we mean by stress. And never also try to understand and identify that how could we actually reduce this stress? Could gratification help? Where it's a challenge that requires us to use some of our personal skills and engages us in a sense of flow, where you actually have a near meditative state, where you lose track of time. You feel removed from the stresses of life and fully engaged in what you are doing. Actually, while making this slide said, I was wondering whether I'm getting gratified, because I did reach a point of time where I lost track of time and I was really fully engaged in trying to understand where do hobbies fit in and how do I actually understand better where could hobbies help all my colleagues who are listening to me. Sense of well-being, definitely. Reduction in stress, definitely. And all kinds of reduction in stress is going to translate into a reduction in all kinds of chronic metabolic disorders, the metabolic syndrome, even disorders like thyroid, as we all know, are increasingly associated with, whether you look at hyper or hypothyroidism, we have seen that stress is one of the precipitating factors. But as I said, difficult to quantify, so easily ignored. That is what we do in the clinical world. What happened in COVID-19? Did leisure engagement help? Did it help our adults to deal better with the situation? Was it a point of time when we connected with our inner self or with our families or with our friends, tried to understand better how to live life? Or have we forgotten the lessons COVID taught us? Data shows that yes, after controlling socio-demographic and context-specific covariates, what was seen that there is a definite association between changes in leisure engagement and, mind you, different aspects of mental health. It could be perceived stress, which was very, very visible in COVID times. Depressive symptoms, a number of our patients went through depression because of varied reasons, and mental well-being. All these aspects of mental health were helped by leisure activities, were helped by hobbies. And hobbies did play a very, very important role in facilitating stress alleviation and actually helped well-being enhancement during all these taxing events such as COVID-19. So why do we not turn to them when we are actually stressed out, when we are actually taxed? Why do we not turn to our hobbies? Why do we not indulge in leisure activities? Why do we all the time perpetuate this vicious cycle of stress begetting more stress and finally converting into a number of metabolic disorders? So take a break, friends. You deserve it. Work-free, responsibility-free time in your schedule. You need to recharge your batteries. Do something you enjoy. May be difficult. You may not be able to give yourself permission to take a break. But sit back, relax. Try to understand where you come from and where you are going. And how would you do that? How are you going to make time for hobbies? What are you really going to do? Are you going to be able to take time out every day? The biggest excuse that I hear, both from patients and from friends, is I just don't have the time. I simply don't seem to be able to fit what I want to do into my schedule. Are you prioritizing it? Why don't you take a long-term approach? Find gaps in your schedule that you can fill. Create those kind of gaps in your schedule. Recently, a very good friend of mine, I mean, if I can name his name, Dr. Sachin Mittal, I met him recently in a conference, and he told me, okay, ma'am, after every 2 hours, I practice 5 minutes of yoga in my clinic. I practice 5 minutes of breathing. And the 2 days that we spent together, he actually taught me how to do it. So it's not a question of not being able to do it. It's a question of actually making that time so that you can do it. If you are unable to do it every day, how about allocating a few hours every week? Or if you can't do it every week, every month for such activities. Maybe take a 2 to 3 day break. Maybe take a vacation. Maybe go for a long walk. Maybe go for a drive. Maybe listen to your favorite music. Maybe dance crazily on something that you would love to do. But do it. The reason do it, it is going to translate into a healthier mind and also a healthier body. Multiple small breaks during your work, the world will not end. If after, for example, every 10 patients, you take a 5-minute break and sort of realign yourself, it is going to actually improve your productivity. It is going to help your output. It is going to help you connect better with your patients. And that is what you want at the end of the day. Most importantly, what you need to really understand, friends, is what is it that is taking up most of your time? I realized a lot of my time was being spent on social media, looking at WhatsApp, trying to answer WhatsApp. And then I realized that the amount of time I was doing with that could easily be translated into doing something more constructive and to doing something that I would really enjoy doing. And once you become mindful, once you become aware that, yes, you can sort of, snatch a few hours from non-constructive activities into something that gives you happiness, into something that is going to really act as a stress buster for you, you realize that, yes, you do have an answer to all the significant amount of stress that you go through. I'm going to leave you with the final thought in my brain. If you are losing your leisure, look out. It may be you are losing your soul. Very, 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 very profound words, I would say, by Virginia Woolf. And I would like to end my conversation with you over here and hand it back to Archana. Thank you very much, friends, for your patient listening. And as I said, I hope this conversation with you does result in all of you going back today and thinking, what was my hobby? What is my hobby? What is it that gives me happiness? What is it that gives me pleasure? Because I am going to practice that. Because once I practice that, it does result into better mental, physical, and cognitive health. And at the end of the day, that is what I want. Thank you very, very much for your patient listening.
Amazing lecture. So many points, not only for us, but also to tell our patients. I feel we all need to prioritize. We are not supermen, we're not superheroes, superwomen, but we need to prioritize what we put on a plate, and leisure hobbies is a very important part of the food which we put on a plate. So I guess we all should move from FOMO to JOMO, that is joy of missing out. Very, very important. I liked your concept about eustress. And I feel it's very important because a little constructive stress, which excites you, which challenges you to think, to grow new connections. For example, my personal example, I'll tell you, I probably just enrolled for a dance class and I was dancing with children, 10, 12, 14-year-olds. And I had a tough time coordinating, telling my right thumb to talk to my left little finger, my right toe to talk to my left heel. And as I needed more practice, the kids were picking up quickly, but at my age, I had a tough time. But a few sessions down into the line, I'm realizing how my own synapses are opening up. And it's been a pleasurable journey so far, and I intend continuing it. It's not a long term, it's not a daily thing which I do. Probably, yes, what you suggested, that we slot out times. Maybe once a week, twice a week. But at the end of the day, if you see your progress in 6 months or 1 year, you've really gone a long distance. So that really would help you to, for our patients also, but to help them manage their stress better, the diabetes better, and lead a more happier and fulfilling life. Now, the next session is another wonderful session, and it's an honor to have Dr. Patwardhan with us here. Dr. Milind Patwardhan sir is a senior most endocrinologist from Maharashtra, and he is a wonderful human being. He's a qualified endocrinologist, but it's a joy to know him in person. He's the president of the Endocrine Society of India Maharashtra chapter, and he's also he's the director of the Endocrine Diabetes and Research Center, Meeraj. And sir would be speaking about music therapy in patients and would be sharing his experiences in this field with all of us here. Over to you, sir.
Thank you. Am I audible? Good evening, everybody.
Yes, sir.
I sincerely thank Dr. Vaishali Deshmukh and her team for this particular conference, which she's conducting for us for years. And I wish her all the best. Today, my topic is music, brain, and stress. Now, what makes us human? There have been many attempts to identify behaviors which reliably distinguish our species from the closest cousins. Bipedalism, use of fire, development of effective working memory, our vocal language, efficient communication have all emerged from these genetic environmental adaptations over several years. However, somewhere along the evolutionary way, our ancestors with very limited language, but with considerable emotional expression, began to articulate, gesticulate. It is called as a denotation before connotation. In other words, meaning in music came to us before meaning given by words. Music is revealing where words are obscuring. Music is very old, even older than language, maybe dating back to more than 40,000 years ago. The frequency band which mothers use to sing to their babies and so-called motheries, that is child-directed speech, with exaggerated intonations and rhythms, is universal. It naturally soothes us, irrespective of whatever language it is sung in. Music stands for the mystical expression of life, life cycles, celebrations, births, deaths, renewal of seasons, hunting, rituals of passage. in our society, it serves us on other familiar conjectures also, such as in dentist chair, waiting rooms, on the telephone, in the mall, in the restaurants, during air travel, helping us to relax or increase our patience. Music is part of our life since time immemorial. Music is a story of humanity. If it is a language, it is a language of feeling. Musical rhythms are rhythms of life. Music with tensions, resolutions, crescendos, diminuendos, major and minor keys, delays and silent interludes, with a temporal unfolding of events, does not present us with logical language, but something beyond language. Listening to the music has potentially many therapeutic effects on a range of mental and physical health conditions, or just as a way to cope with everyday stress of life. Music has proved its stress-reducing, calming properties even during surgeries under anesthesia and in ICUs during ventilatory support. You see, we have middle ear which has developed from the jawbones of earlier reptiles. It carries sounds of variety of frequencies with a limited range, and it is naturally attuned to the sound of the human voice, although it has a range much greater than that. But when we are in stress, when we are tense, we tune in to hear the environmental signals of high frequency sound and neglect the low frequency human sound. In safe situations, we reverse this perceptual preference and attune to lower frequencies. And therefore, when we listen to a human voice intently, mindfully, the brain gets the message that we are safe, and naturally our stress level comes down. See, this is the middle ear. It has 3 bones, and the muscles attached to these bones are supplied by sympathetic nerve, so that whenever we are under stress, these muscles become tense and a high frequency sounds are better picked. And actually, what is sound? Sound is nothing but a wave, compression and stretching of the air particles. And it's really a fantastic miracle how these sound waves of compression and stretching of the air particles, when they reach the eardrum, they're ultimately translated into the what we hear and understand as music and enjoy it. From the eardrum through the cochlea and the nerves, the first projection is to the primary auditory cortex of both the lobes. And from there, it spreads to secondary auditory cortex and then associated auditory areas. And ultimately, you will find that the music reaches to nearly every area of the brain. All neurons are ultimately stimulated by the music. So what is music? It is an art of sound in time that expresses ideas and emotions in significant forms through the elements of rhythm, melody, and harmony occurring and recurring in cycles in such a fashion as to please the listener. So it's an art of sound in time, means rhythm. It expresses the ideas and emotions in significant forms, and it speaks to our unconscious. It is through these elements of rhythm, melody, harmony, which keep on occurring, recurring, cyclic in fashion, that it ultimately forms something which is far pleasing to us. This is called as music. And it is the best exercise for brain, just as cardio is an exercise for heart. Similarly, listening to a music intently, trying to understand it, and it's a great exercise for brain. Music engages much of the brain and coordinates a wide range of processing mechanisms. This naturally invites consideration of how music cognition might relate to other complex cognitive abilities. The tremendous ability that music has to affect and manipulate emotions and the brain is undeniable and yet largely inexplicable. See, music reaches to nearly all areas of the brain: corpus callosum, motor cortex, prefrontal cortex, nucleus accumbens, and amygdala, which are involved in emotional reactions to music, sensory cortex, auditory cortex, of course, hippocampus, which is involved in music memories, visual cortex, cerebellum, which is involved in dancing, playing, keeping time, that is rhythm. So the perceptual processing is that the music is made of sound waves and enters the ear canal throughout the ear. And the primary acoustic circuit involves auditory nerve, brainstem, medial geniculate body of the thalamus, and the auditory cortex. The inner ear or cochlea, the transduction of music signal takes place here, and cochlea filters these signals and outputs are tonotopically ordered. These neural signals from the cochlea are processed by the auditory brainstem and sends them to the thalamus, and which then projects it into auditory cortex. The primary auditory cortex, secondary auditory cortex, posterior anterior auditory fields are also involved in the processing of music. These areas carry out perceptual analysis in terms of rhythm, pitch, intensity, and roughness. Now, cingulate gyrus, medial orbitofrontal cortex, and amygdala are found to have auditory projections, and this is the evidence to suggest that music activates these regions. These regions are actually involved in processing of emotional behaviors. Research on different neuronal responses to pleasant and unpleasant music shows that brain activity for pleasant music is predominantly present in frontal lobes and for unpleasant music in temporal lobes. Now, sometimes memories of our past experience are also recalled by listening to the music. These are called as flashbulb memory. Music evokes positive emotions. It causes catharsis of the negative emotions. It inspires the listeners, provokes thinking, positive thinking, and creates human connection. Coming to Indian classical music, the expression of raga rasa aspect, that is emotion or mood aspect, is considered the primary goal of Indian classical music. And this expression is intended to vary dynamically during performance. The presentation of the raga in ICM, that is Indian classical music, therefore evolves over time in various stages and dimensions like alap, then jod, then jhala, then gar, vilambi, drut, atidrut. Variations are introduced not only in melodic improvisation, but also in composition, tempo, and complex rhythmic cycle. Rhythm, by its simplest definition, reflects the dynamics of musical time. The origin of perception of rhythm can be traced back to the heartbeat the child receives as a mother's heartbeat's imprint, and it interprets it. The socio-behavioral impact of rhythm is said to be manifested in dance, designed to boost our energy levels in order to cope with fight or flight response. Now, it can be said that perceiving rhythm is the ability to master the otherwise invisible dimension of life, that is time. Rhythm is embedded in the right side of the brain. Music is hidden mathematical endeavor of the soul, unconscious that it is actually calculating. This time information is embedded in the right brain and is closely related to the movement of planning and kinematics. The relation between timing aspect of music and movement is emphasized by the concept of mirror neurons. Mirror neurons would be active when the individual is observing or listening to another individual articulating or communicating sound. In Indian classical music, there are at least 72 ragas, which correspond to 72 nadis of Ayurveda, and different timings are set ideally for each raga or each group of ragas. And this is a sort of wisdom developed over centuries by our forefathers and ancestors. For example, I will not tell everything, but after midnight, it is better to listen to Darbari Kannada, Malcolm's Asavari. In the pre-dawn, Purvi and Sohani. Early morning, Bhairav, Lalit, Ramkali, Jogi. Morning, Ahir Bhairav, Todi, Asavari. Forenoon, Bilawal, Bhairavi, Deshkar, Jaunpuri. Afternoon, Sarang, Bhimpalasi, Multani. In the dusk time, Patdeep, Puriya, Dhanashri. Evening, Hamir, Kalyad, Yaman, Marwa. Late evening, Desh, Khamash, Durga, Kedar, Jaijavanti. At night time, Pahadi, Shankara, Bageshri, Malhar, Chandrakons. And anytime, Pilu, Dhani, Kafi. So in short, our music is, you can say, associated with different moods, and therefore they have been given different timings. Your brain, when stimulated by music, carries on so many functions. For example, the brain, you can say frontal part of the brain, when it is stimulated by music, it releases dopamine, the feel-good chemical. The music, which is with a strong beat, produces changes in the ECG, or rather EEG, and slow brain waves are associated with meditative states like alpha or theta waves. Faster beats, beta or gamma, are more, you can say, associated with cognitive thinking. Music occupies the mind and something familiar and soothing. It alters the pain patterns, pain perception, improves your state of mind, and it also acts as a distractor from the problem thinking, problem thoughts. When machine learning was discovered for the last 2-3 years with help of artificial intelligence, what has been done is that the various moods are fed to the machine and various songs are fed to the machine appropriate to that mood. Now machine gives some questionnaire which the patient has to fill, and the machine decides from the different moods which are evident in patient's answers as to which song should be good for the patient as a part of music therapy. Now, raga, rasa, mood or color, what we call it. So, raga actually is related to raga ranga or color, and this color is of the variations in the mood, which is called as rasa. An appropriate mood has to be evoked in the listener's mind before initiating musical treatment. For example, Kafi Rag evokes a humid, cool, soothing, and deep mood, while Rag Puriya Dhanashri, evokes a sweet, deep, heavy, cloudy, and stable state of mind. Rag Mishramand has a very pleasing, refreshing, light, and sweet touch, while Bhageshri arouses a feeling of stability, depth, and calmness. Now, coming to our topic, that life is a continuous chronic stress response which has evolved to protect us from physical and physiological stress. Our life has become too complicated in too short a time than this response would evolve. The threat to survival got translated into threat to our ego or our self-image, and the fight, flight, or freeze got converted to tolerate, transfer, project, adjust, and somehow carry on in the life. Stress is believed to be one of the major factors negatively affecting our health. High stress levels have been shown to be strongly associated with many physical, emotional problems such as cardiovascular disease, hyperacidity, irritable bladder, irritable bowel, chronic pain, asthma, allergies, anxiety disorder, depression, burnout, and addictions. Stress is a general activation reaction, as defined by Sally, to a stimulus that could mean both a challenge or a threat. But Aldrin emphasized the negative part of it and defined stress as the quality of an experience produced through a person-environment transaction that, through either over-arousal or under-arousal, result in psychological or physiological distress. So stress is a common ground. There is a strong relationship between stress-related health problems and higher violence or crime rate, higher absenteeism at work, poor work performance. And to cope up with stressors, millions of people around the world use alcohol or tranquilizing medication, which is associated with numerous contraindications and negative effects. Since life means journey through the river of stress, it is difficult to provide professional support to all those suffering from chronic situational stress, either in school or workplace or in family. We should find out non-pharmacological stress reduction strategies which will help to improve psychological health of those sections. The non-pharmacological strategies, just now before me, Shaila Sheikh spoke about exercise or hobbies, developing hobbies like sports as a part of stress relieving strategy. I will be speaking on music. Of course, dancing, painting, sculpting, card games, reading, social studies, all these can be developed as a hobbies. Just like meditation, other self-help techniques, music is an important non-pharmacological strategy. When we get into a stress reflex or a stress response, our brain produces ACTH through hypothalamic pituitary axis activation. This ACTH acts on the adrenal glands to produce cortisol and adrenaline, and they produce the physical and physiological response in the form of increased heart rate, increased blood pressure, decreased digestion, increase in the blood sugar, increased respiratory rate, and also there is a emotional state associated with it. The physiological response to stress implies the activation of hypothalamo-pituitary adrenal axis, resulting in hypercortisolemia and release of adrenaline, noradrenaline, and increased activity of sympathetic nervous system, resulting in increased physiological arousal, such as heart rate, blood pressure, and cardiac output. The emotional response to the stress can be described as emotional states of subjective worry, such as state anxiety, restlessness, or nervousness. The state anxiety has been defined as an emotional response to an individual's perception of a stressful experience. Distinct stress biomarkers are affected by the music when there is stress, and therefore we can show reduction of cortisol level, decrease in the heart rate and blood pressure as a part of effect of stress. Stress acts on amygdala hippocampus. Music affects the stress-related emotional states, such as subjective worry, anxiety, restlessness, nervousness, state anxiety. So music can modulate the activity in the brain structures that are known to be crucially involved in emotional process. Now we should little bit get acquainted to the semiotics of music. Like if you read some papers done on Western music, you'll find terms like lexicon, syntax, pragmatic, semantics. On the other hand, in Indian classical music, for the same terms we use chalan or pakad of a raga. Pragmatics means thought or gharana of a raga, and semantics means mood or feeling or the emotion of the raga. Music has been used as an intervention for stress reduction, such as music activities like singing, music making, composing, music listening, maybe group listening or individual, or live music therapy offered by music therapists. And biological effects of the music has mostly been studied with heart rate variability, blood pressure. On the subjective side, from the musical appreciation, stress relief, emotion identification or balance, whether pleasurable or not. The messengers within the body which carry these signals vary from small to large molecules like cortisol, cytokines, immunoglobulins, and they also can be measured. And different types of music affects different messengers in our body. A study investigating variations in the emotional experience during different phases of raga elaboration found that emotional variations within ragas were often larger than between the ragas. Indian classical musicians have the ability to strongly vary the expressivity associated with a specific raga in their performances, but within the constraint of raga framework. So that is very important and very much great ability of our musicians. While the brain interprets the music, successive biochemical reactions which are occurring, they produce something which is called as activation of the reward area. Evidence indicates that music plays a role in activating pleasure-seeking areas of the brain that are usually stimulated by food, sex, and drugs. Prefrontal lobe allows the gate neurons to open the pathways to reward area, and once opened, they activate the dopamine burst producing neurons at the climax of the music, so that at the climax point or at the end of music, you feel chills on your body. रोंगटे खड़े हो जाते हैं. Some definitions like purposeful musical activity, self-administered music is called as music as medicine. When given by a therapist, it will be called as music therapy. It may concern music listening, music playing, and sometimes even songwriting, composing music. These are also called as part of music therapy. So music therapy is defined as a systematic process of intervention wherein the therapist helps the client to promote health using music experiences and the relationships developing through them as dynamic forces of change. Involvement of lyrics and emotions is very important. because lyrics add another dimension to the mood generated by the music. In India, we call this Nada Brahma versus Shabda Brahma. Nada Brahma means listening only to the sounds of music which produce their effect. And Shabda Brahma is the lyrics which adds meaning and evokes more or different emotions or amplifies the emotions and produces certain memories to come to the mind. Indian music therapy, in contrast to the Western form, which has its theoretical background predominantly based on psychotherapy, involves the expression of devotional feelings as a key fact. The most common approach used in the Indian form of music therapy is a raga-based approach. This approach is found to be stimulating, anxiolytic, increases attention, and is able to target musical preference and listening pattern. Now, what is a raga? Raga is based on the musical notes. There are 12 notes, 7 major notes and 5, you can say, minor notes. Now, each raga must have the note sa present in it. The raga must always belong to a thaat or a group of notes, so swara samuha. It should have aroha and avroha, that is ascending and descending order of the notes. Each raga must have either ma or pa or both, but cannot exclude both of these. So there cannot be a raga without ma and pa. And two forms of the same note ideally should not follow each other, but there are some exceptions like rag jogi, where Shuddha Gandhar and Komal Gandhar follow each other. The healing power of Hindustani ragas has been decided by our forefathers, but I appeal to all those who are listening to this that we should sincerely and scientifically investigate these claims and try to prove the wisdom of our ancestors. Some ragas like Darbari Kannada, Khamaj, Puriya are found to help in diffusing the mental tension in hysteria. Rag Mallar is known to pacify anger, excessive mental excitement, or manic phase, and mental instability. Rag Jaijavanti has been able to be effective in curing mental disorders or calming even schizoaffective states. Rag Todi is claimed to reduce high blood pressure. The biological effects of music, for example, when it was studied, the music of John Strauss, the waltz king, induced enhancement in atrial filling fraction and atrial natriuretic peptide, and also produced decrement in cortisol tissue type plasminogen activator. While Ravi Shankar's music resulted in lowering of concentrations of cortisol, noradrenaline, and TPA. The neurotransmitters. Music strongly influences amygdala, a part of the limbic system concerned with emotions. Music is associated with releasing endorphins, oxytocin, dopamine. These neurotransmitters play an important role in enhancing sense of our well-being and bonding. So amygdala, hippocampus, and prefrontal cortex in that succession are involved by the music, activated by music, and play a great role in elevating the anxiety, the stress or anxiety state. Listening to techno music was found to alter levels of beta endorphins, ACTH, norepinephrine, growth hormone, prolactin, and cortisol in healthy people. Critically ill patients who listened to Mozart's slow piano sonatas had increased growth hormone and decreased interleukin, which are anabolic. This is the anti-catabolic action of music. Appreciation of mixed selection of rock music increased the salivary immunoglobulin A level, indicative of improved immunity. So clinically, music can decrease pain and anxiety, increase relaxation and decrease state anxiety. In addition, music is used as a process to distract the person from unpleasant situations and sensations, and definitely music can be effective adjunct to pharmacological therapy of many conditions, including even antiemetic regime is helped by associated music. Raga Todi, listening to certain ragas, for example, Desi Todi for 30 minutes every day for 20 days has been shown to produce significant decrease in systolic and diastolic blood pressure without producing any side effects. It reduced stress, anxiety, depression, enhanced feelings of life satisfaction, experience of hope and optimism. Changes in the heart rate, of course, are more prominent in females. Karnataki raga, rag kapi. This is not kafi. This is kapi raga. the Indian classical music with incremental variation in tempo and octave, that is starting with Vilambit, then Drita, and then Ati Drita. This was examined in two sets, that is varying music, that is going from Vilambit to Drita and Ati Drita, and while other participants listening to stable music, that is only Vilambit Khyal. Now what happened? The significant anxiety score reduction was seen only in variable music. That is what we classically listen to in Indian classical music. So variable music induced controlled mind wandering state involving balanced switching between the heightened mind wandering, that is attention to self, and reduced mind wandering, that is attention to the music. Rag Bilhari, this is something like combination of Bhoop and Deshkar. This music therapy again in Carnatic Raga showed significant changes, decrease in the depression, anxiety, and stress scores. Deshmukh et al. Also reported effects of this raga persisted beyond the treatment period. Rhythmic auditory stimulation is used often in cases in gait training where patients have lost their ability to walk properly, such as in Parkinson's disease or recovery from stroke or after a brain injury. While listening to a set of auditory cues, the patients are able to time their movements with the perceived rhythms and quickly gain control of their muscular movements. It is assumed that specific characteristics of music may have impact on stress reduction. Music tempo may be considered as one of the most important moderators. For example, a slow tempo, 60 to 80 beats per minute, is a meditative music, or also called as alpha beat music, and it produces greater relaxation. So in summary, music reduces the effects of stress. It lowers our heart rate and cortisol levels. It releases endorphins and improves the sense of well-being. It distracts us, reducing physical and emotional stress levels, reduce stress-related symptoms, whether used in clinical environment or in daily life. Active participation is music composing, performing, dancing, while passive participation is intently getting involved, involved with anticipation, yet ready for surprises. And having an upbeat music as background ambience is known to affect mood, motivation, speed, quality of work. A pre-recorded music selected by a patient himself is called as music as medicine, while music therapy is offered by trained therapists. Some studies measured the differences in the stress levels between the participants receiving live music, and those receiving pre-recorded music, and it was found that live concerts appear to be more stress-reducing than pre-recorded. The study of effect of Indian classical music on brain activity using EEG signals while listening to music, there is increased frontal midline theta power, and the same effect can be seen during meditation. Music with a range of 60 to 80 beats per minute has calming effect on the brain, and it mainly depends on the pitch, harmony, and melody. Music reduces stress and also decreases hypercatabolism, as evidenced by increase in the growth hormone level and decreased production of cytokines such as IL-6 by WBCs. Dopaminergic neurotransmission is implied in the means by which music modulates the central nervous system. This is in critically ill patients in ICU, and it was shown that music definitely increased their growth hormone and converted their catabolic state into anabolic states. In music medicine, by using questionnaires, music listening has resulted in noticeable reduction in stress. And in this context, it is found that particularly favorite music might help. So don't be under the impression that only classical music will help you. No, whichever music you like, your favorite music, which you listen with all your mind, all your heart, all your interest, again and again, it is known to help you in reducing pain and anxiousness more than any other music. So it is a psychological phenomenon which suggests that more exposed to we are to something or someone, we like it. Repetition in the music is important. Both familiarity and repetition may increase the liking of a piece of music, thus including or inducing positive emotions. Familiarity is in the music has been reported as an important factor modulating emotional and hedonic, that is pleasurable responses in the brain. Neural correlates of the popular music phenomena, that is, when Gangman style music was examined, it was found on, functional MRI to produce lots of pleasurable experience, strong emotional response, and activation of major parts of prefrontal lobe. Left putamen is positively correlated with the mood arousal level score under Gangman style condition. While Korean, for example, Blackpink, is quite relaxing music. Sing-along response, that is, this could reflect an audio-motor synchronization to the rhythm. And then when you sing along with the music in your own mind, anticipating the melodic, harmonic progression, rhythms and timbres and lyric events, this causes recruitment of limbic and reward center in the brain. Old songs can be as fresh as new. The subjects kept processing the meaning of the lyrics, even though they had listened to the same song again and again many times. So the fact that repetition, which is the essential characteristic of familiar songs, did not diminish the meaning processing of lyrics, suggesting that the lyrics and the speech may differ at a higher communicative level. So again, summarizing, music listening is strongly associated with stress reduction by decrease of physiological arousal as indicated by reduced cortisol levels, lowered heart rate, decreases in mean arterial pressure. Music can also reduce negative emotions, feelings such as subjective worry, state anxiety, and increases positive emotions and feelings like happiness. So many areas of our brain are stimulated, and therefore there is definite evidence that the brain of musicians is definitely different in these aspects as compared to those of non-musicians. So my take-home message is that music has calming and stress-reducing effect. Indian classical music is a treasure house of all that is desirable. It is our legacy, and we need to seriously and scientifically study to establish the wisdom of our ancestors. And just like exercise, meditation, and yoga, we should inculcate 20 to 30 minutes of music into our life on daily basis. You must take active interest, develop your favorite music library, and use it as your own de-stressing armor. And I am literally thankful to these people who have made our life so rich. We can't express our gratitude enough to this. So with this, I stop here. If there are questions or discussions, I would like to be here so that I can take part in it. Thank you very much. And thank you, Vaishali, once again, congratulating you for organizing this good and great meeting. Thank you.
Thank you, sir. That was a fantastic exposition. I mean, it's a complete thesis topic on music therapy, not only for us, but take-home messages for our patients also. Because we're running short of time, if there's any question, we can quickly have a question. But I think it was a complete revelation and complete theory, practical, everything. So I guess there are no questions. So for want of time, we'll move to the next topic. And our honor. Yes, sir?
No, thank you very much, I said.
Yes, sir. Pleasure, complete pleasure. Thank you, sir. So would like to invite the next session is Professor Reinhard Vogel. It's an honor to have him here. He is the alumnus from Regensburg University, the president of the Yoga Forum Munich. He's also been the professor for Center of Behavioral Medicine, has initiated Indo-German collaboration on neurosciences of yoga, office bearer for the International Association for the Study of Traditional Asian Medicine, visiting faculty, Technical University Munich Institute of Sports Sciences, organizer of the Munich International Symposium on Health Promotion, Mind, Body Medicine, and Yoga. He's been associated with several European health promotion projects and research studies since 1985. So more than 4 decades of work in this field of yoga. And it's a pleasure to have you, sir. Welcome you, sir, for your talk on yoga in the regulation of circadian rhythms for helping our patients. Over to you, Professor Reinhard.
Yes, thank you very much, Dr. Arjuna. Is my slide visible?
Not as yet, sir.
This is the question.
Yes, it's playing up. Just yes, we can see it. We
Yes,
can
great.
put it on the full screen mode, sir.
Yes.
So you can click on the bottom icon, which is showing as the PowerPoint show mode.
Okay, I think we have to keep it like it is. I start, I think, especially by Charlie and all the organizers for the opportunity to show this very important part. And I thank all these a lot of speakers before me have already mentioned the whole topic, and I don't go into the medical part of it. I just show this one picture of the human biological circadian clock. I'm lucky, I'm in Munich and near to Munich. There was early research on this biological clock, where they put, knew also some people who went into that for 2-3 weeks. They put him into a place where there was no light and no clocks to find out whether there is a regular inner activity going on. And this was the first idea, that there is an inner clock. And then now we know that in every cell is a 24-hour clock. This is the most important information. And this is in every cell of the human being. It is in animals, it is in plants. The life on this planet, which is with sun and moon in a 24-hour cycle, is the life which is also recognized by an inner clock, and we are not dependent only on the outer clock. You can understand that this inner clock is a coordinator for all these activities, whether it is in the morning when you look at this, the blood pressure rises there, the bowel movement is there, the melatonin secretion stops, then it becomes a phase of higher alertness. And then at night, we have the highest blood pressure and the highest body temperature, and then night starts and sleep comes and the bowel movement is suppressed, and there's a sort of recreation. If we go back to the ancient knowledge, we see that the Ayurveda 2000 years back had already mentioned this circadian rhythm, and with their idea that there are 3 main functional systems in the body. One is functioning regarding the hot phases, one is regarding the cold phases, and the vata is responsible, like similar to the nervous system, to coordinate the whole things. So we have a hot phase, day phase, and we have a cold phase, night phase. Cold phase, like in plant, is for growing and recovering, and the hot phase is for using the energy for activity and work. If we have understood that there is this 24-hour cycle going on, the next question is, and this is the topic which I am happy to have, this is how can we make regulations in these whole activities. So main ideas of regulations is, number one, to understand that there is a 24-hour clock within us, and that this can work in a proper way or in an uncoordinated way. Then there is a coordination between the inner and the outer world, and if this is well coordinated, then living is healthier. This we know from shift works, from the flight people who fly overnight and all these things when they change the time zones, that this gives a big disturbance to the whole body. And we had one friend here, one women doctor, a ladies doctor, and he said these ladies which are in the flight attendants, they have big problems with the menstrual period, and this was also a topic today, the sexuality and this very important women's cycle, and that it is for him not possible to change it back to a normal cycle because it's so disturbing. This is the number one. Number two is sleep. We had already a sleep, and it's not so easy to have a restorative sleep, but the importance of sleep we have already seen. Then we come to the wake-up time and the thing of the activity. This is, I will explain in details a little bit later. Then we have the eating rhythms. When does the food enter into the body? Then this is one also main factor of regulation. And we have the activity work, leisure time, which we had two wonderful lectures before me about hobbies and about music. The wake-up time is very important because we know that the light is an important stimulation for the coordination of the inner clock with the outer clock. Inner clock in most of the people is a little bit quicker, then it is 24.3 hours around about, little bit quicker than the outer clock, so that there is a need of daily synchronization of the inner clock with the outer clock. And one of the main points of synchronization is the light, and especially the light in the morning. So the yogic idea is to have access to the morning light. That means you stand up at the time when the morning comes, when the light comes, and you sit or stand or however, look into the eastern part of the world where the light starts, or you have your bedroom. If you have the chance, you have your bedroom with the window to the east, so that in the morning the light of the east falls into your bedroom, and the first thing you see when you open your eyes is the light of the morning. So this is the idea. Therefore, we think that the best idea is to have yoga in the morning and to have this experience of the light, so that the inner world and the outer world wakes up at the same time, and we have this synchronization. If this is not possible, the best idea is to have 30 minutes plus of light every day, and natural light in the outside, and it does not differ if there is sunlight or if there are clouds. With clouds, the light is enough to stimulate the brain through the eyes with this light. Then eating is one of the important factors of the regulation. And eating, of course, is not only eating, it's also a social communication. Most of the times we eat with other people. Most of the time we don't eat alone. And eating is the best thing is 2 to 3 times per day. And of course, drinking 8 times a big glass of water 8 times a day. And the main time of eating is this, when you want to regulate the circadian rhythm, the inner clock in a good way, is to have 10 hours time to eat. That can mean from 8 o'clock to 6 o'clock at night. And then, of course, if you eat at that time, you have 12 or 14 hours of fasting where you don't eat. And this is good for regulating And this is now the main idea of this modern intermittent fasting, where you think there should be a time of fasting, but this is the natural way, which Ayurveda 2000 years back thought is a good way. Eat after you wake up in the morning and eat at night early, and then you have a long time where you don't eat. Then this is good for the digestive system. So because the digestive system otherwise has this load of food which is in the night, and in the night there's no digestion in this sense possible as in daytime, and then you have eaten your breakfast in the evening. Then activity and leisure time. This is a balance, work-life balance is called today, but as I think work can also be very nice, and I think you are doctors, you all work with patients and you love your work, so it is not in this sense that it's not a nice time for you. The work itself can be a sort of leisure time and a sort of hobby for us. This is possible. And then balance it again. Then the main yogic idea, of course, is avoid avoidable stress. We have here heard so much about stress today, and so it's clear that the stress is, we heard in the last lecture about all these physiological reactions of the stress. So stress is not good, and we should be in a stress-free situation. If we look at again the biological clock, 24 hours, then when we start in the morning, I have here start at 6 o'clock, but you can start at 5:30 or at 6:30 or at 7, whatever. This is all plus minus. The main idea with the circadian rhythm clock is to have it more or less regular and not to change every day. Because the inner system makes some expectation what will happen. And if the same thing is happen every day, the expectation and the prediction, the brain makes predictions, and if the predictions are fulfilled, then it is satisfied. And if the predictions are not fulfilled, the brain is not satisfied. So it's good to have a sort of regularity with plus minus variations. In the morning we stand up, we wake up, then the best time is to have some yoga meditation, some light, and then after time, of course, toilet and whatever, breakfast. And this is a modern idea, which I don't know whether yoga had it or not, but if you practice yoga and you practice it, you have 1 hour between getting up and breakfast. And this is a modern idea of the biological clock, that it is, digestion is not ready for food, and it needs 1 hour around for making the inner system ready for food and for digestion. Then comes the screen period, between whatever 8 o'clock and 12 o'clock or 7:30 or whenever you want to start, or 1 o'clock. This is a phase where the main activity of the day should be, and the preparation at night for this time is done, and you can use it. The best thing is to utilize the energy which is there in a proper time, that is the morning time. Therefore, the main morning activity, work activities should be in the morning. This is the old yoga Ayurveda idea. And then the less important idea, more routine activities, there is in the afternoon. Then at noon, this is the old idea, like the sun is in the highest place. The inner heat is also in the, when it is well regulated, is in the highest phase. And then it's a time to replenish what you have used. And this is the idea of yoga and Ayurveda. food intake, you replace what has been used so that it is again filled up and digested at daytime. So the afternoon time is 3 hours, 4 hours digestion time. Therefore, this time should be filled with more routine activities where the inner activity is not so high. Then evening, of course, is the end of the main work. And then you have a time for family, walking, friends, whatever, the hobbies. As we have heard, then at a later time you go to bed, 10 or plus minus, and then you have enough sleep, which is very important, 7 to 8 hours sleep. And then in sleep, we know there's no real digestion, so it's better to have no food. So these are the main points. They are simple: light, food, sleep. And the only thing which I did not mention is temperature. I mentioned that the highest temperature is at noon and in the afternoon, lowest temperature at night. This is also important. Exercise I mentioned. You can do yoga in the morning. I will explain in a minute what other times are good. And the last thing is social interactions. We know that the social interactions are one of the strongest factors to regulate the circadian clock. That means if you have a flight and the time change by flight, the light is one thing, the food is one thing, the sleep is one thing, but the best thing is to make an appointment with friends, with family members. And this appointment is a big stimulus for the coordination of the circadian clock with the new time in the place where you arrive. And this means also that at this time, the main activities, the main appointments in the morning, the second appointments in the afternoon, and then the friends, family appointments in the evening, they are an important factor of regulation of the circadian rhythm. If you want to practice yoga or sports or whatever, meditation, we have the first time is 7 o'clock in the morning, and the second good time is at noon before food. Third good time is in the evening before food, and the last good time for some relaxing asanas is at night before going to sleep. Then if you think what was discussed, what people say, we don't have time, and then first is what our president, honorable president, former director of the Sports University in Munich, he explained in a lecture. He goes in the morning in the bathroom, and then in the bathroom he starts with standing 2 minutes, and then he makes a half dog pose 2 minutes, and then he makes uttanasana 2 minutes and some more, one leg balance, and then after 10 minutes he has done his yoga, and he said when he comes out of the bathroom he has done his yoga already. So this is the point of how you can do it with a little bit of fun. Or the other thing is to have this 1 minute, 2 minute, 5 minute pauses every hour, every second hour, which we have heard, and do some half dog pose I will show in a minute, or some important free breathing that you just sit and observe your breathing and have try to have free breathing. I will also make it with you in a minute. Okay, this is the timing, and of course you can also have all type of sports in this timing. Only sports, they should not be sports which in itself creates stress. Quite a number of sports in itself create stress, and they are not helpful for the modulation of the regulation in the circadian clock. If people want to lose weight, this is the best thing is to have sports in the morning before breakfast. We have studies for that, and you drink something, water, coffee, and eat nothing. Have your 20 minutes of sports, and then this is a better time to have it than in the evening. In the evening, you have a good place, as we have seen here, for coordinating things. There's a good muscle strength and all that, but it's not a good place for reducing weight. Then we have one pose which is very interesting. This is this pose. You can try if you want, or if you don't want, you just listen. This is a half dog pose, and you can use it in your all varieties, a little bit higher, a little bit lower, a little bit with bent leg. This is a very clear but very easy and helpful position, which you always can make in the morning. You can make it in between without any yoga clothes. And then this is also a pose where you can have your 1 minute of free breathing. That means you make it first 40 seconds. This is the time which organism normally needs to come to from the position-dependent breathing state where free breathing is possible, and then you stay a second, meaning with this free breathing. Or you can make the same thing in sitting. Let's show it in sitting. This. Sit here, chair, and you can have a simple version of lotus position, Padmasana. You sit on your sitting bones, you have your sidelines straight, you have your hands on the stool somewhere here or there, and then you sit and you allow yourself to free breathe. This you can do for 1 minute. Okay, so these are the basic ideas. In the discussion later, you can ask questions and I can say more. I thank you very much. Thank you for the invitation, and Shali, thank you very much. And and so I give back to this.
Thank you, sir. Thank you. That was very informative. And I'm sure that all these principles of yogic lifestyle is going to be one of the greatest learning of today's talks. So any questions that we have from any one of you? I don't see any questions in the chat box. So nice hearing you, and hope to see you in India sometime.
Yes, sure. Thank you.
I have started practicing your sitting technique, so it's helping me.
Good. Thank you, Vaishali. Great.
Thank you, sir. Thanks a lot. Yeah, so now we move on to the last talk of today, and we have Dr. Vikram Rajadnya. He's a college senior of mine, and I just got introduced to him of late as a sports and clinical nutrition person. So it's my pleasure to welcome him as a medical consultant in nutrition, exercise, yoga. He's actually in Kolhapur, but he belongs to Pune. And he's done MBBS from BJ Medical College and MD Clinical Pharmacology from Pune, and followed by clinical nutrition course in NIN. He's been a national gold medalist sportsman, over 20 research publications to his credit, and 25 years of teaching experience to UG and PGs in consultant nutrition, exercise, and yoga. So I'm very keen on listening to his practical expertise on handling diabetes patients with all these techniques. So over to you, Dr. Vikram.
Yeah, thank you, Vaishali, for the kind introduction. Let me share my presentation.
Dr. Vikram, I can't see you. Your screen is...
Yeah, it's coming now.
Yeah.
Can you see my slide now?
Yeah, I can see your slides. Make it full screen, and we can't see you.
Okay. Yeah, but actually slides are properly visible.
They are very small. You'll have to enlarge them.
Okay.
Sir, are you sharing it from a mobile phone?
Yes.
Yeah, so just make them go to the view settings and make it full screen.
Where to go, sir?
In the view settings of the presentation.
View settings?
Yeah. Or just make the mobile phone horizontal.
Okay, I can do that. I can rotate it.
Yeah.
I think that will be easy for me actually.
Yes.
Is it okay now?
That's better, perhaps.
Yes, that's perfect.
Thank you. And my voice is clear to you all?
Voice is clear, yes. Your video is not seen.
So let's begin. My topic of presentation is exercise in diabetes and exercise in obesity. I will be focusing on my practice vignettes, that is my experiences in my practice over the last 25 years. Already Vaishali has given nice introduction about me. I have been working for almost last 25 years in the field of clinical nutrition, exercise, and yoga, as it is applicable to mainly chronic non-communicable diseases and sports people. Now, philosophy of exercise is very simple, both for diabetes and obesity. Sit less and move more. But this is absolutely simple to understand. पण मराठीत जसं म्हणतात ना, कळतं पण वळत नाही, for those who understand Marathi. We are sitting more and moving less, right? So let's go to the next slide. For non-communicable diseases, American College of Sports Medicine, which is the prestigious, one of the world's prestigious working body in sports medicine, says exercise is the best medicine. I would like to add nutrition, exercise, and yoga. These three are the best medicines to deal with chronic non-communicable diseases. And over years of my practice, I am very confident to say that these are really the best medicines. Let's move to the next slide. Of course, I will be sharing my experiences with you in the field of obesity, diabetes, especially type 2, because it's very common. And of course, type 1 and pre-diabetes as the case may come. Now, just through the academics, we'll go very briefly. Benefits of exercise, we all know major of the benefits: glucose levels improvement, cardiac risk reduction, weight reduction, other risk, for example, renal complications reduction. Exercise is good antioxidant and anti-inflammatory, because we all know by now that obesity is not just carrying the burden on the body, it's an inflammatory disorder, which can lead to a lot of chronic inflammatory disorders along with it, which we call as comorbidities. And last but not the least, psychological benefits to the patient. These are very, very important. My experience tells me that some patients might not show results on the weighing scale or the sugar as much as we want to, but they derive great psychological benefit out of exercise routines. And never undermine or never underestimate the psychological gain that the patient gets. It's really helpful for the patient as well as you to go ahead. My next slide is about the risk of exercise. Of course, there are always risks associated with exercise, because in all other therapies, just by previous speakers, they're speaking about calmness, melody, and relaxation. But exercise is real hard work. Every physiological system is stimulated. And of course, we are under a lot of risk. But believe me, the benefits of exercise far outweigh the risks associated with exercise. But risk whenever they can occur, especially when the patient is negligent, can be very, very tragic. As we see recently that a lot of youngsters or middle-aged group people, while doing exercise, they have died of cardiac arrest, you can say. There are some celebrities also. So just to enumerate: hypoglycemia, hyperglycemia, cardiac complications, transient albuminuria, joint damages, ulcers, wounds, amputations, and of course sudden death. These are the complications associated with exercise. I would like to just highlight one point here about transient albuminuria. Every exercise, maybe it is cardiopulmonary exercise or weight training, they are likely to cause transient albuminuria, or they are likely to increase the albuminuria which is already pre-existing in the patient. But it is absolutely innocuous. After 48 hours or 72 hours, it will completely disappear. And patient should never stop exercising because of albuminuria seen in routine testing. There are broad guidelines available how to deal with fasting sugar and then insulin dose, carbohydrate intake related to exercise, medications and exercise, other comorbidities and exercise, especially the cardiac comorbidities. A diabetic having ischemic heart disease, carrying some arrhythmias, he should be consulting a cardiologist before starting an exercise program, because these comorbidities can be really dangerous, especially with diabetes. I'll go to the next slide. Mechanisms of benefits of exercise. There are increased glucose uptake and utilization of sugar or glucose in the cells. Second one is very curious. Increased islet beta cell function has been mentioned, of course, in type 2 diabetes as a mechanism of benefit of exercise. And this is a very curious, finding or mention in research publications. Of course, increased insulin sensitivity, increased lipid hydrolysis, reduced obesity-related inflammation, BMI reduction, we all know about it. Continuing with the mechanisms of benefit, another very curious thing is modulation of DNA methylation. It means, in short, exercise has got its role even at the DNA level. And through DNA level, sugar uptake or glucose uptake inside the cells, lipid mobilization and metabolism, it is influenced by exercise. And this is a very interesting and curious finding. There are some recent mechanisms also. I will just mention one of them. I have written iris myokine here, OC osteokine here, ADP adipokine here. These are the chemicals which are recently found. One of these I would like to just mention here is irisin myokine. And interestingly, irisin myokine is said to convert white adipose tissue into the brown adipose tissue and increase basal metabolic rate or fat burning capacity. Frankly speaking, this was a very curious finding for me, because since UG days, we have learned that only infantile stage or till early few years of our life, we carry brown adipose tissue and later on it disappears. But it's a very curious finding associated with exercise. I have experienced over the years that nutrition and exercise as a combined approach is far better than exercise alone, and also far better than nutrition alone in both obesity and diabetes. Why I have put up this slide here is because a lot of patients, if you are running an OPD of lifestyle medicine, will come to you and they will be very curious to know whether they can do rigorous exercise and avoid doing nutritional practices, because doing diet is said to be a 24-hour job and doing exercise is just said to be 1 to 1.5 hour of job. So patients find it very, appealing to do exercise and neglect nutrition. Now, next point comes, whenever a patient comes to your OPD of lifestyle medicine, especially, I'm not saying routine diabetic OPD, and lifestyle medicine, how extensively should we be testing these patients? I will just give one example here. There is a diabetic who is just a beginner in exercise, wants to do very basic exercises. He's asymptomatic. Do not do any extensive testing, because even if as a physician we want him to undergo some tests, let's postpone that, especially with these kind of cases, because extensive testing will put off your patient and all his enthusiasm will go away. And the patients are put off. That is the best word I can use for this. I have mentioned other extreme also. An advanced exercising diabetic who is doing a lot of weight training, maybe doing marathon, or he is symptomatic one. He needs proper diagnosis or diagnostic testing. What exercises? It should be a mix of various types based on patient's current fitness, age, comorbidities, and so many other factors. It's a clinical, a judgment the physician has to carry. I have picked up these images from the site Pexil, and I'm thankful to them. I was needed to acknowledge them. These are the cardiopulmonary exercises that we all know patients will routinely do. Of course, selecting among these is a personal choice. But I usually ask my patients to refrain from running because or swimming for safety purposes. It's, a patient is swimming and he gets some complication, it's very difficult to take him out. Only for that purpose. Otherwise, swimming is an excellent exercise to control, in the control of chronic non-communicable diseases. So at the end of the day, almost 80% of your patients will be selecting walking as an exercise. And believe me, it's very useful. A lot of people are doubtful whether walking is helpful or not, but it is. Let's go to the next slide. Sorry. Of course, yoga and Tai Chi and weight training. Recently, weight training is gaining a lot of popularity. I will mention few points about it later on. Let's move to the next slide. Now, let's understand the most important thing or central concept. Sitting is new smoking. Rather, I would say sitting is more detrimental than smoking because it is said that physical inactivity is more detrimental than combined effect of smoking and hypertension. The principle is very simple. Your advice to your patient can be very simple. After every 40 to 50 minutes or 1 hour, patient should walk or take very light exercises, maybe even 3 minutes to 5 minutes. That is also helpful for the patient, metabolically as well as orthopedically. I'll just tell you a story of an executive and a housewife. There was an executive, this case is presented in a very prestigious publication. Executive who used to do 1 hour of vigorous exercise and sitting all the day behind the desk checking files. On the other hand, they compared it with a housewife, just 20 to 30 minutes of morning walk, but she was active all the day. Housewife was finding it better to have weight and metabolic control better than the executive. NEAT. This is another very important concept, non-exercising activity thermogenesis. It's it's constitutional and genetic trait. You must have seen some people, Marathi ज्याला कडकडे स्वभावाचे म्हणतात. They don't like to sit at one place. They will always keep on moving. Even while watching TV, they will be roaming around, doing some kind of work or something very light activities. Believe me, these are one of the best predictors of metabolic control. So NEAT, those who are doing NEAT, you will find them thin. Someone who keeps on moving, you will usually not find them obese or overweight. A lot of patients will ask you a lot of questions about their condition. I'll just give you 1 or 2 examples here. A diabetic patient comes to you who plans to practice 21 kilometers of running and ask you about a higher dietary protein intake. And second, another patient plans to start weight training and he has heard that he needs to take higher dietary proteins. What will be your advice? Of course, case to case it varies, whether the patient is more than 60 years old, whether he is already having renal complications, and so many things you have to consider as physician. Sustainability is the key word. Whenever patient starts any program or you advise the patient to start any program, think of sustainability, sustainability, sustainability in both obesity and diabetes. I have seen patients walking or jogging in feet of enthusiasm for 2.5 hours. They get results. They reduce weight. They get good sugar control. They get results, but only to abandon it later because they cannot sustain. So sustainability is the key word. 2 major problems in diabetes, exercise and diet. Number 1, hypoglycemia in early stages. because patient might be already on medications, including insulin. You have put your patient on diet, you have put your patient on exercise. Always be worried about nocturnal hypoglycemia. We can go little conservatively, but never aggressively in such cases, because deaths have been reported with these kind of aggressive approaches. And second problem is non-compliance in later phases. Patients in enthusiasm for 3, 4, 5 months, they will follow dietary advice. But if the diet is not that flexible or it's very rigid, so, it's a taboo kind of word, diabetic diet. If the patient keeps on following that boring diet, compliance will be a major problem. The patient will abandon the efforts and again, back to square one. Especially this happens with nutrition. There is a concept of HIIT, high intensity interval training. As the name suggests, you must have guessed, high intensity interval training. I will give you just one example. Here, the patient runs for say 30 seconds, takes rest for 30 seconds, again runs for 30 seconds, like that. It is said that is one of the best routines you can follow in diabetes exercise, but it is very high risk, and I never recommend in my diabetic or obese patients for safety reasons. Though it is good, it can be dangerous. Next, patients can ask you, doctor, can I jog for weight loss? There is a tremendous enthusiasm for running. Knee is under tremendous pressure when the patient jogs. Just 5 to 7 kg overweight patient is putting his knees under tremendous pressure. And at least in initial phases of treatment, I avoid this in my patients. Next, we're very curious finding. Patient asks you, doctor, should I do crunches for that tummy fat which is not going away? No, the answer is no. Because the concept of spot reduction never works. My tummy carries fat, I do crunches, tummy fat goes away. This never works. Crunches are good for abdominal muscle health, but certainly not for going away of central fat. Our age-old tradition, which is related to NEAT, we call it as Shatapavali, literally walking 100 steps slowly after major meals. This is a very helpful practice for diabetic and dyslipidemic patients. Yoga, of course, the experts have spoken about yoga, but in clinical practice, there will be at least few patients who will tell you that they do only yoga for sugar and weight control. You have to counsel them very well. Some patients might be doing well on that, but ultimately, a mix of cardiopulmonary exercises, light strength training exercises, and yoga is always best. Finally, my advice to all of us who want to practice in lifestyle medicine, learn and train weight training, because majority of the personal trainers come from bodybuilding background. Your help and a lot of modifications in protocol are required when it comes to weight training for patients, especially diabetics. Recent developments, as I've already mentioned, Irisine, OC, and ADP, they are being mentioned in research publications. Let's see how they fare in future clinical practices. Future focus, many areas to focus, but in my experience, the foremost area to focus on is developing strategies for non-motivated population. They form the largest chunk. Whatever marathon enthusiasts, gym enthusiasts we see, they form hardly 5 to 7% of the population. Remaining all are sedentary. Especially behavioral strategies and cognitive strategies must be developed to focus on this population. Finally, most importantly, let your patient enjoy life also. Otherwise, he won't be able to sustain if the advice is not leading to some happy, relaxations. To conclude, small steps make a big difference. Moderation in everything. Actually, these are Indian philosophies. Sarvacha Madhya Kadne, moderation in everything. These are the two key take-home messages I would like to give for those who want to work in lifestyle medicine. Thank you all by my heart, Dr. Vaishali, her team, all other organizers and audience. Thank you very much.
Thank you, Dr. Vikram. And that was a very practical sort of a topic, very well covered. And I think that key that you gave, the take-home message of the day, was moderation in all the activities that diabetics need to do. So what would be the, this is only one question which commonly is asked to us. That's why I wanted to know. That a diabetic patient comes on an average who would be not very active in his lifestyle, and he wants to know what exercise should I follow to begin with as a new diabetic. So what is the prescription that you would give a diabetic patient?
Sorry. Have you completed your question?
Yeah. At the outset, when the patient is diagnosed with diabetes, what would be the basic prescription for exercise?
Yes. See, the beginning exercise is always light cardiopulmonary exercise. Never go, it's not a good idea to go for very fancy, kind of exercises like beginning weight training, doing deadlifts and all. Just ask your patient to start walking. You will be surprised to know I tell my patients to just walk through and fro in his hall while watching TV, which is one of the best exercises he can begin with. And then you can put him on proper exercise routine, like walking for 40 to 45 minutes a day. Especially when you give at least some dietary advice, it works wonders on patients. And then later on, you can progress.
So we are not wrong in telling to start with walking. I thought each one needs. Okay.
No, absolutely not.
Ketan has congratulated you on the chat box. He's saying that an excellent talk by Dr. Vikram, very practical and relevant.
Thank you.
Diabetic.
Thank you very much.
Yeah. So thank you all for, I think this was an excellent closure for today. A very tiring day, but very enlightening day, I would say. Learned a lot from all you experts. And I'm sure not only me, a lot of people have learned a lot from this. And I hope to see you all again tomorrow. We begin our day tomorrow at 9 o'clock. I think the Envisage team also has been working very hard today, so we can disperse for today and join back if there are no questions. Are there any questions, Darshan or Amol? Are there any questions in the chat box for the audience? From the audience?
No questions.
Okay, so thank you all, and thank you, Dr. Vikram, for being there.
Thank you very much.
Thank you, Professor Reinhardt, sir, and hope to see you again tomorrow. And please do view our conference for tomorrow and give us a critical feedback so that we can improvise the next time.
Actually, it's already excellent, I would like to say. Thank you.
Thanks a lot. That's a very nice compliment. I would take it as, yeah. Thank you. And it's all to the team. I'm thankful to the whole team of speakers, moderators, and panelists who were there today in the whole symposium and made it so interesting. I have missed most of the talks on the other hall, so I would definitely take some time to cherish those, seeing them slowly and steadily. So thank you so much and have a good night. See you tomorrow morning. Bye.